Mumbai. I welcome each one of you here who are present physically as well as the audience who has joined us online today for this concluding yet the most awaited CME of the year 2025, the specialty CME Adolescent on Adolescent Endocrinology. Friends, you know, adolescence is a period of physiological turbulence, and to differentiate this physiological turbulence from pathological has been an enigma for pediatricians like us. Hence the name endocrine enigma, the theme, the endocrine enigma of teen years. Whether it is dealing with the complexities of puberty gone wrong, or managing the thyroid issues of adolescence, or addressing the ever-increasing burden of pediatric obesity in our country, the endocrine system holds the key for the transition from childhood to adulthood. Today we have stellar speakers lined up to unravel the mysteries of adolescent endocrinology. Today's CME is conceptualized and meticulously curated by Dr. Abhishek Kulkarni. He has not yet come, but he is on his way. Discreetly supported and coordinated by Dr. Amruta Shirodkar on behalf of IAP Mumbai, our past treasurer and the present executive board member. They have ensured us to give the most relevant, up-to-date and the practical scientific content. IAP Mumbai acknowledges Alchem Laboratories as the academic partner of today's CME. So friends, I encourage all of you to participate actively in this CME and take the most from this learning opportunity. So without further delay, I call upon Dr. Amruta Shirodkar to take on the dais.
Thank you, Dr. Kasla. A very good morning to all the delegates, and thank you for sparing your valuable Sunday morning for this unique CME. I think it's the first time IAP Mumbai is doing an adolescent endocrine CME. And when we say the term adolescence, I think the first thing that strikes to us is puberty. So what a better way to start our talk than a pubertal topic. And so we have a very interesting topic when puberty goes off track. And to give us insights on that, we have a very esteemed speaker with us, Dr. Akansha Parikh. Madam is a consultant pediatric endocrinologist at Kokilaben Dhirubhai Ambani Hospital. She is a co-author and author of multiple book chapters. She has been a national and international speaker, and we are really privileged to have us today. So over to you, madam. She will enlighten us on, I think, early, late, and everything in between about puberty.
Thank you everyone. A very good morning, and before I start, thank you to the organizing team of ISPE, of IAP Mumbai to invite me here today. So as we've seen, the topic of puberty is vast, and it's really quite impossible to compress in a period of 20-25 minutes. Yet I've attempted to sort of at least highlight a few things regarding the spectrum of puberty which can go wrong. Yes, so let's just start with something that we all are quite familiar with, which is what is normal puberty. In the Indian population, we do consider 8 to 13 years in a girl, 9 to 14 years in a boy as normal ages for puberty. We also know that puberty most often respects a certain sequence where we, in a girl, we start with thelaki, which then goes on to puberty and then menarche, and the time interval between breast development and periods is usually 2 to 3 years. In a boy, it's not so obvious when a boy starts puberty because the first sign is the testicular enlargement, and then a boy goes on to have puberty. Now, we don't have many recent studies, but a couple of studies in the pre-COVID times told us that the average age at onset of puberty in an Indian boy and a girl is about 10.5 years. And if the girl is overweight or obese, this comes down by a further 6 months or so. But we know in office practice today that, more and more children are having early puberty. And one of the important reasons is an increasing trend of overweight and obesity, which we've seen post-COVID. Now with that, what we'll do is we'll just discuss a few real cases and try and see how we can approach them. So this is an 8-year-old girl who came to us with features of early onset of puberty, where pubic hair and breast swellings were noticed a few months before she came. There was no really significant systemic complaints or past history, except that she was a full-term SGA baby. On examination, you can see her anthropometry on the growth chart, where you can see, may I have a pointer, please? So you can see on the growth chart that her height is on the MPH centile. Can I use this? Yeah, okay. So you can see that her height is on the MPH centile, and weight-wise, she's also okay. She's not overweight. She's Tanner stage 2. She's Tanner stage 2 by puberty, so B2, P2, A2. And there are no other red flags which we saw on examination. So let me ask you all first, what do you think is a likely diagnosis? A, she has normal onset of puberty. B, she has premature thalaki. C, she has peripheral precocious puberty. D, she has central precocious puberty. How many of you think it's A, she has normal onset of puberty? B, premature thalaki. Okay, couple. C, peripheral precocious puberty.
I'll ask one question, whether the breast changes came first or the pubic hair?
Well, when we asked her, she said she noticed both together. And D, central precocious puberty. Most of you, I think, don't have an opinion. You can be wrong, that's fine, but yes. So we have only one height reading. We don't have a previous height to compare whether she's in a height spurt or not. So with the given information, most of you think it's normal. I would beg to differ, and I think I would... Okay, so I'm going to say that I felt it was D, central precocious puberty, and I'll just come to why. So unlikely to be normal because she's 8 years and we noticed the changes a few months before. So it's not that we are starting at 8, we've started actually before 8 years of age. Unlikely to be premature thalaki because we know this is an isolated event. This girl not only has breast development, but she has pubic hair as well.
Height and weight are all below. Her
Hi-
height is less and weight is also 20 kg.
Height is okay, ma'am.
Her height is 123 centimeters.
Yes, ma'am. So when you plot it on the growth chart,
Around 130 should be adult people. So if she's not grown on a height, she's not grown on a weight, so there are sudden changes which has occurred.
yes, I guess you would be right in some ways.
Normal process, it should have been continued for a long. See, accordingly, she should have gained height more.
So,
Weight also. Nutrition is poor.
yeah.
Her weight is only 19 kg, which is around like 20 kg for 4-year-old child. I mean, to
She's
a
8,
5,
ma'am.
6 years old child. And here she is low, underweight. She's height also less, and it is just not, should not be under the carpet, wipe away that this is normal. We should investigate that whether any stimulus is there or any abnormal.
So when we look at her height and weight as per her age and plot her on the growth chart, she does appear to come within the normal centiles, both for height, for weight and weight for height, which is the BMI. All three of them seem to be okay. So going back, a couple of you felt it's peripheral precocious puberty. I don't deny it. I'm saying it's still a possibility. However, we are not getting any red flags for the same. So on history, usually peripheral precocity would be discordant, which means these children would come with vaginal bleeding before they would come with breast development. You can have history of recurrent fractures. On examination, you would see cafe au lait spots for McCune Albright. You could see maybe limb deformities. You could see a goiter for hypothyroidism. So it is a possibility, however, lower down on the list. And eventually, we have central precocious puberty because she's coming early to us with pubertal features which are concordant. And in this age group, central precocious puberty would be probably the most common cause of early puberty. So when you are thinking of precocious puberty, you would send some biochemistry and radiological investigations. Here we can see that the baseline LH is high. The estradiol is also pubertal. The bone age is advanced, and the USG pelvis is showing pubertal features. Now, a quick sort of tip to look at the USG pelvis is the rule of 3. If you see that the uterine length is more than 3 centimeters, the endometrial thickness is 3 mm or more, or the ovarian volume is 3 ml and more, then this points towards precocious puberty, and it points towards pubertal changes internally. What would we have found if we had premature thalaki? We would have found a high estradiol, but the rest of the investigations would have been okay. In case of peripheral precocious puberty, they do have a bone age advancement. They can also have uterine changes which are pubertal, but the LH level would have been low. So now the question is about starting gonadotropin releasing hormone analog therapy. Should we start leuprolide therapy in this child or not? How many of you will say yes? Yes. How many of you say no? How many of you say we don't know? Okay, so when it comes to starting GnRH analog therapy, what are the things that we keep in mind when we decide this child needs it or not?
Bone age, no? Bone age should be
Yes.
not more than 8.5.
So, one is, of course, the bone age. The second is what is the present height of the child. The third is, even if there is not much height benefit, is this child going to be able to deal with regular menses at the age that she will get them at? And then eventually the most important thing is the parental wish. Sometimes we do feel that from a height perspective, it's a good idea to start GnRH analogs, but the parents are very against it, and in such cases we do respect the wishes of the parents, of course. Now in this child, you can see the growth chart here. You can see that X marks the bone age, and a very crude way of looking at the predicted adult height is if you just trace it upwards and see where it hits. Now in this case, you can see it's hitting quite far below the mid-parental height, and in this case, we did advise leuprolide therapy, so much so that we advised not only leuprolide therapy, but we also did advise growth hormone therapy along with it. Now, why did we do it? We did it, one, because we found that the gap between the predicted height and the mid-parental height was very, very large. Two, remember this baby was born small for gestational age. So she already has a valid FDA-approved condition for initiating growth hormone therapy. And you can see her growth chart on both of these therapies. The little arrow here marks where we started both. And you can see how she's growing with time. What I also want you all to see is the bone age. The X's, how they're going up. And so with passage of time, the predicted height improves. And so much so that we want to continue this till we can, as far as possible, allow her to reach within her mid-parental height range. So I think the learning point from this case is that, and okay, before I go to that, there is another slide here where this is a 8-year-old child who came to us. Now look at her. She seems quite tall. Her bone age is not as advanced, and she was B2, P1, A1 when she came to us. Now in this child, we didn't advise GnRH analog therapy, because you can see that if you trace that bone age upwards, she is hitting her mid-parental height. So not all children require leuprolide therapy, and in some, leuprolide is not enough and you may need to club growth hormone as well.
What if the parents feel that she should be taller than her mid-parental height?
No. So I think if you ask me, you have to, as a physician, we have to delineate between vanity and a medical indication. Just because parents may want something, at the end of the day, growth hormone is still medicine. So we can't just give because parents want.
Also, there are two parents. So there is, say, a 5'7" mother and a 5'4" father. That's and so that the child will follow any one. You don't have. In the sense, I know there is a mid-parental and all, but if you have a tall man and a very short woman.
Yes.
Married. Now, the child may be tall, little
Yes.
more than the short woman, and so you have to see that also. So this
Yes.
doesn't need any treatment. This looks,
Yes, absolutely okay.
and just because, like you said, I want a tall model, that doesn't work.
Absolutely. So let's, yes, ma'am.
What my observation has been is the children who have got low growth hormone, and I also get that the vitamin D3 levels done and parathormone hormone levels done. And invariably when vitamin D3 is low, like 6 or 7 or something, by correcting vitamin D3 to the level of 80, 90 and correcting parathormone hormone to the level of 60, 70, after that when I done the growth hormones get elevated and they come to normal. And the child, it is actually basically when the vitamin D and parathormone both are low, then the growth hormone also remains low. But first, before correcting on a growth hormone, first we must correct parathormone and vitamin D3 deficiency.
So, I mean, I think you're not wrong in saying that growth, of course, depends on nutrition, basic nutrition. And how I would explain to my parents is that if you want a tall building, तो building के लिए cement और ईंट तो लगती है, तो ईंट तो प्रोटीन है और सीमेंट तो वेजिटेबल्स है, तो ये दोनों खाना बहुत ही इम्पोर्टेंट है. सो येस, आई थिंक आई अग्री विथ यू.
You said growth hormone levels you check. So how did you check the growth hormone level? Not very easy to check.
Growth hormone levels, serum growth hormone levels.
That's not, that's a very dynamic.
May I request the audience, please, that we will have the question answers at the end of the sessions because I think we are obstructing the flow of the topic. Yeah?
No, not-
So we'll invite questions after the session is over.
Thank you. Okay, so we'll just quickly move on to the second case. Now, this is a 10.5-year-old boy who had actually come to us for concerns of weight gain. And, he was training to be a professional cricketer. So, his physical activity and screen and sleep all seemed to be okay. The food could have been improved definitely, but the rest of it seemed to be okay. And he didn't have any significant past history. On examination, he did have obesity, but to our dismay, we found on a routine examination, he had bilateral undescended testes and they were present in the superficial inguinal ring. They were small in size and he was prepubertal otherwise. So, if we looked at his anthropometry, here again, I want to just quickly point out that his height appears to be okay. You can see that it's along his mid-parental height centile. His weight also, if you notice, age-wise, his weight is within the centiles, but take a look at his BMI. When you look at his weight for his height, it's very, very high, and he does have obesity. So, in this child, now he is a 10.5-year-old boy with bilateral undescended testes. He should have been operated for an orchidopexy by the age of 1 year. So we are very, very late. And we know that when we get a delayed orchidopexy, there is a chance of reduced fertility later on in life. So we did do a basic pubertal hormone assessment, which you can see all of it is prepubertal. And he underwent an orchidopexy at that age. Now, we had counseled the parents and we said we'll have to keep him under observation. So, he came back to us at 11.5 years or so. And we found that he's just starting to become pubertal. So, we said, okay, all right, let's just again see you. And we saw him again after a year. And at that time, the testicular volume had increased a little bit. So, what was 5 became 6, what was 4 became 5. And then again, the next time, by the time we saw him, he was 13.5 years. And at that time, his testicular volume was actually 5 and 4. And then we were wondering what's going on. So we sent another pubertal profile and you can see that the LH and testosterone, all of it has come low again. Now, my question to you all is, what do you think we are dealing with? Are we dealing with constitutional delay of growth and puberty? Are we dealing with a sequelae of late orchidopexy? Are we dealing with a pubertal arrest due to hypogonadism? Or could he possibly be a Klinefelter syndrome? Everybody says C. Does anybody want to differ otherwise? So, yeah, I think all of you all are absolutely right. We are looking at C, pubertal arrest due to hypogonadism. Why is this not CDGP? Because we know in CDGP they start puberty late, but then there is no stopping and staggering. They continue normally. Why is this not a sequelae of late orchidopexy? As we said, usually they come with a problem in fertility. Onset of puberty, the testosterone bit of it, the Leydig cells are usually okay unless you have intra-abdominal gonads, in which case the testes can be completely damaged, but in that case the LH-FSH would have been high. Why is this not a Klinefelter syndrome? Klinefelter syndromes can come with bilateral undescended testes, they can come with maybe a microphallus as well, but they can also come with a pubertal arrest, but they do have some other soft signs, which means they could have intellectual disability, they could have autism, they could have gynecomastia when they come, and we know that Klinefelter syndrome is a primary testicular failure, and in such a case the FSH should have been high. Here we are finding that all of it is low, so the problem is in the pituitary and the hypothalamus, and therefore we are probably looking at hypogonadism. So when we did a leuprolide stimulation test in him, he failed it. We looked at an MRI pituitary to see why is this child not progressing, and it didn't show any mass lesions except for a small anterior pituitary. We couldn't get anything else. So this is what we would call as a partial hypogonadotropic hypogonadism, where the gonadotropins are enough for him to start puberty on his own, enough not to cause a microphallus, but not that much so that the testes are descended completely, and not that much so that the puberty goes on normally. Now in such children also we do need to give hormone replacement therapy. Earlier we used to give testosterone. Now we have the option of giving something which can simulate gonadotropins, which is HCG and recombinant FSH, or instead of recombinant FSH, we can use HMG. And this is given in incremental doses to simulate normal puberty. What is the advantage of giving this over testosterone? Fertility is again, the chance of fertility later is improved. It's been seen that those children with hypogonadism who are given testosterone for pubertal induction have reduced chances of fertility during adulthood. So you can see, how the child did well on treatment. That little red dot shows his last follow-up, which is about 6 months back. He was 14.5 years old. His testicular volume had gone up to 10 ml bilaterally. His height, you can see actually on the growth chart also, he's having a pubertal height spurt as well. So the plan is to continue this for over 2 to 2.5 years and monitor him for his puberty and growth. So here I think the learning points for this case would be, no matter what a child comes to you at what age, a genital examination is a must, because you never know when you can get a surprise like we did in this case. And 2, if you have a child who has undescended testes, a microphallus, your antennae should be up to see not only when is this child entering puberty, but how is he progressing once we've started as well. Okay, so this is the last case for today. She's a 16.5-year-old girl. She's an operated case of tetralogy of Fallot, and she was referred to us for primary amenorrhea. And there was no significant family history. Anthropometry-wise, she was doing okay. Her height was at her mid-parental height, and there was really no significant systemic or general finding, and she was B1, P4, A3. Now with this, let me again ask you all, what do you think we are dealing with? Is she a constitutional delay of growth and puberty? Is she Turner syndrome? Is she Mullerian agenesis? Or is she actually a 46XY with complete androgen insensitivity? How many of you all say A, CDGP? B, Turner syndrome? There's no Turner stigmata. C, Mullerian agenesis. D, 46XY with CAIS. Okay, so the answer actually, I would put my best bet on B, Turner syndrome. Now, why? Could she be a CDGP? Well, unlikely. She's 16.5 years of age. Usually, we wait till about 16 years to say CDGP. Beyond 16 years, if a girl doesn't have secondary sexual characteristics, we would start looking for an organic cause. Now, I want to just highlight one thing here, is that not only she's been referred for primary amenorrhea, but this girl had no breast development either. So, could it be Mullerian agenesis? both Mullerian agenesis as well as a 46XY with CAIS would have very good breast development. In case of Mullerian agenesis, the ovaries are okay. They can produce that estrogen, so breast development is okay. She's not having periods because she doesn't have a uterus. What about 46XY CAIS? They don't have ovaries, but they have testes. And they produce testosterone, which all of it gets converted to estrogen. There is an androgen receptor resistance, and therefore, all that estrogen does act on the breast, causing breast development. They don't have periods because, again, they don't have a uterus. So most likely here, we are dealing with some form of hypogonadism. The ovaries are not functioning or the pituitary is not functioning. Because of that, she's not developed breasts and she's not got her periods. So which of these two is likely? For that, we did her biochemistry, and you can see that the LH-FSH are all high, the estradiol is low, and the rest of her pituitary hormones are okay. So again, this is what we would call as primary ovarian failure, and the most common cause we know is Turner syndrome. We did a USG pelvis and we saw streak ovaries. We sent a hypoplastic uterus, we sent a karyotype, and it came back as 46XX. So no Turner syndrome. Then what are we looking at? So other than Turner syndrome, you can also have other gene mutations which can cause ovarian dysgenesis. And we did send a genetic analysis for that, but it didn't pick up anything. So now what? We need to induce puberty in her. Till date, we had oral estrogen which was available, of which estradiol valerate is the most safe alternative of all of these because it's a naturally occurring form of estrogen. But today what we also have are estradiol, transdermal estradiol patches. Now these are patches, as you can see, are applied on the body. They are typically applied below the waist. They come in various sizes and shapes. The one which we applied on her was a square patch of 50 micrograms. And you can see as the dotted lines are shown, you need to instruct the patients to cut them in equal sizes as is seen. And then twice a week, this patch is applied and in slowly incremental doses such that it simulates normal puberty. And eventually, we also add progesterone to them. Now, many a times, when we are starting pubertal induction, or especially in girls who come with secondary amenorrhea, which means that breast development is okay, periods were okay for a bit, and then they stopped, and then we found that this girl has primary ovarian failure, and now she's not going to get her periods. And when we advise HRT in them, they're very reluctant because they're quite okay to not have periods because they've had their breast development. But especially in these girls, we need to sort of advise that when we are giving hormonal replacement therapy, it's not only for secondary sexual characteristics and regular periods, but a very, very important part of puberty is bone health. And we know that 50% of the bone is accrued at the time of puberty. So if we don't give them these hormones, they are, heading towards severe osteoporosis and early fractures in them. And we also know that, estrogen in women is important because it's protective for a whole lot of metabolic conditions as well, whether it's obesity or cardiovascular events, and therefore it is important. So with that, I would just like to end. It's a little busy slide, but that's how puberty is, that you can have abnormally early onset of puberty, which is precocious puberty. You can have normal puberty, and you can have something in between like a premature thalaki or a premature adrenarche, which are considered as normal variants of puberty. On the other end of the spectrum, you can have abnormally late puberty or delayed puberty. You can have normal puberty, and in between what is called as constitutional delay of growth and puberty. If you have a child who has the onset of puberty within the normal range, they can still have either very rapidly progressive puberty or they can have a pubertal arrest, as we saw. So it's not only important to see when they start, but how they progress. Thank you.
Thank you, Dr. Akanksha, for this
we just
truly
hand over.
insightful.
1 minute, we just hand over to our chairperson, Dr. Rajesh Kasla, and my sincere apologies for not acknowledging sir earlier.
Absolutely.
Sir is our president-elect for IAP, and over to you, sir.
Yeah. Thank you, Dr. Akanksha, for this truly insightful session on pubertal disorders and these excellent takeaways that you've given for the clinical approach combined with the radiological as well as the hormonal analysis. So it's time for some quick couple of questions, short.
Audience has any questions?
Any questions from the audience?
think they were asked during the course itself. So,
Okay,
all-
thank you.
thank you.
Thank you.
Okay. I would request our speaker, Dr. Akansha, and Chairperson, Dr. Rajesh Kasla, to please come for a photograph. And I'll request our President, IAP Mumbai, Dr. Nehal Shah, to please felicitate both the faculty. Thank you, Dr. Akansha, and thank you, Dr. Rajesh Kasla, sir. With that fantastic start to our CME, we now move on to our second topic. Adolescent, we know, is a very dramatic age, and if we add thyroid issues to that, I think it will be even more dramatic. So to discuss more on teenage thyroid, we have with us a very eminent speaker and a pediatric endocrinologist, Dr. Ruchi Parikh. She is a consultant pediatric and adolescent endocrinologist at Leelavati, SRCC, Reliance, Surya, and multiple other places. And she has many accolades and honors to her credit. And I welcome her now on the dais to take the further session. Welcome, Dr. Ruchi. Yeah, and I would also like to invite chairperson for this session, Dr. Rajul Patel. Madam is a senior pediatrician and an adolescent health expert. She practices at Santa Cruz. So welcome, madam.
Okay. Good morning, everyone. At the outset, I would like to thank IAP and especially Amrita and Abhishek for putting this across. So after maybe understanding or not understanding the various problems of puberty, let's come to an easier topic, that's teen thyroid. Do you think it is easy? Okay, good. At least y'all are on the same page as I am. So yes, it is not easy, and hence the title is Let's Decode It. Okay, so just a brief about adolescent medicine. I know a lot of you might be just interested in adolescent medicine, which obviously caters to children between 10 to 20 years. And this makes almost 1/5 of the global population. That's a huge population, right? And hence we definitely need to look at them differently than from the children, and hence the problems that they have, including the endocrine problems, may not be the same as the childhood problem. Okay, and even within this today we are looking at the teenagers, and as we all know, right, as a parent and as a pediatrician, they all grow at different rates, right? They are not the same as children, where in children you may have definite numbers, whether it is dentition or it is weight or it is height, but for the teenage they grow differently and they develop differently. Hence, when they're comparing with their peers, they always feel they are different and there's a lot of mental health issues with them. So let's understand what we can do, and hence there is a guideline that all these teens should have an annual visit, and these are the things that we should be looking into. Okay, and besides that, where we come in this place is what we are going to deal with in next few slides. So thyroid disorders, as we understand, among the endocrine disorders, thyroid disorders is the most common problem in children and adolescents, especially also in teenagers. Okay, as we all understand, right, the teenagers' behavior is volatile. We can never understand them. So it's similar with the thyroid disorders. The presentation can be as variable as no presentation. So it can be an insidious onset to an overt clinical symptoms, okay, or just an isolated thyromegaly. Among this also, when there is a biochemical abnormality, it may not lead to any clinical outcome. So first is to understand if there's a problem, then to decipher what is the biochemistry behind it, and to also understand whether this is normal or abnormal. Okay, so this is what is the problem that we deal with thyroid disorders in teenagers. Again, hypothyroidism is the most common problem that we see. Okay, hypothyroidism is less common, but it's not rare as in children. Okay, thyroid cancers, we know thyroid cancers is more commoner in adult, but in pediatric age group also we see nodules, masses, and they are actually more aggressive than in the adulthood. Okay. So besides this, let's understand the biochemistry. Like, when we are sending out the blood test, it has to be sent to a lab which it detects an ultra-sensitive TSH. So the assays are very important. We need to understand the reference range. Nowadays we get reference range up to 1.5 of TSH and 2.5 of TSH. No, we should not be following them. As you look at this slide, most of the reference range is common over the entire adolescent period, whether it is for T3, T4 and TSH, and the adults and the children have a different reference ranges. So it is very important to know what the reference range is, what the assay is. An ideal assay is very important. Okay, very busy slide, but just look at the red marked thing. These are the common thyroid disorders that we see in children. Okay, autoimmune thyroid disease, as all of us understand, is the most common presentation, or is the most common etiology. There's Hashimoto thyroiditis. Okay, then there is stimulating antibodies which can cause Graves. There's blocking antibody which can cause hypothyroidism, and there can be a combination of both, which is called Hashitoxicosis. Again, very confusing, right? In congenital hypothyroidism or congenital hyperthyroidism, we could see either, but not both. Okay, iodine deficiency is less, so goitrous, presentation with iodine deficiency is now rare because of the iodized salt. Okay, when you look at goiter is a more common presentation either in the neonatal age group or in the teenage age group. We need to know what is a normal goiter, what is an abnormal goiter. Okay, and we also have to understand the there are non-thyroidal illness where you can see a goiter enlargement, which it can settle down post the settlement of the illness. Okay. Do not miss out nodes, do not miss out masses, do not miss out the thyroid neoplasia just because they are teenagers. Cancers are not there, no. It is there, but it's rare. Okay. The rest of the columns, even if they are there, it's quite rare, and most of them don't need treatment. Okay. So the most important area is the red coded. Okay. So as I had shown you those 9 pointers that you should need in an annual visit of an adolescent, routine examination of the neck is equally important. Okay, not only to look at the lymph nodes, but also to look at a goiter. And for goiter, it's best when the clinician is standing behind the child and not palpating from the front. Okay, so you need to look at the goiter. So goiter is the thyroid swelling. Okay, so for that, the child has to swallow. Okay, and see the margins as the child swallows and the child is looking up at the ceiling. Also, palpate and see if there is any, what is the kind of a surface, what is the margin, are there any nodes, are there any masses, how do they feel, whether they feel soft, firm, hard. Okay, so you also need to know the consistency inside. And yes, of course, after that you need to send out the thyroid profile if you find there's any abnormality. Best is to send a free unbound molecule of T4 and T3 instead of the total T4 and T3 along with the ultra-sensitive TSH, because there could be an influence when you send a total T4 or a total T3, which we look into the subsequent slides. Okay, very important, what does not need treatment. Okay, so we also have gray areas in this as well, like, as it was spoken about puberty, what's late, and what's early and what's in between. Okay, so yes, there are certain times when you don't need treatment. So there are conditions where you may see certain abnormalities in thyroid hormone levels, but the individual is still euthyroid, and they may erroneously get diagnosed and treated. So let's understand what is normal. Okay. So the reason I told you that it's better to send a free or an unbound molecule as against a total molecule, because you may see a normal TSH but a high T4, and when you do a free T4, it would be normal. So this is familiar dysalbuminemic hyperthyroxanemia. Similarly, you may see low T4 but a normal free T4 with a TSH. This is a thyroxine binding globulin deficiency. Parents just need reassurance. There is no treatment for this condition. Okay. Now, during illness, most of us do send the thyroid profile, okay, and we find that all three numbers are either low, okay, or we find the TSH to be low, okay. So you can have a different variety of, biochemistry when the child is sick, because the entire axis, which is your hypothalamic pituitary thyroid axis, may be suppressed and it may look like a central hypothyroid. But when you see these children after recovery, the profile would be absolutely normal. So again, they don't need any treatment. Okay, we all understand that TSH helps us to guide if whether there is hypothyroidism, if it is high, and it is hyperthyroidism if it is suppressed. Also, we need to know that there is no interference with the assay, so that is also very important, that where you send it out. Again, as I mentioned, application of adult reference range. Okay, so most of the times we get references of children whose TSH is even 3, 4, 4.5, which is actually normal because of the reference range that the lab is giving out to. Okay, but important is there is no treatment needed if there are no, any red flags, or there is no family history, or we don't find anything as a risk for the child to go into hypo or hyperthyroidism. We don't need to treat the children if the TSH is less than 10. Okay, again, this comes with a caveat. We need to look at the history, the clinical, the clinical makeup of the child, and also a family history. Commonly, we believe that obesity is due to hypothyroidism. How many of us do believe that? So, I think we all know, and it was highlighted even in the introduction that by Akanksha, that we see a lot of weight gain, we see a lot of overweight, we see a lot of obesity. Most of it, 90% and more, is nutritional obesity. It's a lifestyle issue. Okay, so it's rare to find an obese child having hypothyroid. And when will that be? When a child is obese and short. And usually what do we see? Obese and tall. Exactly. So that's one thing. Obviously, we've always understood, short and fat and tall and, like thin and, undernourished. Also understand that you may still find the TSH to be between 5 to 10 in children who are obese. This is a physiological response, okay, because the body is trying to increase the metabolism and limit the adipose tissue deposition. So once they do have an intervention in the lifestyle and you recheck the thyroid profile, the TSH would have become normal. Okay, so again, just looking at that minor change in the TSH when the child is not clinically showing any signs of hypothyroidism does not warrant any treatment. Okay, also we see a lot of parents having hypothyroidism. They do know that we are having antibodies, and as a screen they go out and check their children also, especially the adolescents. Okay, it's not about the children, but especially the adolescent, and they do understand it's more common in females than in males. So you usually see these girls having a thyroid profile done. They would come back with an antibody as well. Okay, but if your thyroid profile is within the range of the reference that I have shown, and you need not need treatment for them. So 20% do develop overt hypothyroidism and they will need treatment. Some will just need follow-up till they show that there is an abnormality in their thyroid function test. Okay, the others are where we see thyroid hormone resistance, where TSH would be near normal, there would not be any signs of hyperthyroidism, needs no treatment. Less common than adults, but we do see infectious thyroiditis, okay, where there is a painful, tender, goiter, okay, and the child may show some signs, some, features of hypothyroidism in the lab, okay, but this is transient, okay, and the children just need treatment with antibiotics, and once this settles, the thyroid profile would become normal. So again, they don't need treatment in this acute scenario, or even in the subacute scenario, which is because of the viral infection. Okay, so now coming to where children do need treatment, okay. We know that TSH helps to distinguish between hypothyroidism and hyperthyroidism along with the T4. Okay, so it's not like an adult, we cannot just rely on TSH. We need to do the T4 as well. Okay, when you only do TSH and you see that the TSH is normal, we could still have a low T4 because the hypothalamic pituitary axis would be affected, which is called central hypothyroidism. So even while looking at TSH to be normal but not looking at T4, we could still miss this small population of children, okay? And when both T4 and TSH are elevated, in hypothyroidism, there could be rare, adenomas or hormone resistance which needs to be considered. Again, we need to see where they lie depending upon their clinical scenario. So hypothyroidism, most common cause of thyroid disorders in adolescent, commonly seen as an autoimmune condition where there is an immunologic response and immunologic destruction, and hence you see more commonly with the antibody being positive, but there are also polyglandular disorders. So along with thyroid disorders, you may have an associated other autoimmune conditions which may have presented earlier. For example, if you have type 1 diabetes, 30% of these children could also have, hypothyroidism later. So it's important to have an annual screen for them, okay? We all have understood congenital hypothyroidism through newborn screening and we leave it out there. No, we can still have a late onset of congenital hypothyroidism. Some features of dysharmonogenesis, ectopic, can come with late presentation, okay? Drugs, a lot of anticonvulsants which are used on a long-term basis, okay? Goitrogens, very rare, okay? Iodine deficiency, again rare. Now because of the, the salt being iodized, we don't see this very commonly, okay? Children who've got some tumors, okay, or have got some malformations in the brain, they are the ones who can come with a central hypothyroidism, so they need to be even watched for acquired. We do see, cancers or, SOLs, okay, who receive treatment, okay, or there are conditions where the thyroid gets ablated because of the radiation somewhere else, again, they can have a hypothyroid feature, okay. And then hypothyroidism in other chronic systemic disorders like renal failure and iron overload in thalassemia, chromosomal disorders. So all downs, even in newborn screening, we say that even if the first screen is normal, you still need to screen them at 6 months. So Turner's, Down syndrome, all of them would need annual screening. Downs can also come with hyperthyroidism, though it's rarer than hypothyroidism. Okay. Commonly we understand how infants present with hypothyroidism, but when it comes to teenagers, you would see goiter. Okay, and you need to understand that the soft consistency of goiter could still be normal, okay, but the consistency can help us to understand the etiology behind it, okay. There could be growth retardation, so you may not see short and fat, okay, which you would probably see in childhood, okay. In adolescent, you may not see short and fat, but you'll definitely see a growth falter or inadequate height gain. Okay, less common is the periorbital puffiness that you see. Okay, bone age could still be affected because that's what the thyroid hormone works on the growth plate. Pubertal disorders, so you may get delayed puberty, you may get secondary amenorrhea, you may get precocious puberty, where there would be a child who's presented with early onset of pubertal signs which is out of sync and the child is short. Okay, so you could have a pubertal disorders as well. And less common is the other features that we see in childhood, that is your constipation and your mental retardation. There could be some affections to scholastic performance, but you may not see it always. Maybe it comes as a retrospective after you introduce the thyroid hormone to them. Okay, and you may see calf muscle, so there's a pseudohypertrophy of the calf muscles as well. This is called as Cocker-Debré-Lessemeline syndrome. Again, the evaluation remains the same. You need the thyroid profile, you need the antibodies, you need the ultrasound scan to know what is happening to the structure, whereas there's a thyroiditis kind of a feature. And if your gland is normal, if your antibodies are normal, you want to look at a late onset of congenital hypothyroidism. That's when your technetium scan will be useful. Screen for other associated autoimmune conditions if it is relevant. Okay. In congenital hypothyroidism, we hit hard. We start with the highest dose, okay? But in this condition, especially when children have presented with the long-term symptoms, they also need the replacement slowly to avoid pseudotumor cerebri. They may have even worsening of scholastic performance if you are hit them hard, okay? So the full treatment would come especially over weeks and days and not in the beginning. So this is very important, okay? After you've diagnosed, even in congenital hypothyroidism, we say diagnosing is first thing, not the last thing. What is important is the compliance with the medications, compliance to test them and titrate the medications and also look at their growth. So equally important over here, look at growth. Here the other thing is to look at the scholastic performance and look at how they are taking the medications. It's very important how they take the medication, where they store the medication. If there was goiter, see what is happening to the size, whether it's regressing or not, and whether the children are starting their puberty on time and whether it's progressing and there is no arrest. Okay. Always make sure that the TSH is within normal and T4 is in the above reference range. Okay. Not the above reference range, but towards the higher of the reference range. Okay, so just one case, typical presentation, 13-year-old boy, not gaining height but gaining weight, and there's a problem with school performance. A very typical, scenario which all of you all will pick up as hypothyroidism. Okay, this child has a weight which is much better. Okay, if you can see the weight. Okay, on this centile chart, it is on the growth chart, it's on a 25th centile, but where is the height? Nowhere. So looking at this is short and obese. It's not like the child is going above the central line to tell you that this is obesity. Okay, so in comparison to the height, this is where the weight is. So the child was actually looking like an 11-year-old for weight and a 7-year-old for a height, and he is 13 years old. His bone age is extremely delayed. Okay, extremely delayed. So this is something that has got missed over a long period of time, or this is a late presentation of something which should have been diagnosed way earlier. Okay, so child did have a hypothyroid look. There was no goiter. Okay, and he was just asked to protrude a tongue, and there was a midline neck swelling. Investigation showed frank hypothyroidism. Okay, primary hypothyroidism with a low free T3, free T4 and a very high TSH. But the antibody was negative, the ultrasound was normal. Then what are we dealing with? Is this athyrosis? But athyrosis should have presented way earlier. Okay, so here is when we did the technetium scan and found that there was an uptake in the sublingual region, and this was an ectopic thyroid gland. So ectopic, congenital, but a late onset. Hence, very typical onset. Let's look at the next case. This is a 14-year-old female, just not gaining height. Okay, there is constipation, poor scholastic performance, but today we know with the gadgets now how to even judge the scholastic performance is very difficult. Okay, family history normal. Looking at the growth, the bone age is delayed, okay, and it is equivalent to the height age, but the weight age is even further delayed. So this is not your typical short and obese. Okay, there is a hypothyroid look. Okay, the child is having shallow complexion, very dull looking, okay, and there was also a goiter, which unfortunately in this image you are not able to see. There was a Goer sign positive. The child was supporting herself while she had to get up, and there was delayed relaxation of DTR. So the complaint here was just not gaining height, but obviously there were no secondary sexual characters as well, and the child had an SMR or a tennis staging of prepuberty. Again, frank hypothyroid, but antibody positive. So this was an autoimmune goitrous hypothyroidism, but a feature which was more like a failure to thrive. Okay, so again, teenagers, difficult to deal, difficult presentation. Be very careful in certain condition which needs treatment. Okay, Hashimotoxicosis. Okay, this is a destruction of the thyroid gland which results from a preformed thyroid hormone. So you'll have a initial hyperthyroid kind of features, but ultimately because of the antibody which are blocking, it is going to go towards the hypothyroidism. So if you keep treating this child with an antithyroid, there's going to be a double-edged destruction or double-edged hypothyroid kind of a feature. So be very careful in such condition, whether it's preformed, the thyroid hormones will be released for a very short, it's a transient thing, and it will ultimately take its part towards hypothyroidism. Hypothalamic pituitary dysfunction. We all have understood now that something which is there in the brain can present with a central hypothyroidism, and they need to be screened. But be very careful. Before intervening with thyroxine, look at cortisol excess. Otherwise, this child will go into adrenal crisis. So whenever you're looking at a central hypothyroid kind of a feature, you need to make sure that what is happening to your adrenal axis, so you don't push this child into adrenal crisis. Cancer survivors, whether the cancer is of the thyroid or cancer is somewhere else and they have required chemotherapy, radiation, there could be just a scatter effect of radiation, whether the radiation is to the head or the radiation is to the spine or the radiation is to the chest, there could still be the effect of the thyroid gland. So they will definitely need an annual screening, not only with the biochemistry, but with also ultrasound. If you wait to palpate the masses in the gland, you will be very late. Okay, so the screening has to be done annually. Coming to the next spectrum, that is hypothyroidism. Less common than hypothyroidism, but much commoner than the childhood onset. And Graves' disease is the most common cause. The other could be, autonomously functioning thyroid nodules, infections of the thyroid, which is transient, which may not need treatment. A lot of parents have hypothyroidism, and the bottles of thyroxine are kept, in the reach of the children. Okay, so we have seen them ingesting these medicines and landing up with hypothyroid features, but again, with the half-life and the excretion of these hormones, this is again going to be transient, okay, may not need treatment for that, will need observation, may need beta blockers depending upon what's happening to the cardiovascular system. Okay, McCune-Albright syndrome is again a peripheral precocious puberty which comes with a stimulating or a hyperthyroid kind of a feature, and there is TSH producing pituitary adenomas. These are the other causes of hyperthyroidism. Graves' disease is a combination of diffuse goiter and hyperthyroidism. So hyperthyroidism is where the children gain weight, they have disturbed sleep, they have increased appetite, they could have increased urine output, okay, and they may still not do well in the school, okay. Ophthalmopathy, that is your prominent eyes, is only the feature that you see as against what you see in the adults with Graves' disease. And here the stimulating immunoglobulin or TSH receptor antibody is going to be positive. Okay, the current treatment approach for more than 10 years is medical treatment first, but even radioablation is becoming the line of treatment for the first phase because of the confidence that they have gained that in the 20 years follow-up, it has not caused any malignancies in them, but we are still heading over there. Surgical approach would be total thyroidectomy. Okay, so that would not be the first approach that we would want to do. It's only in conditions where medical treatment has not caused remission. Radioablation is not possible because the ophthalmopathy is so severe that the radioablation may cause even more severity. Okay, so it's in rare conditions that you would go for surgical approach in a case of Graves' disease. Goiter. So goiter is the enlargement of the lobes greater than the terminal phalanx of the patient's thumb. Okay, not our thumb. Okay, and grading is what 0, 1, 2. 1 is where you have to palpate, and 2 is when you can see it from a distance. Okay, so as the grading goes up, obviously it's more larger and there could be more symptoms of compression. Okay, again, as I had mentioned, that the characteristics of the goiter can help us to understand the suspected disease. So diffuse goiter all over could be some autoimmune conditions, and single node could be still a benign tumor. Multinodular could be iodine deficiency. Okay, so just because you're getting nodes you should not be counseling every family for thyroid cancer. Okay, and approach to our acquired goiter. Whenever you find goiter, obviously you're going to do the biochemical test. It's usually euthyroid when the initial stage of your Hashimoto thyroiditis. Colloid goiter, when you see colloid goiter in the ultrasound, it may not require any treatment. Pubertal goiter, increased demand, so you would probably see some kind of a goiter, but again, all the functions would be normal. And once the child is in the final stages of the puberty, the goiter size would come down. Again, would need no treatment. Hypothyroid, again, in the overt condition of Hashimoto's or in iodine deficiency or iodine ingestion, and any infiltrative disease. Hyperthyroid, most commonly is Graves, less commonly are your nodules. Okay, so when you do find nodules, okay, we have to do the same thing. Get the biochemistry, get the ultrasound. Now, in the ultrasound over here, you would want to know what is happening to the margins. Are there any calcifications? What is the location? Even intrathyroidal location can be found out. Most important is other lymph nodes. So if there are other cervical lymph nodes, and this has already started metastasizing. So you can also find out if it is involvement of any other metastasis. If TSH is suppressed or hyperthyroidism, you need to do a radionuclide scan to know what is the uptake and where is the uptake if it is a single node. Okay, and to differentiate whether this is benign or malignant, you'll definitely need a FNAC. Most common thyroid cancers are either medullary or papillary thyroid cancer. So medullary, you need to do the calcitonin. Papillary is a diagnosis of histopath. But when a papillary thyroid cancer is diagnosed, it's more aggressive. Okay, the lymph nodes would have already been involved in them, so it's more aggressive than the presentation in the adulthood. Familial cancers, right? So medullary thyroid cancer is associated with men, multiple endocrine neoplasia. So need to investigate for the other associated like pheochromocytoma or hyperparathyroidism. There are also certain genetic syndromes where the cancers are there. In such conditions, maybe as a preventive, you might have to do a thyroidectomy as soon as it is diagnosed. So those are very rare things, hence I'm not discussing over here. Okay. This is a child, 13 years, 6 months, presented with goiter, but there was a prominent nodule on the left side of the thyroid gland. The most important part was the consistency. It was hard. Okay, it wasn't soft, it wasn't firm, it was hard. And it was a single nodule. Okay, and growth-wise, he was okay. He had still not achieved any signs of puberty. First thing that we do was to do the thyroid function test, absolutely normal. Okay, the next thing is ultrasound. Ultrasound just said enlargement of left thyroid lobe, but there was some lymph node involvement. Because there was a lymph node involvement, there was an FNAC run. It was just shown as follicular hyperplasia of thyroid. Then they approached, the oncology team, okay, the surgeon, and the surgeon asked for a PET CT. In PET CT, it wasn't just the left lobe of the thyroid gland. There was an uptake also in the left cervical, supraclavicular, and left upper paratracheal lymph node. Along with that, there was some metabolic active lesion seen in bilateral lung field. So there was already a metastasis that had happened. Okay, and the histopath confirmed it was a well-differentiated papillary thyroid carcinoma with nodal and bilateral lung metastasis. So quite aggressive. Of course, the child underwent total thyroidectomy. You can't do subtotal over here. You have to do a total thyroidectomy to clear the lymph nodes. Okay. So now we are dealing with a thyroid problem. We are looking at hypothyroidism, but in the immediate post-op period, you also have to look at the parathyroid. So this child definitely presented with tetany, had hypocalcemia because of hypoparathyroidism, so needed treatment for them. Could not cite the thyroxine because the child has to undergo radioiodine ablation. Because of such an extensive thing, the child remained hypothyroid for the first 3 months because radioablation is only done when the TSH is high. So no treatment is started in the first 3 months. Look at this, how many times the child has undergone radioablation. And that's not just for the thyroid carcinoma, it's for the metastasis. So the 3 times that the child underwent, it was for the metastasis. Obviously, there was a monitoring of thyroglobulin to look at what is happening to the thyroid cancer over there, and that was not detected. Hence, the ablation was done to the nodes and the lungs. Okay, every time the child would go for the ablation, the thyroxine would be stopped. So this is how old? 13 and a half, going to school. Every time a radioablation is done, the thyroid is stopped. TSH is more than 100. Imagine the amount of time the child would have gone into overt hypothyroidism, undergone radioablation, and then came out of it. Went in, came out. Went in, came out. So in a short term, you may not actually see the implication of this in and out that the child has gone. But as a long term, we need to know what is going to happen to his scholastic performance. What is he going to be as a personality? How confident is he going to be? Because his confidence was always down when there was overt hypothyroidism. So here, besides obviously the whole endocrine thing, this is the child who also needs, a support for mental health illness, So aggressive tumors need a holistic approach. And on top of it, the guideline says that you have to keep the TSH less than 0.1. Now, in keeping the TSH 0.1, there are times when we are also pushing this child to hyperthyroidism. Okay, so it's a very, very difficult, window to keep the child within that range and not, push him towards hypothyroidism as well. So you require a very aggressive monitoring as well. Now, we are not looking at 3 and 6 monthly monitoring over here, but maybe even 4 to 6 weekly if we are seeing some features which are not going into it. So adolescent, school performance, so much of monitoring, so much of radioablation, and definitely a lifelong monitoring. Okay, so earlier the diagnosis, we can avoid the metastasis. Hence, routine examination of thyroid gland will be equally important. So this is the last slide. Abnormal thyroid function test is always the criteria for referral, but now do remember multiple pointers towards what is normal. Okay, nodes which are firm, nodes which are rapidly increasing, nodes which are causing compression, or a goiter which is causing a compression, causing dysphagia, hoarseness of voice. There's a strong family history of thyroid cancers, early referral for diagnosing, intervening, and probably giving a better long-term outcome. Stature and menstrual. So again, growth. Okay. Taking the heights, plotting it on the growth chart, seeing the trend will still be very important. And if you see that the pubertal onset is delayed, or it's early, or there is secondary amenorrhea, definitely you need to look into what is happening to the thyroid function test. So the take-home message is, you can have early diagnosis just by looking at the growth and the neck examination by goiter. Also understand what is normal, okay? And once the children have been diagnosed, all of us in this hall, we need to make sure that they adhere to the treatment, they adhere to the compliance of regularly monitoring and regularly adjusting the doses so that we can give a better outcome in growth, puberty, and long term. Thank you.
Yeah. Thank you, Dr. Ruchi, for such an insightful, practical, and excellent session. As she said, the adolescent thyroid disorders are very common, subtle, and often missed. So it is very, very necessary to diagnose it early and timely manage it, because timely management definitely will improve the long-term outcome in adolescents. Thank you, Dr. Ruchi. Your tips is going to help all of us very much in our day-to-day practice. Thank you. Any questions? Yeah.
The range of TSH we should maintain while treating hypothyroidism?
Yeah, so again, as I showed you the last case, if it is a cancer, post-cancer hypothyroidism, you want to keep it on the lower half. They say less than 0.1, but we try to keep it as 1. For any other cause of hypothyroidism, TSH has to be less than the reference range that is there. Okay, we are not targeting the TSH over there, we are targeting the TSH when it comes to cancers. And hypothyroidism secondary to cancer, even though they've ablated, even though the thyroglobulin is low, we don't want a recurrence to happen. Okay, so most common is to keep the TSH in the reference range and T4 in the higher normal reference. Okay, so not in the lower reference. Also understand that, if the children have missed the medications and when they come to us, okay, and like abhi doctor ko dikhana hai, fatafat medicine le lete. Okay, this is very common. So you'll suddenly see a T4 which will be better, but TSH not. So TSH tells you a long-term thing. So you would know the long-term compliance is missed. Okay, but because they knew that they had to come and see us, they would have started taking the medication in a short period of time. So,
Sometimes it so happens that the T4 is slightly on the higher range, but
Right.
TSH is maintained.
Right.
Should we alter the dose at that time?
so this is called thyroid hormone resistance, okay, and we do commonly see this. This hormone resistance could be at the tissue level, that is thyroid at the pituitary level, okay. So you have to make sure that here, in this case, targeting TSH may not be important, but targeting the T4 levels will be important. So that's where the thyroid hormone resistance and its management takes a lot of toll on us as well, because we don't want to keep the T4 higher and give them hyperthyroidism because we are targeting the TSH. In this case, even a reference range is gone beyond. Like even if you keep 6, 7, 8, 9, 10, as I said, 5 to 10 is not a problem. It's okay as long as you keep the T4 in higher normal but normal range. Okay, so you do see this, and this is commonly even seen in congenital hypothyroidism. Okay, so in such cases, we are not targeting the TSH, which are actually targeting the T4.
So we should reduce the level of the treatment if the free T4 is going
Yes,
above.
yes. If you're seeing 2, 2.2, 2.3, but because you're targeting TSH as 4.5 and 3, no. Okay, it is okay to keep the TSH 6 and 7 in such situations. This is a situational case, okay, where there's a thyroid hormone resistance. Sometimes this is going to be transient and then it's not going to be taking over. You especially see this when they are long-term, they're missed for a long period of time. So this chronic people may have this adjustment issues where the TSH setting is not getting recognized by the thyroxine that you're giving. So in that case, it is important to keep the T4 in the higher normal than the TSH in the normal range.
Hello Ruchi, good cases. I have 3 questions for you actually. First one, you said anti-seizure medication causing, long-term anti-seizure medication causing hypothyroidism. So how frequently one should
It's
monitor?
more common with subclinical hypothyroidism in such cases, okay?
Right.
You may not see an overt hypothyroidism, but where we are looking at here is that if you're starting to see that the thyroid function test, which was normal, annual screening is what you would need, okay? And then now you're starting to see the TSH is building up, okay? In such case, if you have a family history positive, you also want to see that there's an association of any autoimmune condition that is coming up. Okay, so in such cases, you would definitely need treatment. I would not say just because you're seeing a TSH of 6 and 7, you titrate your anticonvulsant medicine. That's not there.
And whatever I remember, it's more common with the phenytoin phenobarb,
Yeah.
oxcarbamazepine, and the newer anti-seizure
You don't see it.
medications you don't
Don't
see,
see it.
apart from gabapentin. That is the thing.
So it's not common.
Yeah.
So again, like iodine deficiency, goiter, and
Yes.
anticonvulsant. Nowadays, it's not very common. Hence, you know,
Right.
you are not looking at that, and hence the
Right.
screening is not very common. But again, it is done because you want to make sure that the child's development, growth, puberty is optimized. So you just want to make sure that there's no any
You
associated
did
condition.
mention about the causes and everything. So what about autoimmune or infectious induced? Is there a recurrence?
So, when there is a infection-induced thyroiditis, that's what you are trying to say, right?
And even
you may
with the autoimmune, is there a recurrence if the infection triggers or something?
autoimmune condition is a condition of hypothyroidism.
Right.
Okay. So, whether there's an infection or not infection, your underlying problem is still there.
Yes.
Here, probably you're trying to ask if this was an overt autoimmune hypothyroidism and you were treating, or this was non-clinical, non-overt, and there was just an antibody which was positive, and the child has got a thyroiditis, and now you want to see whether the child needs treatment. Okay, so in the thyroiditis, you could actually see a release of the preformed thyroid hormone. So you'll see like a hyperthyroid state. Okay, you would definitely want to, in such conditions, without the underlying autoimmune, you still want to check for the thyroid function test if you have checked during this infection once the child has settled down. Because you can't interpret the reports while the child is sick. And especially now that the child is having an autoimmune condition, because they may turn into an overt hypothyroidism, you definitely want to check on them that what has happened. Are we getting misguided just by the infection? And just because the autoimmune, the antibodies are on the lower side, should we just ignore it? No, but you know, once a child settles within 1 to 3 months, you can look at the condition because there was already an autoimmune underlying phenomenon.
Right. The third case which you showed about a papillary, what made you, go for a PET scan?
So
Because,
so this is a case. So this is a case from Tata. Okay. So this child comes from an interior of Maharashtra, and after all, whatever they had found, because of the hard nodule, they were referred to Tata. Okay. And there, the oncosurgeon, obviously in Tata, the first thing, because of the hard node which was there was a cervical lymph node which was involved. The first thing that they do is PET scan. Okay. So this was not done by the pediatrician or so. It was done by the team who's specializing in that. Okay, and when they did this, that is when they found. The doubt was that the whatever the FNE was done, the report was not matching what they were actually seeing in the ultrasound or what they were palpating. Okay, so that made the doubt, and as I said, even though it is rare, it is still very aggressive. So I think finding a lymph node involvement made them do the PET scan, and they found the lungs as well.
Okay, yeah. I think we'll take questions in the tea break. We are already running a little late. Ma'am, we can take it in the tea break. After this session, we have a tea break. We have a 15-20 minutes tea break. Extremely sorry for that. I would request Dr. Ruchi and Dr. Rajul to please come on the dais, and I would like to invite Dr. Sikha Agarwal, our Secretary IAP Mumbai, to please felicitate as we move on to the next session. Thank you so much for that insightful session, Dr. Ruchi. Thank you. So with that, we now move on to our next session. Our next session is a panel discussion on adolescent obesity. We know in adolescent period, growth spurts, snacking spurts, but I think before blaming the lifestyle, we should not forget the endocrine system. So let's question the calories and cross-examine the hormones now. For this session, I would like to invite our moderator, Dr. Jagruti Sanghvi. She is a pediatrician and an adolescent health expert at Nanavati Max, at Advanced Hospital, and at Nurture and Suture Clinic. And she is our dynamic treasurer of IAP Mumbai. So a big hand to her, and I would like to request her to start the session and invite her panelists as well. Thank you.
A very good morning to everyone. May I invite Dr. Paresh Desai. He is a senior consultant pediatrician at SRCC Children's Hospital, Haji Ali, Bhatia Hospital and Saifi Hospital, and with special interest in diabetes, obesity in children, asthma, public health and infectious disease. May I invite Professor Dr. Abhishek Kulkarni, the hero of today's session. He is a senior consultant pediatric and adolescent endocrinologist and department head of SRCC Children's Hospital and Reliance Foundation Hospital. He has numerous publications to his credit, lots of faculty invites. He's been Chief Scientific Advisor of the Pediatric Endocrine Evaluations and Recommendations modules of IAP. He's been collaborator for multiple projects related to various endocrine issues in pediatrics as well as adolescent, and we indeed have an honor to have him here with us. And with the mentor, we have his mentee, Dr. Devika Desai, who's a junior consultant pediatric and adolescent endocrinologist at T2T Hormone Clinics, SRCC Hospital and Apollo Hospital, Navi Mumbai. She's also been co-author, co-investigator for multiple trials related to various endocrine issues in children. I'm going to come to talk to you about a topic that's relatively simpler than the previous two topics that we dealt with, and something which we see as general pediatricians in our practice, the weight debate, tackling teenage obesity. And we know that the prevalence of obesity has been rising in the metros. India is becoming the third most obese nation in the world, with obesity in adolescents rising as far as never before. The prevalence rate is increasing, and there was a study done in Tamil Nadu where it was found that more than 20% of adolescents in the school were obese, and overweight and obesity was seen in 85% of children with a high waist circumference. Obesity is indeed the new pandemic after COVID, and COVID has also actually given rise to more and more obese people. The share of obese and overweight children or adolescents is expected to double by 2050 in India to 37 to 40% from a current 20 to 25%. It has been found in numerous studies that most adolescents do not engage in physical activity, with physical inactivity being as high as 75% in adolescents in India. And we know that the prominent causes of obesity that we come to see is basically related to lifestyle. So you are what you eat, and then nobody runs, nobody exercises, and therefore obesity runs in the family. And like Kiku Sarda, I'm sure all of you have heard his famous interview where he says that obesity is the only city which stays. Other cities may demolish, like you can have various cities in the world which might demolish, but obesity hamesha aapka saath deti hai. And then as we see that as our screens became slimmer and slimmer, and more times that we spend with them, our body fat increased tremendously. And why does this obesity matter as far as adolescents are concerned? We have the 4 M's to look at. The first is metabolic issues that can come up. So early onset type 2 diabetes, non-alcoholic fatty liver disease increasing as never before, PCOS as well as hypertension. Mechanical issues like functional complications like obstructive sleep apnea, musculoskeletal disorders or pains, mind injuries, GERD. Mental issues, psychological impact with causing anxiety, depression, binge eating, body image disturbances, and refusal to go to school because of being bullied. And finally, interpersonal relationships being affected because of weight. So your milieu, your basic milieu where we live in is also getting affected. With this short introduction, I'm now going to directly come to the cases, and I would invite our faculty to take part in it and give us more insight into it. So these are real life scenarios that I saw over the last 10 days in my clinic itself. There was a 12-year, 3-month-old tween boy, as they would like to be called, sedentary, doesn't like to go out and play. Parents are actually working, so he plays only indoors, does not want to go down and play, eats home-cooked foods generally, dinner at 9, sleeps at 9:30. He showed a rapid weight gain of 9 to 10 kilos in the last year, growth velocity of 6.5 centimeters a year, weight of 37 and a height of 136 centimeters. On a routine pediatric visit that he came to me, I saw acanthosis nigricans. His BP was 110/70. And this is what we saw over the past 1 to 2 years, that he is now going towards being overweight. So his BMI is about 22 23 adult equivalent. Now my questions to our esteemed panelists here is, and I'll start with Dr. Paresh Desai. Would you be concerned about Keen's weight gain, and why? And the next question is whether you would like to screen for depression, anxiety, because he doesn't want to go out and play outdoors. Which tween would not want to?
So,
Can you help him with the mic?
okay. So the most important thing here is the rapid weight gain, and it's definitely of concern because here we have also, as Dr. Jagruti said, there was an acanthosis. So that is a huge red flag sign when you see acanthosis. Second thing is, what is the weight gain as compared to the height gain? And it's quite massive. Why the child is not going down? Because maybe, a lot of fat shaming is done. So there's always in our classrooms, at least in my time, there was always a Jadia or a Motu or a Beam or whatever. So people are made fun of, and no child likes getting embarrassed. Also at 13, as he is now, there are girls playing also. So, that's when you started taking interest in the opposite sex, and like the other way around. And therefore, again, being called these names is a very big problem. So he'd rather not go and play on his computer or whatever he's playing. And that increases, it's like a catch-22 situation, which makes his obesity even worse, or his weight gain even worse, because he's not going anywhere. And then, peers, this is a very big problem. The same child, now when they are playing cricket, because as it is not going to run fast, so he'll be kept behind. So it's all
It's like a vicious
kind
cycle.
of cycle, and therefore it needs to be concerned. Now again, parents working, I know, it is now today in this city or in any cities, both parents many times have to work. It was easy कि एक जन बैठ जाओ घर में, but if it is possible, sure, go ahead. But otherwise, it is difficult. You need the money to educate your child also as you go ahead. So with that, parents will not be there. So that is what. Also then, we'll come to other things, but what is there at home to eat is also very important.
Okay. So, sir, would you have any quick tools to basically look for anxiety, depression in this child?
Yeah. So, you ask the child about how he's with friends, what games he plays, and it's very easy to find out a child who's not interacting with other children. So yes, that, and also the other signs, like things like acanthosis, central obesity, all these things when you see, you need, because it's going to be a problem.
Yeah, so in short, we would be concerned, although he's just touching the overweight range, we would be concerned about this kid.
So this child, most important, all children must have a BP examination, but a blood pressure,
Yes.
a BMI, a height weight, which we miss. So all pediatricians will weigh the child, but let's do a survey and how many have stadiometers and how many have a proper, these are endocrine. I'm talking to the general pediatrician.
Yeah.
Just go from one area to the other. It's not there.
So as Dr. Amdekar sir rightly puts his emphasis on growth charts, so growth charts should be done at every visit. So Dr. Devika, is monitoring the BMI enough in this child? Like we mentioned that we should do a BMI charting. Are there any other parameters would you like to look for?
So thank you, ma'am, for your question. So though BMI is the main parameter to differentiate between obesity, the class of obesity, and whether the child is overweight or obese, the other parameters, the anthropometric parameters would be the growth velocity, the height SDS, besides that also the waist circumference, and the waist to height ratio. Besides that, as sir rightly said, the BP measurement, it is extremely important with each clinical visit, and other endocrine parameters like say testicular volume, other metabolic parameters, the metabolic profile of the child, along with the BMI, these are equally important.
Yeah, so one is that we are trying to diagnose obesity and also look for complications related to obesity. So various parameters. So I think waist circumference is something that we may not be doing it in our busy OPDs. Nowadays with so much of growth, importance on growth chart, I'm sure a lot of us are doing the growth charts. But yes, that is something that we would surely keep in mind. So Dr. Abhishek, how would you classify obesity? And do you do any particular kind of staging for it?
Yeah, so I'd request you to go back a slide. So there's something nice I wanted to emphasize to the audience. Now, what is generally perceived is comorbidities would be proportionate to the degree of adiposity. First and foremost, I mean, whatever Dr. Jagruti and my co-panelists have discussed, is we must not only think of the extent of adipose tissue. The current definition says any excess or abnormally located fat mass in the body should be defined as obesity. And that's why Devika spoke about waist circumference. In South Asia, many of our teens will have appropriate BMIs or just borderline BMIs like this kid. Look where the BMI is, it's just barely touching the 23rd adult equivalent, which is the definition, beginning of the definition of overweight. But as Dr. Jagruti has pointed out, look, there has been a steep rise in the last 2 years. And at this degree of overweight, you do not expect acanthosis unless the child is genetically predisposed. And that's what I'm going to talk about again and again. Probably the pediatricians may not like it or relate to it, but 40 to 70% of the obesity that reaches a tertiary care clinic has some underlying genetic predisposition. Please do not mistake it for monogenic obesity. It is a polygenic trait where variants across pathways in the body come together to promote an obesogenic environment. And as South Asians, we are blessed or cursed with it. So we need to accept it, understand that these kids unfortunately are predisposed. Now, if you look at a Caucasian or an African, at this BMI, you will not see acanthosis nigricans. Yes, the steep rise could have triggered it. You see the incline is very steep, but generally you will see it at class 2 and 3. So another important feature is we do not talk of 85th and 95th percentile in South Asia. We talk of 23rd and 27th equivalents. And these numbers are lower than the 85th and 95th percentile. That's because Indian researchers realize that we should have lower thresholds for classifying overweight and obesity. And class 2 and 3, which are pharmacotherapeutically significant, are 120% above the 27th equivalent and 140% above the adult equivalent. What Dr. Jagruti wanted to ask about Edmonston's classification is more epidemiologic, is where you have a preclinical, clinical, complication, comorbid, and disability. So you have 5 stages of Edmonston, but that is more epidemiologic. When we are writing papers, we use it, and it's more seen in the adults because teens are not going to come with disabilities and end organ damages. But what is important for pediatricians is overweight, which is 23rd, obesity, which is 27th. These are equivalents of adult numbers on the centile curves, class 2 and class 3. That's what we must go home with.
Sir, is there any correlation with adiposity rebound that we see on the growth charts around 4-5 years of age? So can we predict obesity as early then?
Yes. So what is another very, very important message for the audience and for all of us here is IAP does not have its own references until the 5th year of life. They are in process. The data is being collected. Anthropometric measures are being collected. So what you see is data from the MGRS or WHO charts being fused with the IAP charts. And if someone's genuinely plotting, you'll see there's hardly any space to plot on the height curves in the first 3 years of life. So there is this phenomenon of tracking of body mass from childhood into adolescence and adolescence into adulthood. So this obviously becomes obscure when you're fusing the charts for statistical purposes, because you can't expect the pediatrician to have a vaccine card, a 0 to 5, a 5 to 18, and so many other things. So as endocrinologists, yes, that's the only thing we ought to do, so we have all the time in the world to do it. But what is being used in practice are fused charts. So they're not appropriate in themselves, but they do serve the purpose to alert you as to who's moving towards being overweight or obese.
Sure. Coming to the second case, Nia, a 15-year-old girl.
One question.
Yes, sir.
Slightly perplexed about this child is having only home food. So what?
Yes.
So we'll just come to...
So very quickly, now we've done a study. It's called the Assessment of Dietary Recall Study. And in most of my prescriptions for children who reach us with adiposity, you will find it. Indian diets have more than required proportion of carbohydrates. Simple grandmother saying, poli, bhaji, bhat ani dal. What is the need to have bhat and poli together in the same meal? And for the predisposition that we have, the amount of carbohydrate consumed is 30% more than what is required. So assessment of dietary recall and reduction in total calorie intake by 5 to 7% is almost always the first statement that is dictated to the postdoc, saying this family eats more than required carbohydrates. And all the people who've slimmed and lost weight here would confess that they've given up on carbohydrates by at least 30%.
Yeah.
Yes, insulin insensitivity.
Coming to the second case, 15-year-old girl has menarche since 11 years, has regular periods, has got acne on the T area of her face with a BP of 126/84. She had 2 episodes of ligament injury in the past 1 year with minor trauma. She has a screen time of more than 5 hours a day, sleeps post midnight every day, and has a morning school at 7 a.m. So the sleep time is definitely reduced. Dietary habits, she obviously skips breakfast because she's always in a rush and loves packet snacks. There's Swiggy, Zomato available at the beck of her call for midnight meal and snacks. And there is a history of diabetes in the maternal granddad. These are her charts over the past 3 years at 13, 14 and 15 years of age. As you see, she's been a tall child, so initially parents were not bothered, but eventually they realized that the weight was growing far more in proportion. So we have the weight and height charts as well as the BMI chart in this child, where she's clearly higher, above more than 120, 140% from the adult equivalent of obesity. And in the past 3 years, these are the parameters that she has. As we see, her BMI has reached 29. HbA1c over the past 2 years has been 6.2 and 6.1. And some other metabolic issues have also now come up. Her SGPT is 30, prolactin of 55, TSH of 5.8, raising from 3.04 2 years ago, and a vitamin D level which is 25.6. Now here I've got a little messed up animation, so I'm just going to put it up. I would like to ask Dr. Paresh Bhai, what about Nia's weight gain are you most worried about?
The Nia's weight gain, the most important is 9 kilos and 7 kilos over 1 year. A 16 kilo weight gain over 2 years in a child this age, this something just cannot be this thing. And a lot of time, I'm sorry, this is just another thing. So they say, हमारा घर में tendency है. Because everybody is eating the same thing. It's the parents, the grandparents. So it's tendency. There is no such thing as a tendency. I mean, with, again, due respect to Abhishek, there is a genetic predisposition and all that. But these other things are very important. So I'm very worried about Nia's weight gain. And it is an area that I think that's the first thing that you should consider. Everything else comes after that. Her academics, her first ranking, her sports, I don't know, whatever. And so eating habits, and this dietary recall, I at least 5 times in a day in my practice, I've asked children and the parents who are sitting there, you tell me since yesterday morning what all has gone in. Don't, other than water, just keep telling me. And we just write down, and you see it's actually a lot which the parents see when you put it on a piece of paper. So this is very important about this.
So, sir, what red flags would you check if you have just less than 5 minutes in an OPD
it's very easy
to check?
You take the weight, please do not miss the height.
Right.
That's the most important. If you have a record from the previous time when If you have a record from the previous time that you just see the velocity, so it's nice to have a growth record if this child has been coming to you for vaccinations and so on.
Right.
So then you have a period of time. Then, quickly blood pressure, look for acanthosis, look for central obesity, I mean waist circumference, height, weight. Height, I really am telling you, not many pediatricians do a height. So this height is very important. And you can ask the parental height. I mean, everybody knows I'm 5'4" and he's 5'9", and so at least that you can convert to centimeters
roughly,
or whatever you want the charts to be. And the quick, red flags would be the BP, the acanthosis, central obesity. You talk to the child and you'll find out, children are very quick now. You see children, they talk so much. And this fellow is not interested too much. He's not. So I ask them, who are your friends? What do you do? Do you play anything? What are you good at in school other than your academics? So you come to know, these are in 5 minutes you'll know that this child needs this issue to be addressed. Parents don't take this seriously. It's only the 104 fever that bothers me.
Yes.
Not even the 104 fever, if there is an exam tomorrow in the 3rd or 5th standard. I mean, which of you person here
No,
knows the
exactly,
9th
sir. You're
standard
absolutely correct. In
midterm
fact,
results?
the mother told me last year pre-diabetes, मतलब 6.2 था, अभी 6.1 हो गया.
I mean, I said don't give exams. And remember what Mark Twain said, I have never let my schooling interfere with my education.
Absolutely, sir.
Yeah, please don't. There are two different things. ગુજરાતીમાં ભણેલા છે પણ ગણેલા નથી. So this is, I mean, red flags are there. You can see here.
We can see for them.
And
Yeah.
if you know, I do another thing. I'm sorry. Please pardon me. I apologize in advance. So when I go for general conferences, here there are all endocrine people. So I'm actually very pleased with the audience today. And I'll tell you why. So when you go for a general pediatrics conference to Powai or wherever that thing is, I look at the gate. I sit somewhere there where she's sitting, yes. And I see, जो adults से pediatrics में, अरे मोटे कितने हैं? मोटे is again a bad word. Overweight कितने हैं? And you will find more than 50% are not okay. Here, I find today's audience really amazing.
That's great to know, sir.
Clap for
Let's
yourself.
clap for ourselves. And with that, I'll come to Dr. Devika. Ma'am, can you tell me all the investigations that we as general pediatricians must do in our practice? And we have already discussed TSH. Dr. Ruchi has mentioned that TSH may be high, so we may just leave that part of it. But would you do USG to look for fatty liver in this child who's having an SGPT of 30? And what all investigation you must do? And later on, Dr. Abhishek can pitch in whether there are any other optional investigations that you would like to do.
So, ma'am, the investigations that are recommended in all children with obesity, adolescents with obesity rather, one is the average sugar or the HbA1c. That is a better marker than random insulin levels. Second would be an SGPT because as it has already been emphasized, fatty liver is the most common cause of cirrhosis these days rather than alcoholic liver disease. Third would be the thyroid function. Fourth would be a lipid profile. In all obese children, that is a must. And a creatinine level would also be, so basically a metabolic profile to start off with. Now, TSH in all adolescents, as ma'am has already specified, we would like to do because there is mild TSH elevation because of obesity, which is seen in all cases, but it is mandatory when there are other red flags like short stature, delayed puberty, a family history of autoimmune thyroid ailment. So in these cases, a TFT is a must. So as a baseline, a thyroid function test is mandatory. As I already have mentioned that insulin levels are not mandatory in all cases because they are not reproducible. A better marker to predict insulin resistance would be the HbA1c level and the fasting sugar or the OGTT, that is the oral glucose tolerance test, because they are more reproducible and the monitoring is better because standards are established with the range as per age, etc. So instead of insulin levels, these would be better. Cortisol levels are honestly not reliable, not mandated in all cases of obesity, again only if there are signs of Cushing's. So red flags for Cushing's would be sudden weight gain, again short stature, violaceous striae, pubertal delay, mooning, a hump. All of these would mandate cortisol, otherwise cortisol is not mandatory. Now USG to look for fatty liver, SGPT is a better marker of to predict transaminitis rather than USG because USG can sometimes miss fibrosis and very early mild steatohepatitis. A better investigation would be a fibroscan, but that is not easily available. So take home TSH is mandatory, insulin levels not required, cortisol again not mandatory. Fatty liver, look at SGPT levels first.
What about, sir, Dr. Abhishek, about prolactin being so high in this child? Would that be something that you would be worried about and any other optional?
So very quickly on TSH, thyrotropinemia in obesity is extremely common because of acquired leptin resistance. So do not treat the TSH unless an etiology is ascertained. Having said that, as a pediatric endocrinologist, what I need to remember is obesity increases the risk of thyroid autoimmunity exponentially. So expression of the autoimmune thyroid disease is 3 to 5-fold higher in an obese adolescent female than a non-obese adolescent female. So thyroid function is hence mandated. We do not suspect hypothyroidism to be affecting the adolescent clinically in a tall and obese one. Elevation of prolactin as a thought is often secondary due to a polycystic ovarian accompaniment in an obese adolescent. That's the commonest thing that a pediatrician must think about. Secondly, sleep deprivation and other drugs that an adolescent is on. And hence, Dr. Paresh Desai mentioned, taking a good history to understand mood, behavior, scholastic performance of the child is very, very important in the current era. Now, the other investigations, one investigation that we like to use, and I'll speak a bit about it again, getting to genetics, is the highly sensitive CRP. So we need to understand what obesity does to the body at the molecular level is basically alters lipid partitioning. And once lipid partitioning is altered, so this is what obesity is all about at the molecular level. I work for the genetics of obesity study group, and that's what changed my perspective towards obesity rather than just seeing children as kilograms. Lipid partitioning creates an inflammatory milieu in the body, leading to increase in cytokines, adipocytokines, and free fatty acids. This is what happens at the cellular level. And this leads to insulin insensitivity and endothelial dysfunction, which is what metabolic syndrome is all about. So the whole of the world is trying to arrest, reverse, or at least halt these things at the molecular level temporarily. So a simple marker that we use to segregate the high risk ones from the moderate or low risk ones is the highly sensitive CRP. But the sensitivity and specificity of this analyte is very, very variable. And as Devika mentioned, in obese adolescents, these analytes are often not reproducible. On a morning, you will have a fasting insulin of 50 in an adolescent with severe acanthosis. On another morning, depending on whether the child is going through the follicular phase of menstruation or has had a sports day, what the child has eaten the previous night, how many hours the child has slept, the same fasting insulin will be 18 or 19. So they are not reproducible analytes. They have positive predictive value if they are high. So a senior clinician would know, okay, this is the day to test. And a day prior to the examination is the time to get a fasting insulin level done. So we don't give them out as general take-homes to pediatrician that you must chase these numericals. So highly sensitive CRP is a marker that we use to look for inflammatory milieu in a child with obesity. There are researchers who use it as a marker of remission, though there is no therapeutic endpoint defined. It is neither normalization of the BMI, normalization, optimization of the waist circumference, amelioration of comorbidities. These are used arbitrarily in clinical practice, or remission of highly sensitive CRP. But we do not know as of yet when to stop treating these individuals.
Okay, coming to the management, which is, sir, we'll take questions later. Coming to the lifestyle management principles, we have already spoken about diet, as doctor had asked a question. Quickly, would we like to talk about exercise? What is, like, normally we say lifestyle changes, but what lifestyle changes do we need to ask the patient to actually do? So quickly, if Dr. Paresh could talk about relevant culturally relevant dietary advice, sir, just be a little crisp, because we need to give the right messages.
Culturally relevant dietary advice is very clear. So you have to see where your patient is coming from. Is he a Punjabi Sardar, Sikh? Is he a South Indian from Tamil Nadu? So you can't tell the Punjabi that you give the idli in the morning and this, and the other way around. So that fellow wants the paratha, and how much butter to put in it. In the winter, again, pinni, panjiri, this is all not necessary in today's day and age. In Bombay, there is no winter. There is no need to eat all these parks and whatever that the parents, or if there is a grandparent in the house, wants you to eat. So culturally relevant dietary advice, and the dietary advice is for, even in diabetes now we all say, right? There's no diabetic diet. Everybody should eat the right thing. So there is no culturally, everybody, there should not be, so, I am a Gujarati. So when my childhood, there will always be 5 Barnis. One has Gatia, one has Chevda, one has Busu, one has this. They're there. So you just go and pick up. So the thing to have here is to have children do get hungry.
So
Children
keep
do
the
want
right
to
kind
eat
of
it.
snacks,
So there
basically.
has to be good snacks. So in my car, I mean, I'm an old man now, but in my car, there is chana. In my clinic, there is chana. Simple, just sing chana wala chana. No mungfali in it. And that, just one handful gives you so much good, and I'm okay for 2-3 hours then. So these are the kind of snacks. Even popcorn, though it is said junk, a popcorn which is not very high in butter and is not the caramelized nonsense that you get in theaters now, full of sugar, is a very good snack. The other thing that I talk on is, my son says you are an idiot doctor because you talk about fat children and children who don't pass motions, pediatric, chronic functional constipation. Your life is this, I said, yeah, I'm at the bottom of the pile. And my son is a wicked lawyer, so how it goes.
So we'll just proceed to the next
So
part.
that is very important. So it has to be according to you, and this Bernie system has to go.
Bernie should have the right
Bernie
kind of
system,
snacks.
Seasonal eating system,
Yeah, so healthy snacking.
you already talked about late night studying, the dorm cycle as they call in America. They won't study. They'll study only in the night till 2 or 3 o'clock they are awake. All children have elder children will have morning schools. So the sleep deprivation, again that creates a problem. And in the night, if you're going to stay awake for till 2, I get hungry. I want another meal after my dinner. So yes.
So sleep according to the sleep cycle is most important.
Sleep hygiene.
Yes.
Sleep hygiene. And the most important thing which was in one of these slides, breakfast. I asked the child, I asked the parents, what is the first meal called in the morning? Why is it called breakfast? Because that's the highest time in 24 hours that you are fasting. Otherwise, I've had breakfast here, I'll have lunch at 1, I'll have a cup of tea without biscuits at 4 or 5, and at night I'll again eat. So we are eating every 2-3 hours in the night. And the last thing that impresses the parents about breakfast, because it's important to get your parents, is that the brain cells, the neurons, which you want your child, everybody wants a first class first child, they can only use glucose as substrate. So please give foods. You have to feed the child before he or she goes.
To school.
Also, foods with high glycemic indices are not good. You'll have this and a that.
So we need to basically give.
This is the thing.
Yeah, we need to basically tell them exactly what is to be eaten. So coming to Dr. Devika, how fast should you target weight loss? Like you can't have somebody, you just say weight loss. How much should you target? At the same time, what exactly are the type of exercise? Quickly, if you can wrap this up in a minute.
Sure, ma'am. So in pre-pubertal or adolescent children, like early adolescents, even if you target weight maintenance, that is okay because you're going to grow in height, so the BMI will normalize. Late adolescence, when the growth is lesser, at that time you can target a weight loss of up to 1 kg per month, so about 250 grams per week. And in extremely overweight or obese children, not overweight but obese children, up to 5 to 10% weight loss should be targeted in a period of 6 months to 1 year.
Okay.
In terms of physical activity, any structured, moderate intensity activity is encouraged. So aerobic more versus weight training or strength training. Minutes, in terms of minutes per week, it should be about 45 to 60 minutes, at least 5 to 7 days per week. 5 days, 7 days would be ideal, but 5 days at least. Aerobic versus strength training is also equally important because it improves insulin resistance. But to lose weight, aerobics or structured isotonic activities are more important. So if you have to just sum it up, about 60 to 70% aerobic, 30 to 40% strength training.
With resistance bands, etc., can be done for children.
So one important message: when patients present to you with class 2, class 3 obesity, you do not begin with strength training immediately. You start them more on isotonic activity. The word is moderate intensity. These are very specific terms quantified by kilojoule calorimetric studies. For the pediatrician to tell the parents simply, it is that level of activity where the child is able to speak in words and not in sentences. This is very, very objective. It's not a subjective definition. It's been matched to kilojoule studies. And as Devika rightly mentioned, more severe the degree of obesity, more is the weight loss expected in the initial few months, 1 to 4 kilograms per month in an adolescent with lifestyle and or pharmacotherapy. And a must is 4% reduction in BMI every quarter. Otherwise, that treatment strategy is deemed not successful. So these are objective criteria in the obesity clinic where we say, oh, this strategy is not working or this drug is not working for the child.
So doctor, first thing is stop this weight gain, this 9 kilos, 7 kilos. Even if you come after 3 months and if you're say 38 kilos and you're 38, that's the beginning. Yes.
So, yeah.
We don't want 33.
Absolutely. So you don't want a very rapid weight loss either. So you give them targeted, realistic goals. So Dr. Abhishek, when would you consider pharmacotherapy in adolescents according? So whether drugs like metformin or Listat, whether we as pediatricians can use it in our practice, when and how, with what dosage, and what are the expected timelines and when to stop?
So now let me get back to classifying. I'm going to be brief to the point, but it is very important for the pediatrician to understand. One is the extent of obesity. Class 2 obesity with comorbidities that Devika and Dr. Jagruti mentioned is an indication of pharmacotherapy as adjuvant to lifestyle measures. Please understand, lifestyle measures are the mainstay of obesity irrespective of the etiology. And when it is medically significant obesity, lifestyle measures often fail. This is what is written in most journals, that lifestyle measures in isolation often fail in pathologic obesity. And that there is the role of pharmacotherapy. And why is it? Because all of the obesity is mediated through 3 inherent mechanisms. Most importantly, your resting energy expenditure. 65% of the energy spent by the body is at rest. It's only 15 to 30% that is spent with exercise, which is called thermic effect of physical activity. So one who is blessed with better resting energy expenditure is leaner, irrespective of the degree and the duration of exercise that individual performs. And the thermic effect of food is only 10 to 20%. So a person who is cursed with low resting energy expenditure accrues fat mass or differentiates the mesenchymal stem cell into adipose cells faster. The second is dysregulation of the hypothalamic nuclei which control appetite and satiety. And third, differentiation of the mesenchymal stem cells into fat cells irrespective of the energy intake. Usually you need to have a positive energy balance for this differentiation to occur. But there are people who would say, doctor, my appetite is not great. When you do the recall, they are not even consuming what the RDAs are, and yet they keep differentiating their stem cells into adipose tissue. So that's why I say 40 to 70% of all of the obesity has some underlying predisposition, which is usually polygenic, on which bad lifestyle acts. Now coming to drugs, class 2 with comorbidities and class 3 obesity, which is 140% above the 27th adult equivalent, are indications for considering pharmacotherapy. Now the strange paradox is metformin is not FDA approved for treatment of obesity alone, but in countries like ours and other countries in South Asia, it's the commonest drug prescribed. That is because it works very well in patients with insulin insensitivity. It is, however, FDA approved for impaired glucose tolerance, type 2 diabetes, and treatment of obesity associated with polycystic ovary disease and obesity triggered by atypical antipsychotics. In today's day and age, a history is very, very important. Depression, mood disorders are often a common accompaniment of adolescents with obesity. And if the obesity you deem is triggered by one of these offending agents, the role of metformin is highlighted. The benefit is primarily on insulin sensitivity, and the degree of reduction in BMI over a 12-month period is to the tune of 3 to 5%. So it's a very modest agent for obesity, but often used first line where insulin insensitivity is seen. Now the more potent group of drugs are the GLP-1 receptor agonists, approved by the FDA for use 12 and above, Off-label authorization from 10 to 12. How these work is regulation of the hypothalamic nuclei and hence improve satiety. Activate resting energy expenditure again through the hypothalamic nuclei, the root cause of obesity. And that is the reason why these drugs are published, are studied, and are so deemed successful, is they target the molecular mechanisms. And they also slow food movement through the GI system, hence reducing the hyperphagia that these patients have. So it's called the gut-brain talking. They act at the level of the gut and also at the level of the hypothalamic nuclei. And just to give you a perspective, semaglutide, which is used once a week subcutaneously in a phasic manner, starting from 0.25 mg and moving up to 2.4 mg weekly, which is the threshold dose, can accord a median reduction in BMI of about 16 to 20% over a duration of 52 weeks. So this is data from NEJM. We are in process of publishing our own data, over 491 adolescents being treated with semaglutide. But stratification of the individual based on BMI, presence absence of comorbidities, and likely etiopathogenesis at the molecular level is extremely important before choosing the subject as a candidate for pharmacotherapy. So
what about tirzepatide? It's quite something
yes,
that is...
Yes, so tirzepatide has an added advantage of it being a GLP-1 receptor agonist and also targets the glucagon inhibitory peptide. So it acts as a dual agent. The current FDA position is approval above 16 years of age. So it is used less in the adolescent population. The first line agent to go with is the GLP-1 receptor agonist. But it definitely is more potent when you look at the median weight reduction in BMI over the same 52-week interval, but currently has approval 16 years and above. Now, the only drawback with these drugs is extreme degree of gastrointestinal side effects. So the patient must be counseled. And if you ask me what percent of patients in my experience or my series have had, so I've treated close to 490, maybe enrolled one yesterday. And 80% of the patients have had gastrointestinal discomfort. 20% to the tune of wanting to opt out of therapy, and it needs intense reaffirmation, counseling, dose, stoppage of dose escalation, sometimes stepping down, and if people interested could read the STEP-TEEN protocol, which is used to initiate and escalate these doses, and up to 80%. So almost all of them will experience gastrointestinal discomfort with these drugs.
And there is also rebound that...
1 minute on metformin. The reason,
Sir, Mike, please.
Is general pediatricians, obese children coming in the OPD, 20, 30 patients to be seen. So something needs to be done. That's the first thing.
Right.
Second thing, metformin is extremely cheap.
And safe also.
Extremely safe. It's the safest anti-diabetic drug to be given in adults. And it, reduces appetite. So Sarah, all these obese children, come khao. So that's where it starts. Correct khao wo nahi. Theek thak khao wo nahi. It's the kam khao. So this also, and I also want to tell you one more thing. If you're using too much metformin, keep track on the B12 level. The B12 level, really the absorption goes down tremendously. Plus because we are predominantly all vegetarian, all of us. So even if you are eating an egg and
So it's a good idea to start metformin before we go to a pediatric endocrinologist for a referral.
Glutides whose spellings I don't know, I don't even venture into this. This is for the ruchis and the others.
So Dr. Devika, I want to tell us what are the referral criteria to send it to a pediatric endocrinologist. After we have started metformin, after we've done with the lifestyle modifying measures, what are the referral criteria?
So first things first, if the basic measures fail, so 6 to 12 months of following compliance in diet, lifestyle, everything that was advised, and still there is increase in the BMI or there is no reduction in the BMI. Second, very early onset obesity. So onset of obesity within the first 5 years of life mandates an endocrine evaluation. Metabolic obesity, meaning any comorbidities like transaminitis, thyrotropinemia or thyroid ailment per se, any other comorbidities like elevated cholesterol levels, dysglycemia, that should also mandate a endocrine evaluation. Next would be any syndromic obesity. So any form of dysmorphisms, any syndromic obesities, intellectual disabilities, those children also require a thorough endocrine evaluation. I think, and other comorbidities like hypertension. So all of that put together does merit an endocrine evaluation.
So here take home for us would be that lifestyle modifications for at least and specific guidance given to the parents. At the same time to the patient. The teen should understand what we are trying to tell them. Metformin may be started maybe at the dose of 500 milligrams per day and then gradually, so what exactly are the dosages that we would start with?
Metformin, the message is, please use it in patients where you suspect a degree of insulin insensitivity. If you're going to use it as a first line for a patient for only targeting the BMI, you may be disappointed. You must gather evidence for insulin insensitivity, either clinical, even truncal adiposity, transaminitis, elevated triglyceride. These are indirect evidences of insulin insensitivity. And be very realistic, tell the parents about the modest efficacy in patients where the component of insulin insensitivity is not predominant. I saw Dr. Jagruti the endpoints and I spoke about it. We still do not have well-defined therapeutic endpoints because we have no cure for obesity. Obesity is a chronic disease akin to diabetes and hypertension, and the world will soon accept it. But optimization of BMI, amelioration of comorbidities, regression of the inflammatory milieu in the body, these are the current therapeutic endpoints that are being used in practice. And in patients who have underlying genetic predispositions which are very, very explicit or have been documented by studies, there is role of a maintenance phase. So we keep these patients on the same pharmacotherapeutic agents in a reduced dose to prevent resurgence and rebound. So in years to come, you will see a lot of papers on maintenance phase of use of GLP-1s, of use of metformin for duration as long as 2 years, or maybe even up to 5 years. And that's where role of, like a simple example is replenishing B12 in patients on metformin, or monitoring patients for gastroparesis when they are on GLP-1 will be the key. This cohort of patients will continue to follow up at tertiary care centers, and clinicians will need to be aware of the ADRs of long-term use of these drugs that they would have to be monitored for.
Okay, sir, last rapid fire questions, strictly within our one sentence answers. Dr. Paresh Bhai, top 3 obesity red flags to indicate an endocrine cause.
So, truncal obesity,
Okay.
high blood pressures. So we are not checking blood pressures. That is the problem for every child. So top is blood pressure, acanthosis if you see.
So insulin resistance.
Insulin resistance evidence. Once you see these things, you have to, these are the top 3 flags. You can see that the child is overweight in our experience.
Right. Dr. Devika, BMI, waist circumference, or both?
Both. BMI for classifying the stage of obesity, and waist circumference because BMI cannot pick up visceral obesity.
Visceral obesity. Dr. Abhishek, real world dietary advice, wheat versus rice.
Rice better if you're looking at the Indian population, and but then food preferences in our country, definitely, you would have to go. So tell the family about variants of wheat like whole grains, or maybe emmer wheat, which you're looking at food tolerance, you're looking at glycemic index, and you're looking at the carbohydrate content. But if you ask me, as a pediatric endocrinologist who's into epidemiology, and I'm looking at allergenicity, autoimmunity, rice any day versus wheat.
Okay.
Gluten triggers a host of immune responses that rice doesn't.
Dr. Paresh Bhai.
No, more important, not both together.
Absolutely.
Not both together. Okay.
Absolutely.
Dr. Paresh Bhai.
2 rotli, then bhat, and then...
Okay, biggest misconceptions that you hear in your clinic, 1 or 2?
Tendency che. Hamara ghar mein tendency che.
Right. So that is what Dr. Abhishek, polygenic.
But they're all eating the same thing.
Yeah.
You do a dietary recall.
Yeah.
What are the snacks available to a child? Are your child sleeping in time? Are your child waking up? The children, the screen time. Now you were talking about screen time. Screen time very important because you have to have children who are not like me. I need somebody to even set up my phone. That's not the right thing. I agree. Studying, yes. Non-study screen time should be restricted to weekends only.
Okay.
Absolutely. I have had children and I have done this and I have been sure taking out all this Netflix, no cable. Therefore, Doordarshan.
Dr. Devika, role of intermittent fasting.
No, intermittent fasting
in
is
adolescence.
not, yeah, it is not recommended because it can also trigger eating disorders in children because children are growing, so it can impact. More important would be timely eating or time restricted eating. So say 8 a.m. to 6 p.m. having a breakfast, as sir said, is a must. Not skipping any meals and having early dinner. That would be better than intermittent fasting.
Great. Any other words of wisdom, Dr. Abhishek?
No, so, again, let me emphasize the extent. I mean, pediatricians, pediatric endocrinologists, we are often overwhelmed by the extent of obesity, looking at the concomitant height, whether the child is short and obese, tall and obese, presence, absence of comorbidities. But let's lay emphasis on predisposition. Your perspective towards looking at the child, understanding whether this is a one-off bad event that has occurred to the child or is a chronic disease will change based on how deeper you probe into understanding the genetics.
And any way to change the resting energy expenditure? Can we help a patient?
So one important thing that Devika was mentioning is one is in severe obesity, class 2 and 3, we don't start strength training immediately. Secondly, exercise enthusiasts and people who are very conscious of their body image would agree with me that good lifestyle coaches and trainers will tell you the ratio of strength to aerobics is usually 1:2.
Okay.
For so-called perfectly sculpted bodies. So whereas research would tell you that there should be about 20 minutes to 60, but most lifestyle coaches would confess that ratio should be around 1:2.
Right.
If you're looking at good distribution of lean mass.
Okay. So we have take-home messages from today's talk that early identification important. Do blood pressure, BMI, waist circumference in all children who come to us. Treat obesity as a disease and not just a behavior based on their eating habit. Screen for comorbidities. Lifestyle measures should be specified and structured lifestyle instructions need to be given with 60 minutes of daily activity. 45 minutes is also good. Okay, so it's 20 minutes of aerobics and 40 minutes of aerobics and 20 minutes of strength. Less than 2 hours of screen time or only screen time on weekends. Regular sleeping during the sleep cycle. Food advice must be simple as well as culturally relevant. No wheat and rice together. Metformin and GLP-1 agents have clear indications. Use them wisely. Take advice of pediatric endocrinologist. Mental health and obesity are inseparable. Please always screen your patients for the same. Family-based care where everybody is trying to eat the same kind of food and do exercises together makes a lot of difference. Address myths like Dr. Paresh mentioned about tendency chair and all that in the family upfront. Follow-up very, very essential. So monthly review for 3 to 6 months is essential to track whether the patient is going on the right track. And then as he mentioned about maintenance therapy or maintenance treatment. And most important, do not shame the adolescent ever in the clinic. He will never come back to you. So thank you to our panelists for such a wonderful and practical discussion and for a very wonderful audience. Thank you so much. That Amrita will decide.
Have you seen any weight loss drugs, Mounjaro and this, any need to do the thyroid workup?
Very good. Yeah. So let me clarify. Excellent question. So both with GLP-1 receptor agonists and a combination of GLP and GIP, why does the drug insert mention the word medullary carcinoma of the thyroid? That's the question. That's because in mice model studies, hyperplasia of the C cell was noted during the trials of both these agents. But why we pediatric endocrinologists allay anxiety and we do not yet advocate performance of an ultrasound routinely for every patient being initiated on the drug is because mice express C cells 35 times more than humans. So if you choose an animal which has overexpression of the thyroid C cells for a study, there is going to be hyperplasia, or it is likely that the animal would have hyperplasia. Humans do not express thyroid C cells as much. So theoretically, the patients are not at risk. But because the C cell hyperplasia was noted, FDA mandated the company to mention in the insert that patients who have had personal or family history only of the medullary carcinoma of the thyroid, not papillary and follicular, must not be prescribed either or both of these agents. But let me confess, the conservative clinicians that we are, we have extrapolated that to any carcinoma or any solitary nodule of the thyroid. So we are very jittery when a patient has a history, personal or familial, of thyroid carcinoma. We usually do not advocate, but evidence mandates us to not prescribe it only to patients with personal or family history of medullary carcinoma of the thyroid, and the data comes from mice model studies and not human.
Okay, thank you, Dr. Jagruti and the esteemed panelists. We are, as we all know, we are doing this session live online. So we have just 2-3 questions online, which I can just take. First question is oral semaglutide used?
So oral semaglutide is approved and in use for type 2 diabetes with obesity. Please understand, doses available in India are 3, 7 and 14 milligrams. Just as I speak to you, Novo Nordisk yesterday has submitted for an FDA approval for its oral semaglutide molecule measuring 25 milligrams. So yes, so 3, 7 and 14 milligram strengths are currently not approved for use in obesity without type 2 diabetes, because the equivalence of dose required to cause meaningful reduction in BMI is 25 and above. So Novo Nordisk has submitted to the FDA for an approval of its molecule measuring 25 milligrams. Currently, oral should not be used for obesity without diabetes.
Okay, there's just one more question. There is, do you suggest DEXA scan for measuring fat mass, muscle mass, lean content, etc.?
So in a country like ours where healthcare is pay out of the pocket, we would rather use BMI and waist circumference, because we can be lean and fat. So we might not appear overweight, obese, but may have visceral adiposity. But if you ask me what is the gold standard to quantify fat mass, then it has to be DXA and PQCT to quantify the actual fat mass in the body. But in clinical practice, we use BMI and waist circumference. So our experience, unfortunately, is primarily limited to semaglutide because of the FDA approvals. Most of our population is up to 19 years of age. But patients who have not responded to semaglutide and who are above 16 years of age or have had partial response and have further needed to have pharmacotherapy to be continued, we have used them. We have used tirzepatide in them. Vis-a-vis, tirzepatide stands more potent as compared to semaglutide, but currently the FDA does not authorize its use in individuals younger than 16 years of age.
Okay.
My observation is that the paralysis of the gut, what occurs almost in the 80% of cases with the semaglutide, Mounjaro is much better tolerated, and patient does not get that kind of bloating and
GI intolerance is reported to be lesser on tirzepatide, primarily because of its its mechanism of action. It has dual GLP-1 receptor agonist and GIP as well. So GI tolerance is definitely better, particularly in the first 4 weeks of onset of use with tirzepatide.
Okay, thank you so much for that wonderful panel discussion. I would like to invite Dr. Rajesh Kasla sir, President-elect IAP Mumbai, to kindly felicitate the moderator and the panelists. And we are going to break for tea for only 10 minutes right now. and then we'll continue with the CME. And just an announcement for the delegates who are attending us online. We have almost 10 questions asking if there are MMC points if we attend online. No, there are no MMC points. If you attend online, you have to be present at the venue. All those who have come here today will get the MMC point. Okay, thank you. And one more message for our audience who are online. We will be having a Ask the Expert session. So if I missed out on a few questions, we will be taking it. So stay tuned online.
Friends, growth chart is the progress card of health, and every child should have it being monitored till the end of the growth. Periodic growth monitoring can pick up an early deviation that could be the only clue to a hidden disease or a defect, and it gives you an early diagnosis. In day-to-day practice, the growth chart helps us to define correctly the origin of the disease, because many times the parents present with acute symptoms, but behind that could be some insignificant symptoms overlooked by the parents, and we can pick up by the growth chart a subacute or a chronic illness, though presenting apparently with an acute symptomatology. Of course, duration and progress adds to the probable etiology, and the diagnosis can be helped. The difference between a recurrent infection and a persistent infection with a recurrent symptoms like tuberculosis can be easily made out by the growth chart itself. And finally, parents are always worried about their child being thin, and a growth chart keeping up the centiles can really assure the parent that their child is quite healthy. Friends, growth chart has a very positive preventive role and also a diagnostic ability. It is so simple, it's most useful, and it is cost effective. Friends, if you are not doing it so far, please take a pledge and start doing it. After all, we all want to be rational pediatricians. Thank you.
Friends, growth monitoring is a routine practice for all of us as pediatricians, as it provides us with crucial clues to make diagnosis of certain conditions. Growth monitoring, which includes monitoring of head circumference up to 5 years of age, length or height, and weight monitoring, is equally important in hematology-oncology practice. If there is an acute weight loss accompanied by fever and/or other symptoms and signs, one must suspect malignancies such as leukemias, lymphomas, and/or solid tumors. An early diagnosis coupled with early institution of appropriate therapy definitely improves outcomes in these children. In a child with iron deficiency anemia, if there is growth faltering, both weight and height, one must worry about malabsorption syndrome such as celiac disease. In certain chronic conditions such as hemoglobinopathies, we must monitor height regularly to derive height velocity. And with that, one can diagnose whether the child has short stature due to pituitary and/or gonadal iron overload. Timely appropriate intervention in such children can help treat short stature to attain better final heights. Anemia of chronic diseases such as anemia due to chronic renal or hepatic disorders almost always is accompanied by short stature. A preceding growth chart is a great help in diagnosing these conditions. Friends, one cannot overemphasize the importance of growth monitoring in each and every child that visits our clinic. Let's continue this practice as we have been doing in the past too. Thank you.
Most pediatricians recognize kidney diseases by the symptoms of puffiness of face, oliguria, hematuria, or massive proteinuria. However, only 20% of children with kidney diseases present with this obvious symptoms and signs. The majority of children, over 80%, have subtle symptoms and signs not easily attributable to the kidney, and hence kidney diseases often go unrecognized and undetected in the early stages and are detected very late. An important feature of all kidney diseases is failure to thrive and a poor statural growth. Hence, growth monitoring using growth charts becomes a very important tool to identify those selected children who may benefit from a deeper evaluation to find out the presence or absence of kidney diseases. Weight less than the 5th centile or a falling weight centile, height less than the 5th centile or a low height velocity or a height curve which is falling below the mid-parental height curve would give a clue to which child should be investigated. So I would suggest that growth monitoring using growth charts should be used in all children.
So dear friends, let's join this movement with Team IAP Mumbai. Let's start using growth charts in our routine office practice and pick up all those faltering growth curves and offer early intervention and early referrals for all our patients. Let's become rational pediatricians. Thank you.
Hello, this is Dr. Vaman Khadilkar. I'm a pediatric endocrinologist and I was instrumental in designing IAP growth charts. Like under 5 mortality speaks of health and disease of a nation, growth charts speak of health and disease in a child. In my specialty, it forms the crux of making the diagnosis as well as following the progress of patients. For example, even when there are no symptoms present except for short stature, if I see that on a growth chart child is short and obese, I know this is hypothyroidism, versus a child who is short and also has significant weight deficit, then it's chronic disease or chronic malnutrition. It also helps me in following my patients extremely well. For example, when I treat children with precocious puberty, if the rate of growth is optimal, I know my treatment is working. But if it is too fast, I know I have to increase the dose. And if it is too slow, I know I have to reduce the dose. Also, growth charts help me in diagnosing overweight and obesity early. And now with the new IAP BMI charts, I can even define the grades of obesity. I can practice pediatric endocrinology almost without endocrine test, purely based on anthropometry, growth charts, and my clinical diagnosis. So I strongly recommend all pediatricians, irrespective whether they are generalist or specialist, to start plotting on a growth chart even before they have examined the child. And I request all of you to please take height, weight, and BMI. Thank you.
Friends, growth chart is the progress card of health and every child should have it being monitored till the end of the growth. Periodic growth monitoring can pick up an early deviation that could be the only clue to a hidden disease or a defect, and it gives you an early diagnosis. In day-to-day practice, the growth chart helps us to define correctly the origin of the disease, because many times the parents present with acute symptoms, but behind that could be some insignificant symptoms overlooked by the parents, and we can pick up by the growth chart a subacute or a chronic illness, though presenting apparently with an acute symptomatology. Of course, duration and progress adds to the probable etiology, and the diagnosis can be helped. The difference between a recurrent infection and a persistent infection with a recurrent symptoms like tuberculosis can be easily made out by the growth chart itself. And finally, parents are always worried about their child being thin, and a growth chart keeping up the centiles can really assure the parent that their child is quite healthy. Friends, growth chart has a very positive preventive role and also a diagnostic ability. It is so simple, it's most useful, and it is cost effective. Friends, if you are not doing it so far, please take a pledge and start doing it. After all, we all want to be rational pediatricians. Thank you.
Friends, growth monitoring is a routine practice for all of us as pediatricians, as it provides us with crucial clues to make diagnosis of certain conditions. Growth monitoring, which includes monitoring of head circumference up to 5 years of age, length or height, and weight monitoring, is equally important in hematology oncology practice. If there is an acute weight loss accompanied by fever and or other symptoms and signs, one must suspect malignancies such as leukemias, lymphomas, and or solid tumors. An early diagnosis coupled with early institution of appropriate therapy definitely improves outcomes in these children. In a child with iron deficiency anemia, if there is growth faltering, both weight and height, one must worry about malabsorption syndrome such as celiac disease. In certain chronic conditions such as hemoglobinopathies, we must monitor height regularly to derive height velocity. And with that, one can diagnose whether the child has short stature due to pituitary and or gonadal iron overload. Timely appropriate intervention in such children can help treat short stature to attain better final heights. Anemia of chronic diseases such as anemia due to chronic renal or hepatic disorders almost always is accompanied by short stature. A preceding growth chart is a great help in diagnosing these conditions. Friends, one cannot overemphasize the importance of growth monitoring in each and every child that visits our clinic. Let's continue this practice as we have been doing in the past too. Thank you.
Most pediatricians recognize kidney diseases by the symptoms of puffiness of face, oliguria, hematuria, or massive proteinuria. However, only 20% of children with kidney diseases present with this obvious symptoms and signs. The majority of children, over 80%, have subtle symptoms and signs not easily attributable to the kidney, and hence kidney diseases often go unrecognized and undetected in the early stages and are detected very late. An important feature of all kidney diseases is failure to thrive and a poor statural growth. Hence, growth monitoring using growth charts becomes a very important tool to identify those selected children who may benefit from a deeper evaluation to find out the presence or absence of kidney diseases. Weight less than the 5th centile or a falling weight centile, height less than the 5th centile or a low height velocity or a height curve which is falling below the mid-parental height curve would give a clue to which child should be investigated. So I would suggest that growth monitoring using growth charts should be used in all children.
So dear friends, let's join this movement with Team IAP Mumbai. Let's start using growth charts in our routine office practice and pick up all those faltering growth curves and offer early intervention and early referrals for all our patients. Let's become rational pediatricians. Thank you.
Hello, this is Dr. Vaman Khadilkar. I'm a pediatric endocrinologist and I was instrumental in designing IAP growth charts. Like under 5 mortality speaks of health and disease of a nation, growth charts speak of health and disease in a child. In my specialty, it forms the crux of making the diagnosis as well as following the progress of patients. For example, even when there are no symptoms present except for short stature, if I see that on a growth chart child is short and obese, I know this is hypothyroidism, versus a child who is short and also has significant weight deficit, then it's chronic disease or chronic malnutrition. It also helps me in following my patients extremely well. For example, when I treat children with precocious puberty, if the rate of growth is optimal, I know my treatment is working. But if it is too fast, I know I have to increase the dose. And if it is too slow, I know I have to reduce the dose. Also, growth charts help me in diagnosing overweight and obesity early. And now with the new IAP BMI charts, I can even define the grades of obesity. I can practice pediatric endocrinology almost without endocrine test, purely based on anthropometry, growth charts, and my clinical diagnosis. So I strongly recommend all pediatricians, irrespective whether they are generalist or specialist, to start plotting on a growth chart even before they have examined the child. And I request all of you to please take height, weight, and BMI. Thank you.
Friends, growth chart is the progress card of health and every child should have it being monitored till the end of the growth. Periodic growth monitoring can pick up an early deviation that could be the only clue to a hidden disease or a defect, and it gives you an early diagnosis. In day-to-day practice, the growth chart helps us to define correctly the origin of the disease, because many times the parents present with acute symptoms, but behind that could be some insignificant symptoms overlooked by the parents, and we can pick up by the growth chart a subacute or a chronic illness, though presenting apparently with an acute symptomatology. Of course, duration and progress adds to the probable etiology and the diagnosis can be helped. The difference between a recurrent infection and a persistent infection with a recurrent symptoms like tuberculosis can be easily made out by the growth chart itself. And finally, parents are always worried about their child being thin, and a growth chart keeping up the centiles can really assure the parent that their child is quite healthy. Friends, growth chart has a very positive preventive role and also a diagnostic ability. It is so simple, it's most useful, and it is cost effective. Friends, if you are not doing it so far, please take a pledge and start doing it. After all, we all want to be rational pediatricians. Thank you.
Friends, growth monitoring is a routine practice for all of us as pediatricians, as it provides us with crucial clues to make diagnosis of certain conditions. Growth monitoring, which includes monitoring of head circumference up to 5 years of age, length or height, and weight monitoring, is equally important in hematology oncology practice. If there is an acute weight loss accompanied by fever and or other symptoms and signs, one must suspect malignancies such as leukemias, lymphomas, and or solid tumors. An early diagnosis coupled with early institution of appropriate therapy definitely improves outcomes in these children. In a child with iron deficiency anemia, if there is growth faltering, both weight and height, one must worry about malabsorption syndrome such as celiac disease. In certain chronic conditions such as hemoglobinopathies, we must monitor height regularly to derive height velocity. And with that, one can diagnose whether the child has short stature due to pituitary and/or gonadal iron overload. Timely appropriate intervention in such children can help treat short stature to attain better final heights. Anemia of chronic diseases such as anemia due to chronic renal or hepatic disorders almost always is accompanied by short stature. A preceding growth chart is a great help in diagnosing these conditions. Friends, one cannot overemphasize the importance of growth monitoring in each and every child that visits our clinic. Let's continue this practice as we have been doing in the past too. Thank you.
Most pediatricians recognize kidney diseases by the symptoms of puffiness of face, oliguria, hematuria, or massive proteinuria. However, only 20% of children with kidney diseases present with these obvious symptoms and signs. The majority of children, over 80%, have subtle symptoms and signs not easily attributable to the kidney, and hence kidney diseases often go unrecognized and undetected in the early stages and are detected very late. An important feature of all kidney diseases is failure to thrive and a poor statural growth. Hence, growth monitoring using growth charts becomes a very important tool to identify those selected children who may benefit from a deeper evaluation to find out the presence or absence of kidney diseases. Weight less than the 5th centile or a falling weight centile, height less than the 5th centile or a low height velocity or a height curve which is falling below the mid-parental height curve would give a clue to which child should be investigated. So I would suggest that growth monitoring using growth charts should be used in all children.
So dear friends, let's join this movement with Team IAP Mumbai. Let's start using growth charts in our routine office practice and pick up all those faltering growth curves and offer early intervention and early referrals for all our patients. Let's become rational pediatricians. Thank you.
Hello. Requesting everyone to please settle down as we start the second part of today's CME. Dr. Abhishek. Can we, Dr. Abhishek, can we go ahead? Yeah. So our next speaker is the dawn of today's CME. So, Dr. Abhishek Kulkarni, whom we heard so lucidly in the last talk or the last panel discussion. So I am saying that he is the dawn of today's pediatric adolescent endocrine CME, and he definitely has that dawn D factor, and therefore he is going to talk to us more about the D factor in adolescent growth. And over to you, Dr. Abhishek.
So, thank you, Dr. Jagruti, Dr. Nehal, Dr. Amruta, and Dr. Shikha.
May I request Chairperson Dr. Sushma Save to grace the stage. Thank you.
So at the outset, let me thank Indian Academy of Pediatrics, its office bearers, and the chairperson. So in the next 25 minutes, let's try to sum up an overview of vitamin D deficiency in adolescents, the current evidence, treatment perspective, and preventive strategies. There are going to be a bit of subtle differences or not so subtle differences between what the Indian Academy Pediatrics position statement of 2021 says and what the global and Indian expert group currently speaks about. But what we should go back home with is consensus take-home messages rather than brooding on what is different. So in a sun-rich country like India, we still end up leading the world in deficiency of vitamin D in adolescents. As it happens, whether it's type 2 diabetes, whether it's other non-communicable illnesses, India leads the world in vitamin D deficiency amongst adolescents, in spite of being sun-rich. So the presentation outline is going to be role of vitamin D in physiology, prevalence of vitamin D deficiency in India, determinants of vitamin D status in the body, some case scenarios to let the pediatrician know when should one screen for vitamin D levels. We should not be routinely screening vitamin D levels in adolescents except for certain pre-specified case scenarios. The consensus from Indian Academy of Pediatrics and Society of Adolescent Health and Medicine, and lastly, some summary and key takeaway messages. So let's look at the comprehensive National Nutrition Survey data of 2016 to 18, which used a cutoff of 25 hydroxy vitamin D level of 20 nanograms per ml to define deficiency. So this is where the conflict starts. Society of Adolescent Health and Medicine says levels above 30 nanograms per milliliter are optimal. Indian Academy of Pediatrics defines levels of 20 nanograms per ml and above as sufficient. But the Indian Academy of Pediatrics position paper does not segregate the same amongst age groups in pediatrics. So that sort of tells the expert that there's more work that needs to be done here. So 24% across adolescents, the sample size was around 35,000 children surveyed in the CNNS, of which there was obvious gender disparity due to both different biologic needs, cultural, behavioral differences between girls and boys, and obviously awareness gaps in rural India about the biologic needs of the adolescent girl vis-a-vis that of an adolescent boy. So 24% of the adolescents in India were found to be deficient. If we raise the threshold to 30 nanogram per ml, the extrapolation is 54 to 67% region-wise, and there is gross region disparity. Northern India during winters, the prevalence is much, much higher. So what determines the vitamin D status? Female gender, higher risk. Urban residents, naturally, significantly increase the risk of vitamin D deficiency. Vegetarianism, but let me tell you, non-vegetarian food except for fatty fish are also not a great source of vitamin D. It's only salmon, mackerels, tuna, and the livers of these fishes, which have about 1200 micrograms per kg of vitamin D. And the Indian Academy of Pediatrics guideline talks of egg yolks as a good source of vitamin D. Now, an egg yolk provides only 20 to 40 international units of vitamin D. And the estimated average requirement is about 600 international units for an adolescent. So I'm not sure if we could call egg yolk a great source of vitamin D. And for us vegetarians, mushrooms. How many of us eat mushrooms every day? So dietary sources, difficult to quantify. And low physical activity, less than 3 hours a week, also contribute to higher risk. These determinants are from the Indian adolescent population. Winter season again, and northern regions of the country because of the latitude and ultraviolet ray distribution. So what are the consequences? What pediatric endocrinologists are often concerned about the skeletal implications of vitamin D deficiency. I don't need to tell this august audience that it's impaired mineralization leading to osteomalacia, which is the foremost impact of vitamin D deficiency. But what is often neglected is its impact on the osteoid. And one may want to ask, how does vitamin D impact osteoid? It obviously impacts mineralization. That is because of secondary hyperparathyroidism. So the PTH level going up above the inflection point, below the inflection point of 25-hydroxy vitamin D level leads to an increased osteoclast activity, which augments bone resorption. And this is how vitamin D levels impact bone mineral density as well, in addition to just leading to osteomalacia in the adolescents. So this is what it does to the skeletal system, and good 40 to 60% of the total skeletal mass is accumulated towards the later part of childhood and adolescence. So that's why the critical window of intervention and obviously prevention of vitamin D deficiency. Now, while we were training as fellows, we would often sit and chat in between lectures by eminent clinicians, asking ourselves, what does vitamin D do to the human body? And some of the smarter boys and girls would often joke about that vitamin D in the years to come is probably going to add years to our immortality. So it was marketed as the wonder pill across the world way back in 2006 to 2009, before we started to realize that it's not just the levels of 25-hydroxy vitamin D that matter, but there are a host of other issues which I'm going to talk about. But where does vitamin D have a role? Most importantly, other than the skeletal system, please understand skeletal system is the foremost emphasis of today's presentation, is both innate and adaptive immune responses. And that's why studies on association of vitamin D deficiency with pneumonia, with tuberculosis, with asthma, and I'm going to show you some data with the consensus as to what should we be going home back with. So immune system. Second, cellular function. It is involved in cell growth, differentiation, and induction of apoptosis. This is what interests oncologists. So, and obviously angiogenesis. Thirdly, it regulates renin concentration and insulin secretion. That's why it interests the endocrinologist again. And deficiency has been significantly associated with cardiovascular disease, certain forms of malignancy, and autoimmune conditions. Does it call for routine supplementation of vitamin D in these conditions? The answer is strict no. But I'll show you the evidence for it. So determinants and strategies. Sunlight exposure. So the whole world, and we are talking about sunlight exposure. I said India is a sun-rich country. Then why are we not sufficient in vitamin D? So first and foremost, what determines adequate sunlight exposure? Initially, we were taught minimal erythema dose, which is exposure to sunlight to cause a bit of pinkness or brightness in your skin. But ask yourself, aren't we differentially sensitive to ultraviolet light? So how do we go ahead and quantify what is adequate exposure? So the current terminology that is used, a measure of effective erythemal radiant exposure, is standard erythema dose. So which is nothing but an exposure equivalent of generation of energy worth 100 joules per meter square. Now, how is this determined? Is subjects who are volunteering for a study to determine the adequate duration of exposure are made to wear dosimeters. They are put in the pockets, and they quantify the joules of energy generated in response to ultraviolet radiation between 11 a.m. to 3 p.m. So if you expose yourself well enough to generate 100 joules per meter square, that duration of sunlight exposure is deemed adequate or appropriate for you. So the word minimal erythema dose causing a bit of pinkness on your skin is outdated in the modern objective era. And what is recommended for Indian adolescents is daily exposure of 30 to 45 minutes. Obviously, regional preferences, use of sunscreens plays a role, the degree of pollution in urban areas, whether the ultraviolet light reaching you is direct or reflected from housing societies. All of this matters. And 15 to 40% of the body surface area at noon is mandated between 11 a.m. to 3 p.m. So, can you think how it would look like? It would look like this. This is what we need to do between 11 a.m. to 3 p.m., 30 to 45 minutes each day for 5 days a week. Is it doable? Just ask yourself, is it practically doable? It is not even doable on our staycations. And what does evidence show us? That supplementation of vitamin D3 raises the level marginally better than sunlight exposure in adults. Can we say that for children and adolescents? There is not yet enough evidence. But that also, these are statements from the Indian Academy of Pediatrics position paper. I have also put in the level of evidences from 1 to 5, 1 being the strongest and 5 being the weakest. So current evidence does not support recommending the superiority or inferiority of universal vitamin D supplementation over sunlight exposure in preventing vitamin D deficiency in children. However, when we say children, infants and adolescents must be excluded, because we have well accepted that universal supplementation of vitamin D in infancy is advantageous as compared to sunlight exposure. And in years to come, all professional societies will accept that universal supplementation in adolescents is also probably superior to sunlight exposure, mainly because of the inadequacy of sunlight exposure. Now, there are also some caveats which are not spoken about often during conferences and presentations. Is prolonged sunlight exposure carries a well-established risk of skin cancers, requiring a careful balance between vitamin D synthesis and photoprotection. And again, the Indian Academy of Pediatrics, at a level of evidence 3, goes on to publish that the specific risk of skin cancers with prolonged sunlight exposure in the Indian pediatric population remains unknown. So unless we have had targeted studies to establish clear, safe and effective guidelines for vulnerable populations, particularly children, I'm not very sure which modality is going to be the most appropriate one in the pediatric population. For infants and adolescents, I think we have a near consensus towards tilting for supplementation. Now, dietary sources I've already mentioned, it's the fatty fish. And what is important to take home is the RDA for adolescents has been revised to at least 800 milligrams for calcium. From the earlier 400 to 600 milligrams, it has now been revised to 800 milligrams. So food fortification obviously is a strategy that is being now explored in India. So milk, dairy fortification was attempted in Delhi for the first time. By my colleagues, Dr. Rajesh Khadgawat, and what was found is fortification of vitamin D to the tune of 600 international units per day raised the 25-hydroxy vitamin D levels beyond 20 nanograms per ml in 70% of the subjects who consumed fortified milk. And the baseline value was 4.9%. So only 4.9% of the subjects had sufficient vitamin D versus 70% after food fortification. And if you raised the quantum of supplementation, naturally the percentage of subjects achieving sufficiency went up, which is quite self-explanatory. Now, this is important for the pediatrician to understand what tests do we prescribe to assess the adequacy or inadequacy of vitamin D stores of the body. So the analyte that needs to be used is 25-hydroxy vitamin D. So what is consumed or prescribed by the pediatrician is cholecalciferol. What is measured in the blood or the serum is 25-hydroxy vitamin D. And what actually acts on the receptor is the hydroxylated 125-hydroxy vitamin D. And this is why we all need to understand that mere levels of vitamin D do not signify adequacy and are not enough to explain the multitude of extraskeletal benefits of vitamin D. It is the regulation of hydroxylation and very, very importantly, vitamin D receptor polymorphism that determines the efficacy of extraskeletal benefits of vitamin D. So what is commercially used is an automated immunoassay where polyclonal antibodies are used to measure the 25-hydroxy vitamin D. concentrations. It obviously comes with a disadvantage that this allows a bit of cross reactivity between the inactive metabolites, and you may end up overestimating the vitamin D or the 25-hydroxy vitamin D level by 10 to 15%. But it's still cost effective. And the other thing that this doesn't allow you is to differentiate between the hydroxylated form of D2 and D3. But that may not always be clinically relevant, but it's the 10 to 15% variance between the inactive metabolite that may confound a clinical decision. Now, the gold standard obviously is liquid chromatography, but is surely more expensive and may not always be feasible to perform in clinical practice. So the simple message is have an allowance of 10 to 15% for the numerical that you see on an automated immunoassay, because 90% of the laboratories would be using automated immunoassays. But for research studies, we use liquid chromatography mass spectroscopy. So let me show you some case scenarios. And before I start showing you cases, I have a disclaimer to make that on many occasions, vitamin D deficiency may not be responsible for the presenting symptoms. I have taken these scenarios in perspective of today's talk. Not every muscle ache or weight loss or feeling fatigued is due to vitamin D deficiency. So these case scenarios are very, very representative. So adolescent with diffuse muscle aches. This is a scenario where the pediatrician is allowed to prescribe a 25-hydroxy vitamin D level. Like I said, you will not routinely prescribe a 25-hydroxy vitamin D test to a child visiting your clinic. But if you have an adolescent with diffuse muscle aches, you're justified because that is one of the presenting features of vitamin D deficiency. Second, athletic children who have shin pain and decreased sports performance. Yes, you are justified in optimizing the vitamin D levels in these set of children. Obesity, yes, you are perfectly justified in asking for a 25-hydroxy vitamin D level in an obese adolescent if the adolescent is symptomatic. And one of the ways, in addition to limb pains and muscle aches, is proximal muscle weakness. Many of the obese adolescents have an occult proximal muscle weakness which becomes explicit when you make them get up from the chair or make them get up from the examination bed, and that should alert you to look at a 25-hydroxy vitamin D level. Why is it also important that the dosage regimes to treat vitamin D deficiency need to be individualized in obese adolescents? Because obesity itself sequesters 25-hydroxy vitamin D. So you may need to treat longer. The maintenance phase needs to be longer in patients with obesity. Now, I have already emphasized the importance of looking for proximal muscle weakness. Adolescents who have clothing which usually covers them completely are a high-risk scenario where it is justified to ask for a 25-hydroxy vitamin D level. Vegetarian diets, but I'm not sure the type of non-vegetarian food consumption that happens in urban India would offer you any great advantage, but vegetarian diets with symptomatology which is subjective is also an indication for prescribing the 25-hydroxy vitamin D level. Now let me emphasize to you this case. This is something important because this child went from pillar to post, and it was getting difficult to understand what was the cause of the progressive painful lower limb weakness. This child presented with limb pains and proximal myopathy, and as you can see, the pain was bad enough for even a technetium 99 bone scan to have been done. And you could see multiple pseudo fractures. And in the end, we concluded that this was secondary hyperparathyroidism due to severe vitamin D deficiency. So vitamin D deficiency in the adolescent can lead to an extreme presentation and must be considered in patients with limb pain and proximal muscle weakness. So let me now speak about the IAP recommendations. And here there is a bit of a difference between the Society of Adolescent Health and Medicine guidelines. So the estimated average requirement in an adolescent varies between 400 to 800 international units per day. And the IAP expert group as of 2021 goes on to say that this requirement must be met through diet and natural sources like sunlight. it says there is no role or it does not recommend routine supplementation of vitamin D in the adolescent. Whereas the Society of Adolescent Health and Medicine and also the Indian Expert Group 2025 goes on and makes a recommendation that adolescents who are not at high risk must be given 600 international units of vitamin D every day, in addition through what they derived from diet and sunlight exposure, like the infants. And those at higher risk must be replenished with 1,000 international units per day. The Indian Academy of Pediatrics guideline says levels of 20 nanogram per ml and above are deemed sufficient. But if you read the guideline carefully, towards the end it makes a mention of the word optimal, which is not mentioned anywhere earlier across the paper. It is a 34-page paper and it talks of deficiency, insufficiency, sufficiency. And towards the end, there is a mention of the word optimal. So the Society of Adolescent Health and Medicine is more explicit. It says levels below 20 nanograms per ml in an adolescent must be deemed deficient. So what I like to use in practice is for the pediatric population, the pre-adolescent, I like to stick to the IAP guidelines. Once the child has reached adolescence, I like to use the thresholds prescribed by the Society of Adolescent Health and Medicine. Their levels above 30 nanograms per ml are defined sufficient and optimal both. Route of administration, oral. Please understand, oral supplements raise vitamin D levels faster. So the preferred route of treatment should always be oral while managing adolescents with vitamin D deficiency. Dosage regimes are about 3 equivalents of 3,000 international units per day. And when you're treating deficiency or rickets related to vitamin D deficiency, the duration of treatment is 12 weeks. That's because remission of the metabolic bone disease requires about 12 weeks. And intramuscular route should only be reserved for cases where oral absorption is uncertain or compliance is questionable. So now let's come to slightly revised guidelines, which I think are more applicable to the adolescents. So deficiency is defined as levels less than 20 nanograms per ml, and optimal and sufficient levels are above 30 nanograms per ml. And if you see now, the upper limit for being optimal has been reduced to 50 nanograms per ml from the earlier suggested 70 nanograms per ml. And what is the treatment protocol? In established cases of deficiency, you treat these patients with 50 or 60,000. Now the global guideline says 50,000 because commercial preparations contain 50,000. In countries like India, the commercial preparations contain 60,000. So it's okay to use them interchangeably once a week for a total duration of 8 weeks, followed by maintenance phase. So all individuals who have had clinical or subclinical vitamin D deficiency must be provided a maintenance phase. If you ask me how long, the guideline doesn't mention an end point, neither of the guideline. So it indirectly tells us these individuals must be receiving supplements forever. Now, how does one define these cutoffs? It is very important for us to understand why these numbers, where have these numbers been derived from. So the most important numerical marker is the inflection point where the parathyroid hormone rise is inhibited. So at levels above 30 nanograms per ml, secondary hyperparathyroidism does not exist. That's the first criteria for determining sufficiency. In adolescents, we also need to understand concentrations that are necessary for acquisition and long-term maintenance of bone mass will help us determine what numerical we should be targeting. And thirdly, the level at which calcium absorption is the best. I think of all the markers that are used to determine a particular numerical in an adolescent, these 3 markers serve my purpose as a pediatric endocrinologist the best. So I have already spoken about it, that 600 international units per day in addition to sun exposure and dietary vitamin D intake. If your individual is a high risk one, who are the high risk individuals? Those who have malabsorption, chronic liver disease, chronic renal disease, obese adolescents, dark-skinned adolescents, patients who are on anticonvulsants, glucocorticoids, anti-HIV group of drugs, are high-risk individuals, those adolescents who undergone bariatric surgery, those who use complete clothing. Here it is perfectly justified for the pediatrician asking for a 25-hydroxy vitamin D level and replenishing them with 1,000 international units per day. So I've already spoken about it, the treatment protocols. The one simple suggestion that you could give your patient is you consume the supplement with the largest meal of the day. And in Indian households, it's usually in urban Indian households, it's the dinner because the family eats together. So you ask the patient to consume the supplement with the meal. Do we need milk or ghee to be taken along with the current preparations? The answer is no. The current micellized preparations of vitamin D do not necessarily require a fat medium to enable or aid absorption. So, very, very important, prevent recurrence in an individual who has had vitamin D deficiency, and hence the role of maintenance phase. And if you look, most guidelines speak of it as a long-term strategy, emphasizing the need for ongoing consistent supplementation. Neither of the guidelines speaks about an end point. So vitamin D insufficiency, you treat these patients with 1,000 international units a day or equivalents in a month. So you could treat them with 30,000 units once a month or 1,000 units once a day. This is for adolescents who have levels of 25-hydroxy vitamin D between 20 and 29 nanograms per milliliter. Vitamin D toxicity, very, very important in pediatric population. It's often a concern, but in the adolescents, it's very, very rare. That's because the threshold equivalents are you need to have consumed 10,000 units of vitamin D daily for a duration of 4 to 6 months. That usually doesn't happen. The safety thresholds are much higher, and primarily the symptomatic manifestations are seen, the hypercalcemia, hyperphosphatemia, soft tissue calcification, renal and neurologic dysfunction are seen when levels are close to 200 nanograms per milliliter or above. But does that mandate a revision of the cutoff? No. The cutoff for defining toxicity in adolescents is still 100 nanograms per ml. That is because the societies want to have a large window of safety margin between where the highest probability of occurrence of clinical disease versus the safe level exists. So 100 nanograms per ml still is the safety threshold, but symptomatology is usually seen when levels exceed 200 nanograms per milliliter. Now let's talk about very, very briefly the extraskeletal benefits and what must the pediatrician take home. So vitamin D deficiency is definitely associated with increased incidence of pneumonia, with the severity of pneumonia, with tuberculosis, with HIV. But does it mean these patients should receive routine vitamin D supplementation while being treated? The answer is no. Indian Academy of Pediatrics says there is no role of routine supplementation. However, it is suggested to maintain optimal vitamin D levels in them. And this is where, the difference arises. It talks of 20 and above as sufficiency. And then towards the end of the paper, when it speaks of extraskeletal, it starts to use the word optimal without defining what is optimal. So I think 30 nanograms per ml, as a pediatric endocrinologist, primarily for the skeletal benefits. I'm no expert to look at the neuromuscular and the pulmonary ciliary epithelium. Maybe some researchers have quoted 40 nanograms per ml, but 30 nanograms per ml. But the recommendation is these subjects must have optimal vitamin D status. But routine supplementation as a prescription while treating these disorders, we do not have enough evidence. The non-infective conditions, asthma, ADHD, autism spectrum, definite association. Obesity, metabolic syndrome, definite association. Atopic dermatitis, definite association. And strong level of evidence 1 and 3. But again, the Indian Academy of Pediatrics unequivocally says existing data does not justify routine vitamin D supplementation in them. But clinical advice is to maintain optimal 25 OHD status. So if you deem these patients could be insufficient or deficient, treat them. So prescribing 1,000 units of vitamin D to them without checking the 25-hydroxy vitamin D level is absolutely justified. These are high-risk individuals. So you can prescribe 1,000 units. But prescription of 60,000 units once a week for 8 weeks without the level may not be justifiable. If they are deficient, yes, you can go ahead and treat them. So the summary of the Society of Adolescent Health and Medicine's core recommendations is aim for a level of 30 to 50 nanograms per ml, daily supplementation of 600 units for apparently healthy adolescents and 1,000 who are at risk, 50,000 units once a week for 8 weeks for treatment of deficiency followed by maintenance. Patients with insufficiency have to be treated with 1,000 units for 3 months to attain sufficient levels. And toxicity is rare. However, the safe upper limit is still described as levels of 100 nanogram per ml or below. Now, summary of the IAP recommendations. It says meet the estimated average requirement through diet and sunlight, but it does not segregate the children and adolescents. So it's okay to tweak when you're dealing with adolescents exclusively. Now, treat confirmed deficiency with a 12-week course of oral cholecalciferol. Here I agree with IAP more. If you look at the SAHM guideline, it says 8 weeks. But yes, for adolescents, that's because we are giving a higher dose. An important take-home message is when you use higher doses of cholecalciferol, the half-life extends. So the half-life of the drug is dose-dependent. And that's the reason when you have given very high parenteral doses of 1.5 or 3 lakh, you will often see the drug in the 25-hydroxy level in circulation to be high for up to 3 months. So the half-life of the molecule extends when you increase the dose. And that's the justification why the Society of Adolescent Health and Medicine says we are okay to treat for 8 weeks and then put the adolescents on maintenance phase. Now, utilize advanced methods like liquid chromatography for precise 25-hydroxy estimation. But if you are smart enough to account for a 15% variance, using a polyclonal automated chemiluminescent immunoassay is just fine. It's much cheaper. While optimal status is advised, routine supplementation for treatment is generally not supported for extraskeletal benefits by current evidence. And further research is needed to clarify the therapeutic role of vitamin D supplementation beyond deficiency treatment. Now, to sum up, the approach for prevention and combating vitamin D deficiency is multi-pronged. First is targeted supplementation. So adolescents, high-risk population, infants must be supplemented. There is emerging evidence that pregnant women in the second trimester and beyond must also be supplemented with vitamin D. So not in the first trimester, please understand the difference. Safe sunlight exposure, you need to balance between the plausible risk of future skin cancer versus vitamin D sufficiency attainment through photo exposure, and population level food fortification for a large country like ours. So dairy and flour are the simplest ones that are fortified in the West, and similar strategies on pilot basis are being attempted in our country as well. Public health campaigns, especially for high-risk individuals. And most important avenue for research is to prioritize studies on long-term safety of sunlight exposure, and even further, comparative intervention efficacy of supplementation versus sunlight exposure in prevention of deficiency. There's no two thoughts on efficacy of supplementation for treatment of deficiency. Research is needed to understand which of the two modalities is superior in prevention. Is it adequate sunlight? When I say adequate and safe sunlight exposure, and maybe I like to add practicality as well, because 10 to 3 is the time all of us are indoors. So maybe tilt towards supplementation in adolescence and infancy. So thank you very much, ladies and gentlemen. And two important, I don't know, in the era of AI, we always like to search quotes, before our presentations. So two of them which I thought would be very, very, very relevant is pediatricians must understand that in the modern day and age of gadgets, that bone health is built in the clinic as much as it is built in the playground. So because these kids are going to see you more often than, not all of them are fortunate enough to manage time and resources to be competing in a professional sport, or the concept of unstructured play as it was during our childhood is diminishing. So this thought really appealed to me, that skeletal health is built in the clinic as much as it is built in the playground in the current era. Secondly, vitamin D is not merely a vitamin, but a steroid hormone which regulates the transcription of 200 or more genes. So that's the message that we go with, that this is an endocrine molecule. It's a steroid per se, and it regulates the transcription of good 200 or more genes. And lastly, the adolescent of today is connected with his family and friends on social media, but is disconnected from sunlight, right? So thank you very much, ladies and gentlemen, for the patient hearing.
Thank you so much, Abhishek, and as usual, very excellent talk. Any questions?
So I still want to ask that you've said that there's no calculation for the endpoint, but what do you practice clinically? So you just go on and on?
Yeah, so in the endocrine clinic, most of these patients fall into the high-risk category. Now, what often happens is these patients either have a metabolic dysfunction or are on medications which induce accelerated metabolism of 25 and 125 hydroxy. So as a routine practice, the estimated average requirement is often supplemented in the clinic. So I would confess that all our prescriptions would entail that at least 600 international units of vitamin D are prescribed to children. But these are children with morbidities. That's why when I was looking at the CNSS data, I was unable to segregate what geographic location and what was the cohort of patients. How many of these were healthy and how many of these were visiting health clinics for a pre-existing morbidity. Now, if you go and look at the 25-hydroxy vitamin D in a pediatric neurology clinic, they're going to have accelerated metabolism. So there's no way that a neurologist cannot prescribe the EAR of vitamin D3 via supplementation. So in high-risk clinics, yes, supplementation is universal and ongoing.
And of course, you must be monitoring the levels to see that
most
of the times it's maintaining them, as you said rightly.
Yes.
They never cross a trough.
So from the safety perspective, what I can confidently tell you is levels up to 1,000 international units per day, unless there is an undocumented duplication of consumption of supplements, not from dietary sources or sunlight, has never been associated with toxicity of vitamin D. And sunlight exposure can never lead to vitamin D toxicity because of self-degradation of 25-hydroxy vitamin D into 24. So there's a ceiling. A certain level of 25-hydroxy vitamin D, when is reached by feedback, the degradation to an inactive precursor happens. So doses of up to 1,000 international units per day have never been associated with toxicity.
Thank you.
Can I give a comment?
Yes.
Since adolescents are exposed to the sports, and the children have to be also challenged for the growth, and also they are likely to get depressed because of the studies and potential. Now vitamin D3 has a role in mood elevator. It has also improves the immunity. The sports activity will be better for the child. If he's better mood, the attention span will be also better. And what we have seen actually, what I've been seeing, that children who are the girls especially, having small injuries, and when we do the vitamin D3 level, it is around 7 to 9 nanogram. It's not even 20. It's actually 96% of the children, we find them deficient. So I think we should, as an adolescent, this society should make a recommendation that it should be regular supplementation for the adults, and that will improve their performance, scholastic performance, as well as concentration, growth. Indians are short, other people are not, because that growth also is affected because of long years of deficiency, which has affected, and the genes are affected, as you said. So deficiency has affected the genes also, and we all population has become short.
Yes, so I'd agree with you that, and that's the reason why the Indian expert group of 2025 and the Society of Adolescent and Health Medicine have explicitly mentioned that universal vitamin D supplementation in adolescents is recommended. It obviously positively impacts gene transcription. I'm not a sports expert, but I'll tell you what happens in the sports medicine departments at hospitals is generally sports medicine consultants and physiotherapists working with professional athletes like to target 25 hydroxy vitamin D levels of 40 nanograms per ml and above. And neurologists interested in this arena have often done studies on muscular function, optimal muscle function, have also quoted levels of 40 nanograms per ml and above. Pulmonologists often quote levels of 30 nanograms per ml and above with decreased association of flares of acute exacerbation of asthma. So it's 30, 40 for sports.
So what is the role of vitamin K2 supplementation along with D3? Is there any role?
No. So there is no recommendation of supplementing vitamin K along with vitamin D. There are preparations available, and the role is in patients where malabsorption is suspected. So the guidelines do not speak of universal vitamin K supplementation along with vitamin D. What is universally co-supplemented is recommended dietary allowance of calcium. Yes.
Nowadays, there's a trend that all the infants are being given vitamin D supplementation at the age of 1 year.
Yes.
Whether it is required, of course, IAP and premature babies do require, but the baby is as good as 3.5, 4 kilograms also. So that is
Yes. So, yeah, I'll tell you the rationale for it. Yes, the answer is unequivocally yes. That is because sunlight exposure in infancy is quite a contentious issue. And in countries like ours, where universal supplementation of vitamin D in the second and third trimester is not performed, with Indian Academy of Pediatrics emphasizing on exclusive breastfeeding, with breast milk containing only 20 to 40 international units of vitamin D per liter, the answer cannot be anything but supplement the infant with vitamin D. But it has unfortunately reached a proportion that the pediatrician in the remotest part of India is prescribing vitamin D but is not performing a TSH level. So the industry has been very, very proactive and reached the nook and corner of the country, but the science is perfectly justified because of lack of supplementation of vitamin D to the mother in the second and third. The levels of cord blood of vitamin D being 1/3 of what the mother would have had at the time of delivery, contentious sun exposure in infancy, and emphasis on exclusive breastfeeding, which obviously is advantageous and must be performed. So the answer is yes.
So does this go ahead to 600 in the first
Yes. So as soon as the infant turns 1, Indian Academy of Pediatrics says we do not have an answer whether universal supplementation must continue. So even I do not have an answer. Until the first birthday, supplementation must be continued. Adolescents, after the 10th birthday, supplementation must be continued. Between the first year and adolescence, high-risk situations, supplementation must be done universally. But for non-high-risk ones, IAP guideline says requirements of EAR must be met through dietary sources and sunlight exposure. There's no guideline which says supplement them universally. But children following up for chronic morbidities, the answer is yes.
Is there any entity, pseudotumor cerebri by over supplementation of vitamin D?
Yes, so again, the neurologic manifestations of benign intracranial hypertension are usually seen only at levels of 200 nanograms per ml and above. They are not usually reported at levels of less than 200 nanograms per ml and above. But if you ask me, are there case reports of benign intracranial hypertension at levels of 100 nanograms per ml and above? The answer is yes. But usually, by probability, by the rule of probability, this entity would be seen when levels have exceeded 200 nanograms per ml. And why this difference is again because of the feedback inhibition of the hydroxylation. Please understand again and again and again, it's not the 25 hydroxy vitamin D level alone, it's the 125 hydroxy that acts on the receptor. And what form of polymorphism of the vitamin D receptor do you carry? That determines its efficacy, whether it is for skeletal health. So an individual who has a level of 20 nanograms per ml with a good receptor polymorphism and upregulated 125 dihydroxy vitamin D3 may behave better than an individual who has a level of 34 nanograms per ml but a poorer upregulation of 125 and a poorer receptor polymorphism. So it's beyond the level of 25 hydroxy vitamin D that is going to determine how you respond or perform with it.
For us as practicing general pediatricians, you have a healthy adolescent, no comorbidity who comes, an 11-year-old. What will you prescribe?
600 international units of vitamin D, without a doubt.
And we continue till
We
1 year,
continue,
2
we
year,
continue
3
till
years,
adulthood, till attainment of
18
adulthood.
years, 18 years. So that is one definite take home.
And for ease of compliance, they can be given a monthly dose of up to 30,000 units per day, not exceeding that. You can give half of it. You can give 2.5 ml of the... No, you can't do that once in 2 months because the half-life of up to 30,000 units varies between 14 to 21 days. So as a part of a study, we estimate the 25 hydroxy vitamin D levels between day 22 to day 30. And we often find them dropping.
Going down.
So it's up to the 21st day after universal supplementation that you maintain your sufficiency.
So, but
So
it's going to be 30,000 units per month, no?
Yes.
Even without a documentation, you can
Yes,
give that safely.
Yes, it's safe till attainment of
18
adulthood.
years, 18 years.
Till attainment of adulthood.
So I'm taking an advantage of my chairman post. So I need to ask you 2 questions, Abhishek, quickly. So one is during the insufficiency, you said 1,000 international units per day, and there only you said per month can be given. That
Yes.
was the 2 schedules you had
30
mentioned.
30,000.
Yeah, so 30,000. So what is the result of that? Means does that give an equivalent, or which
Yes.
one is better?
Yes. No. So if you ask me, the ideal scenario is to take 1,000 units per day, because as I mentioned, the half-life of the molecule at the dose prescribed is between 14 to 21 days. So the last week, you will find levels dipping below the sufficiency threshold. But it may not always be practical for the adolescent to be consuming a daily dose. So as an easy alternative, the societies recommend a monthly equivalent.
Yeah, thank you. And the other quick question is about the toxicity. So the child goes with a limb pain and he's been prescribed vitamin D. He takes one for 8 weeks, another for 8 weeks, and he comes with a 124 or a 150 of a nanogram per ml. So how does one deal with that? Yeah.
Toxicity for the clinician is not just the level of 25 hydroxy vitamin D, but the absence of hypercalcemia and or hypercalciuria. So hyperphosphatemia and soft tissue calcification come very, very late. It usually doesn't happen in the metro cities. But what needs to be looked at is the serum calcium level. So if your calcium has exceeded 11 milligrams per deciliter and the individual is symptomatic, you do definitely need to start treating it. And the simplest things that the pediatrician can do before a referral is hydration. And second, prescription of a 5-day course of oral steroid. A 5-day course of oral prednisolone in a dose of 1 to 2 milligrams per kg can be used as first aid in symptomatic hypercalcemia due to vitamin D toxicity. Please understand, this is not the first aid management for hypercalcemia in general. It's only when it is suspected to be due to vitamin D toxicity. A 5-day course of oral steroid can help you temporarily ameliorate the levels, but brace yourself for a rebound because this is a fat soluble vitamin, and up to the 3rd month, usually when you attain toxic levels, the half-life of the analyte prolongs, and up to the 3rd month, you have to brace yourself for symptomatic manifestations. What is done in the institute is hydration, diuretics, typically the loop, and use of bisphosphonates. And if the individual is manifesting with pains, which are the moans and groans, we end up using salmon calcitone in nasal sprays, though efficacy of bisphosphonates is unequivocally superior to salmon calcitonin. So where resources are not a constraint, we use salmon calcitonin as an expensive analgesic for these patients. Right?
So thank you so much. And we do have a session on Ask the Expert.
Yeah.
So can we have a questions there? Otherwise we are running late. Yeah. Thank you so much. Thanks.
Thank you, Dr. Abhishek and Dr. Sushma. Dr. Abhishek, can you please come and felicitate Dr. Sushma for gracing? You have already received your portion. May I also request Nehal, Dr. Nehal, please join in. Yeah. Yeah. Thank you for a very, very engaging discussion. Our next panel discussion is going to be on a very, very interesting topic. It is about a topic that we see into our day-to-day life. It quietly walks into our OPDs, not knocking loudly, and not waving red flags all the time, but it can leave long-term metabolic and emotional footprints if we miss it early. Periods late and pimples loud, teenage worries, confidence bowed, hormones misfiring with an internal mess. Let us pick up the early whispers of PCOS. I invite Dr. Amruta Shirodkar, consultant pediatrician and adolescent health specialist affiliated to Surya Children's Hospital and Guru Nanak Hospital, to come up with this excellent and very, very interesting discussion on PCOS.
Yeah, thank you, Dr. Jagruti. And can we have the present? So yes, our topic, our panel today is titled as the PCOS puzzle, because it is indeed an puzzle. We know PCOS is much beyond just cycles and hormones, affecting metabolic health, mental health, and also posing a cardiovascular risk. And so now, from a single hormone like vitamin D, let's move to a complex syndrome. I'm sure our panelists are going to make it simple and easy for us. So we have chosen this topic because there is extremely high prevalence. We may not know, but there is pooled data saying almost 15 to 17% adolescents do have PCOS, at least features of PCOS. And despite this high prevalence, there is still a low awareness. And there is significant metabolic risk which is present in the adolescents. Almost 60% of the adolescents with PCOS do have metabolic features of metabolic syndrome. And the guidelines, till recently, we never had guidelines which are specific to adolescents. We had the NIH, the Rotterdam, the Adolescent Access Society, but now we have the guidelines which are, the consensus guidelines. So to simplify this puzzle, let's call upon our esteemed panelists. I invite Dr. Jayati Jhala, who is a consultant pediatric endocrinologist practicing at multiple hospitals in Mumbai. We have Dr. Rachna Keswani, again a pediatric endocrinologist from Mumbai. And we have with us Dr. Nirmal Gujarati, who is a consulting gynecologist and obstetrician. So with this starry panel, I think we will start with our discussion. We are going to keep it practical, case related, and helping us with our day-to-day practice. All right, so we'll straight away begin with a case on PCOS. We have this girl who's 10 years, 6-month-old child, a girl. Excess weight gain in the last 3 years. She's gained almost 20 kgs in 3 years. She has prolonged menstrual bleeding lasting for almost 7 to 8 days with clots, has irregular cycles, intermittent spotting sometimes in 15 to 20 days. She attended menarche 9 years and 10 months. She has weight gain with a good height gain. There is sedentary lifestyle, increased screen time, and unhealthy eating habits. Very common scenario for us when we see adolescents as pediatricians. Born at term, birth weight is 2.25, no significant perinatal history. There was a PIH in the mother, development is normal, obesity in multiple family members, hypothyroid in mother since 1 year. On examination, those are her vitals. The BP is more than the 95th centile. SMR-wise, she is B5, P4, A1, attend menarche. There is acne, there is facial hair. A modified Ferriman-Galloway score is 5. There is acanthosis on the nape of the neck, axilla, groin, pink striae, nothing on systemic examination. That's her anthropometry. Please note the waist circumference is more than the 95th centile. These are her growth charts, which clearly shows her weight for age is more, and on the BMI chart, she is more than the 27 adult equivalent for obesity. So I would like to ask our panelist, Dr. Rachna, what is the interpretation based on the history and the clinical examination?
Yes, so besides the chief complaint, which is of menstrual irregularity, it's important to take the case and the entire clinical context together. For example, in the history that you mentioned, the child was born SGA, the child is obese, there's family history of obesity, and on examination there's hypertension. There is some acne and some hair, but we will have to see that properly. And yes, she had acanthosis also.
Right.
So the entire clinical context is important to interpret together.
Okay, so absolutely well put. What about the facial hair and the acne, and what about the Ferriman-Galloway score? Was that significant? Can you just elaborate on that?
Yes, so the modified Ferriman-Galloway score is a semi-quantitative score where we look for areas, androgen-dependent areas, and we look up for the hair growth in those areas. So if we go head to toe, it is the upper lip hair, the chin hair, the chest, upper abdomen, lower abdomen, back, upper and lower, right? And also the arms, not the forearms and the legs, but the arms and the thighs. That's why it's modified, and there's a score of 0 to 36.
Okay.
This child had a score of 5,
yeah.
which is not high, like a score of 8 or above is considered high.
All right, well taken. So, Dr. Nirmal, now this child is an early adolescent. She's just attained menarche. Now, how do we differentiate these menstrual irregularities from early signs which can be suggestive of a PCOS?
So in this case, the early signs we have to consider about the PCOS. Here we are only seeing the menstrual irregularities.
Right.
But if we consider after 1 or 2 years, what we call as a physiological, and once you cross 2 to 3 years of the same symptoms, and along with that, if you have the inflammatory acne and the modified Ferriman-Galloway score is going on the higher side, then we can say it is a PCOS. So here I will go most probably in the menstrual irregularity part only, not much of early signs of PCOS as of now.
Okay, so you wouldn't like to call this as a PCOS as of now at least.
Yes.
She's just in the first year of menarche.
Right,
so
right.
there is some ovulatory dysfunction, but it is not...
not a PCOS per se. We cannot label it as a
per se.
PCOS per se.
Absolutely. So, Dr. Jayati, how important are we see how the child, the girl is having a lot of metabolic features. How important are they now while considering a diagnosis of PCOS in someone like this who's newly post-menarche?
So very important to consider here, and as well as being pediatricians, we are the first contact who comes with such kids. So it's not a linear disorder. It's always a vicious cycle that begins with obesity, begins with poor lifestyle, begins with poor habits, and then of course we may refer after 18 and label it as PCOS after 18, or maybe after 2 years of menarche. But it's not something which suddenly appears the next day. It's always an ongoing process, and the metabolic features are the red flag signs in this case, especially because they are adolescents who are at risk of PCOS. Now there is something called as at-risk PCOS. So it's not a definition PCOS, but definitely these are the kids who are at higher risk of PCOS. And it's very important to halt this process at this stage because they are very well established. We have well established evidence that they are going to be PCOS obese individuals as adults. So as pediatricians, our role is to halt the process rather than prolong it till 18 and then label it as PCOS. So yes, the metabolic features are the red flag signs, and we need to halt this process very seriously in this kid.
Absolutely. So I think that's a point well taken. We have to keep our antennae up when we see such a patient. So like Dr. Nirmal already mentioned, just for the audience sake, this is when we call the ovulatory dysfunction as significant. So in the first year of life, it's okay if the cycles are irregular, but for the after first year, from 1 to 3 years post-menarche, if the cycle is less than 21 days or more than 45 days, for more than 3 years post-menarche, it's less than 21 days or less than 21 days or more than 35 days, or if the girl is having less than 8 cycles per year, or if there is primary amenorrhea, which means no menses by the age of 15 years. So these are I think the criteria for ovulatory dysfunction. And for hyperandrogenism, it has to be, remember, it has to be clinical and biochemical both. So Dr. Rachna rightly mentioned about the Ferriman-Galloway score when we say progressive hirsutism, and it has to be moderate to severe acne. So I think our patient had just mild acne, which can be considered as a normal puberty.
Yes.
And biochemically, there has to be elevated total or free testosterone. Dr. Rachna, can you just tell me about the testosterone, how do we test, which assay to use, we do total or free, what is it?
Right. So, like in this case, we don't have clinical evidence, but
Right.
if we want to give some evidence for biochemical hyperandrogenism, we may do the total testosterone levels. So now, amongst the two, of course, the free testosterone is the active form which is causing the hirsutism.
Right.
However, the assays are not very reliable, and that is why we often end up sending total testosterone
Right.
levels, and using the SHBG, which is the sex hormone binding globulin values, and total testosterone, the free androgen index can be calculated.
Right.
So that is what we normally do, and we have to use very sensitive assays for total testosterone and free testosterone levels.
Okay, so use of sensitive assays is important. So hyperandrogenism has to meet clinical and biochemical criteria both. So Dr. Rachna, ke now she's not meeting the diagnostic criteria. Will you send hormonal or metabolic or both workup?
Okay, so for metabolic, like the discussion we had pre the tea break, of course, 101% the metabolic
Right.
workup. There are no questions about that. Hormonal, like maybe, you know, the opinions might differ here, but yes, we might send testosterone levels
Okay.
to, as a hormonal test for some
Even though she is
biochemical
only
evidence.
still in the first year of menarche, we will still
Yeah.
send that testosterone level.
To label her as at risk.
Okay. All right. Dr. Nirmal, now this is the borderline case. Do you prefer to label this as at risk for PCOS? Dr. Jayati mentioned something
Actually,
as
yeah,
at
she
risk.
had already mentioned about
Yeah.
it. But yes, at risk of PCOS, we have to consider either of one of the features,
Right.
either menstrual irregularities or the hormonal profile derangement.
Right.
So if one of the feature is seen, then only we can say that they are at the high risk of PCOS.
Okay, so point well taken. If there is only ovulatory dysfunction or there is only hyperandrogenism, we will put them as at risk for PCOS. We don't label them as PCOS. To label them, we need to have both the criteria. So these are the labs which were sent. We can see this is the metabolic profile. Dr. Rachna, I want you to have a look at the labs and comment on the reports.
So this kind of summarizes our discussion done previously. The child has some amount of dyslipidemia and not warranting treatment currently, and the TSH is slightly elevated, which may be due to the obesity.
Okay.
And the rest of the profile, the HbA1c is 5.6. It's below the pre-diabetes range, but
Right.
just below it.
Right.
And yes, everything else.
Okay, so there is some amount of dyslipidemia here. So now we sent a metabolic workup. Unfortunately, we don't have a testosterone level in this child. But as Dr. Rachna said, and I think we should send a testosterone just to know that we are not dealing with a at-risk PCOS. Dr. Jayati, what is something that we should not send here and it is not for diagnosis?
So here comes the main difference between the adolescent PCOS and the adult PCOS, because adult PCOS solely relies on the USG findings, on the sonography findings, that if you have a polycystic ovary, it is PCOS. It's considered to be a one-to-one diagnosis, but it's not the same for adolescents, because adolescents do have a physiological multicystic ovary, and it is not considered to be a diagnostic criteria for PCOS. We get many references with just a USG finding of multicystic ovary labeled as PCOS, especially in the peri-pubertal stage. So it's not a diagnostic criteria. Very important to understand that. So first and foremost, USG finding is not reliable in adolescents. Secondly, we have some AMH levels. We have insulin resistance, which are also considered synonymous with PCOS diagnosis. So it's very important to clear out this confusion. Yes, they may be an additional risk for PCOS, but they are not the diagnostic criteria. Only two diagnostic criteria have been defined by the latest guidelines, which is ovulatory dysfunction and hyperandrogenism, which is clinical and biochemical. So apart from these two, all are additional supportive markers for diagnosis, but they are not diagnostic criteria. So as mentioned, pelvic ultrasound, not diagnostic. AMH levels, not diagnostic. Insulin resistance, obesity alone, yes, they are predisposing markers, but they are not diagnostic. And mild acne, again, it is a physiological thing during puberty, so it's not considered to be a diagnosis in adolescents. These are, again, considered for adults, not for adolescents.
Yes, I think Dr. Nirmal wants to comment.
I want to just say one thing. There are two different terminologies, PCOD and PCOS. So what you describe is a PCOD initially, when the patients are getting referred to you people also, they are only for the PCOD. Unless we don't see any hyperandrogenism or any ovulatory dysfunction, there is no need to treat those things. Unless they become the adolescents and then they are coming to us, of course, we'll treat them later on.
Right. Point well taken from the gynecologist. Okay. So now coming back to you again, how will we manage now? This child is having menstrual irregularities. Will we manage, and if yes, how will we manage?
So already you have described that if she has less than 8 cycles per year, and that too in a physiological part, and then the post 3 years, all those things we need to consider. And definitely I would like to treat these patients, but only I will say that with the progestins or progesterone. Nothing else, no COCs, no additional things. You don't need to add up the contraceptive pills because estradiol component is going to cause the epiphyseal fusion, and all of us know that thing. So we need to avoid that. So by giving the progestin pills, we can definitely manage, either by giving it for 20 days or 15 days or sometimes only 5 days a month, so that they get their periods on time. So 5 days, 15 days or 21 days, that's a good idea to give that.
Okay, so only progestin pills may be prescribed to this patient for menstrual irregularities, definitely not the estrogen-progesterone combination. And with a metabolic syndrome set in, obviously this child needs a lifestyle modification and management for that as well. Alright, so it's already been said, I just want to emphasize, if it's only one feature present, it is known as PCOS at risk. We have to provide symptom management. So we need to do lifestyle management for this patient, and we have to follow them up annually so that they don't go on to developing the PCOS. Okay, so we'll now move to our case 2. This is now a 16-year-old female. She has irregular menstrual cycles since 3 years. She has increased weight gain since 2 years and increased facial hair. She attained menarche at 13 years, irregular menses occurring every 2 to 3 months, lasting 4 to 5 days, requiring almost 2 to 3 sanitary pads, no clots. There was a 10 kg weight gain in the last 2 years with a sedentary lifestyle, junk food intake. Concerned about excessive growth of body hair, especially over the face. Associated with multiple acne over face and back, receiving topical treatment from dermat but not with much improvement. I think the third and the fourth point is, as pediatricians we will be seeing adolescents coming with when they have something wrong with their facial features or physical appearances when they show up to us. So birth-wise, she is the only child, birth weight of 2.3 in grade 10. No similar complaints in the family, but there is borderline diabetes and hypertension in both the parents, recently diagnosed. Strong family history of diabetes and obesity on the maternal side. Now here is her examination. Her vitals are fine. She has acanthosis. She has hirsutism. Here her score is 13 on 36. SMR 5, no clitoralomegaly, no goiter. Those are her anthropometry, and this is the Ferriman-Galway score chart which has been put up. This is how it is. The scoring is done. We add up the scores and we got a score of 13 here. This is her height and weight growth chart, which we can see she is in the about the 97th centile for the weight. And this is her BMI chart, where also she is falling in the obesity range. So Dr. Jayati, based on this case scenario now, what do you think this child could be having?
So if we can just correlate, maybe the previous case in the future, 4 years later is this.
Right.
So as I was mentioning, it's not a one-day phenomenon. It begins probably right from the antenatal period when the mother starts having junk food, continues in infancy, the family continues unhealthy habits, there is no play during childhood. Again, we see the clinical scenario in adolescence, but it's not starting in adolescent. It starts much, much before then we actually see this. So probably the 12-year-old girl child did not get any intervention, did not consult a pediatrician or a pediatric endocrinologist, and ended up with everything that we just mentioned. So yes, the first differential that we all have been listening to since morning, obesity with metabolic syndrome. PCOS is just a fancy name that we have given to one of the feature of metabolic syndrome. So yes, the first differential in this kid, otherwise healthy with good height, no other problems, would be a classical metabolic syndrome secondary to exogenous obesity with PCOS. Right? So that is definitely the first one. But as experts and as pediatric endocrinologists, I would not miss other things, because sometimes that is not apparent, has to be always checked. So one thing that we would definitely rule out is a non-classic CAH, that is congenital adrenal hyperplasia, because one striking thing that is a very high Fermin-Galway score, there is significant hyperandrogenism. So we don't want to miss anything hormonal that has to be treated. So yes, the first differential after obesity would be a non-classical CH. Other things very rare would be an androgen secreting tumor or hyperprolactinemia or hypothyroidism, and all these features are of course down in the list, which can be easily ruled out by very minimal biochemical tests. And functional hypothalamic amenorrhea also could be one of the differentials. So very important at this stage, of course, we know the picture very clearly in our OPD. Once the child comes to us, we know, okay, this is obesity with high PCOS. But as an expert, we should not be missing any of the other differentials as well. So, as mentioned on the slide, it's a non-classic CH, hypothyroidism, androgen secreting tumor, hyperprolactinemia, and functional hypothalamic amenorrhea. Percentage is very less, but we should not be missing these as well.
Absolutely. So I think with this differentials, when we ask the negative history, this is the negative history which we got. No history of cold intolerance, lethargy, no history of any voice change. Voice change is mainly for androgen excess. So, but then the androgen levels would have to be really high, I think, to cause a...
Yeah, so everything biochemically would rule out all of these disorders.
Right.
Yes.
So, no galactorrhea for, of course, the hyperprolactinemia states, no easy bruisability, no muscle weakness, no abdominal pain, no mass. So, this was the negative history which we got. Now, Dr. Rachna, when evaluating this patient, what hormonal tests do you want to send? And sometimes we do order a lot of hormonal tests which are not required. So, can you just elaborate on that?
Yes, so maybe we can categorize it into two. One limb would be ruling out other disorders biochemically.
Right.
So the list that was enlisted, we would do a thyroid function test, a prolactin, a DHEAS, the other androgens which may be secreted by a androgen secreting tumor. And for the PCOS diagnosis, besides the metabolic profile, we would do testosterone levels, and of course in the other limb there was thyroid function also.
Right.
And we would do testosterone levels. What we would, I
put that sex hormone binding globulin in red. I just want to know, do we send it? It's very expensive, I believe.
Yes, so we do not routinely send it, but yes, it is a part of which we do for diagnosis of PCOS. 17-hydroxyprogesterone levels is for non-classical CH.
Right.
FSH and LH, so we were initially taught that the LH is higher than FSH in PCOS, but it's not really essential for diagnosing PCOS.
Okay. No. So we may not in fact send an FSH LH?
We may not send. Yeah.
Okay. All right. Any of the other panelists wants to comment something?
So only point here is the guidelines that we study and that we know are from US, who have a insurance-based panel of tests. When we practically send in a pediatric endocrine OPD, we evaluate each cost very, very, you can say very economically, because each test that is enlisted here is minimum of 2,000 to 3,000 rupees. And if the patient on the first visit gets a 15,000-20,000 list of the investigations, they are not going to come back to you. So practically speaking, you have to clinically diagnose, especially in countries like India. Right. We cannot follow the panel which is approved by the insurance companies of the Western countries. So emphasizing that, we want the child to invest more in lifestyle changes rather than invest in all these investigations.
Absolutely. I think that's an important practical takeaway. So these were the investigations which were done. Dr. Nirmal, would you like to interpret the hormonal test? Or Dr. Rachna, any one of you can do that.
Okay. So here we have 8M cortisol levels which were normal. We are not suspecting Cushing's. Otherwise, we would have also done an overnight dexamethasone suppression. The thyroid function test is normal. The TSH is only mildly elevated. Estradiol levels are normal. Testosterone is increased. The testosterone levels are more. And the DHEAS levels, if it was a tumor, the DHEAS levels would be really high.
Right.
LH, FSH, here the ratio is more than 2, which is corroborative evidence. And 17-hydroxyprogesterone level of less than 2 nanogram per ml rules out
the non-classical CH. Dr. Nirmal, how do we differentiate? We do get physiological hyperandrogenism as well, right?
So again, I guess we are going back to our first case where we had discussed all these things. First 3 years of life after the menarche. So whatever the symptoms are occurring with the ovulatory dysfunction, we can call it a physiological hyperandrogenism.
Right.
And then after that, after the 3 years, if the symptoms persist, the acnes are getting inflamed and the other symptoms are also there, like for hyperandrogenism, then definitely we can say that those are the pathological ones.
Right, right. All right. So this is the metabolic profile for this child, Dr. Jayati.
Yeah, so as we had discussed in the previous case, the 5.6 HbA1c has rose to 6 because
two
the
different
child,
cases, but if
the child continued to have sugary foods, packaged foods, everything. So that was expected. So 6 is definitely now a figure that we can label it as a pre-diabetic range.
Right.
So yeah, we were to intervene at 5.5, but yeah, at 6 we definitely need to intervene. OGTT again has deranged, and cholesterol has been also a little bit on the borderline zone, and these triglycerides then cause sudden MIs in the early adulthood.
Right.
So again we have to halt at this process, and the rest of the hormones are biochemically normal, but the child is not normal. So biochemically we do have normal report. That does not mean that the child does not need intervention. So sometimes these hormonal levels are very tricky. They do show it as normal on the picture because again these are adult ranges of normals. We don't have normal ranges of pediatric population right now of post-COVID adolescents. Maybe if we do have a study, these ranges will all become deranged because these ranges then go into the adult.
Absolutely. If this continues into adulthood, we are going to see adult obesity.
Yeah. So MIs then come on such sudden cardiac deaths. So very important to intervene. The only message is that this child needs an intervention and an evaluation by a pediatric endocrinologist and halting the metabolic syndrome that's happening.
Absolutely. So with a pre-diabetic HbA1c and a high triglyceride, we are going into a metabolic syndrome. Now, I know ultrasound is not a diagnostic criteria, but of course we did an ultrasound for this patient because there was obesity and other factors also involved. Dr. Nirmal, can you comment on the ovarian size, morphology, anything?
So again, we are coming back to the same things, I guess. But yes, ultrasound is not the diagnostic criteria.
Right.
Here. If it comes down to the adult part, definitely the volumes has to be more than 10 cc when we come to the adult part. But it seems to be a multicystic ovary only.
So these small follicles are normal for
normal for that because there are physiological changes are happening there.
Right. So this small follicles we should not label on the basis of sonography as a PCOS, but of course she's meeting the other criteria here. So now, Dr. Jayati, you spoke about a lot of differentials. Most of them can be ruled out on the basis of history. Any lab results which can rule out the differential for PCOS? I think we have covered it already, but maybe you can just stress upon it.
Only important is 17 OHP that I would say. It's important to roll out because clinically you might not see anything else except hyperandrogenism, and it's a very silent disorder, most of the times missed by most of us. So without a 17 OHP report, we would not be confidently ruling out non-classic CH. So that 17 OHP has been normal, that's reassuring. Other than that, thyroid function test is a very important marker as well. So as mentioned, non-classic with the 17 OHP. If there is a doubt, we can always do an ACTH stimulation also. Hypothyroidism with a thyroid function test. Prolactin levels sometimes are mildly elevated with obesity as well, so that can be a little deceiving. Cushing's, only if we suspect clinically, we do either an 8 AM cortisol or directly a dexamethasone suppression test.
Right.
And androgen secreting tumor, though very down in the list, but it is very significant to rule out as again it's a tumor, so DHA's level makes a difference with that.
Right. So I think those are the lab results which can help us in ruling out of PCOS differentials. So now we know we are dealing probably with the PCOS. Now here our goal of therapy has to be very clear. What is the child most distressed about? Irregular menses. So I think that should be top of the criteria to treat this patient. Second, of course, comes the physical features, so hirsutism and acne. Then long-term CVS risk and the risk of developing type 2 diabetes. We saw there is already a metabolic derangement, so that needs to be tackled with. most important, improving the quality of life in this adolescence. Remember, we are not dealing with an adult, we are dealing with an adolescent who also has other issues. And I think from the future point of view, the parents are always worried that how do we preserve the fertility in these patients and how do we decrease the risk of endometrial cancer. So Dr. Rachna, now lifestyle management, can you give some realistic goals, some practical tips? What do we do?
Yes, so one realistic goal is weight maintenance.
Yes, I think we had an entire panel on obesity, so most of you we know, but we can just refresh it once more.
One is weight maintenance because that makes it a little less intimidating.
Yes.
Then is 5 to 10% weight loss over the next 6 months, and before that, even telling the child that it's okay if you're not losing weight, but just adopt a healthier lifestyle and
Absolutely.
just commit to exercising every day and commit to healthy eating. That kind of changes the focus and puts the
Absolutely.
pressure
So
off.
non-judgmental, I think
exactly.
very sensitive communication is very important here.
Yes, and for diet, actually, maybe for diet, when like we always say that the healthy eating advice that we give, it's not a general advice, it's a prescription.
Right.
So we have to be very specific about it. So I usually tell them 4 things: sugar, sugary stuff, sweets, bakery, and junk food. If you can just remember that these 4 shouldn't be chosen, and
Right.
something healthier should be chosen. That kind of makes it a little more specific for them.
Right. I agree. I think they should be given with small goals to begin with,
Yes,
because if
yeah.
we give them a list, obviously they are going to default. So, Dr. Jayati, now, when should we start metformin? Now, we know we are having a lot of metabolic issues here, indications, dosing, monitoring, and can it only help for cycle regulation?
So right now, metformin is like our Ramban. That's the only drug that we have approved for children, which will not be questioned by the parents or the Google or the Chat GPT. Because the moment we prescribe something, it's going on the Chat GPT and it's going to be asked whether this drug is safe for my kid or not.
So in your clinic only they will be saying Chat GPT.
Yeah. That goes on. So only safe drug right now that we have with us is metformin. Rest all are off-label, not used, research, this, that. So only safe drug that we have is metformin.
Right.
And I personally use metformin to the fullest because the kids who are referred to me after a long counseling by the pediatrician, after 3-4 years of intense counseling by the pediatrician, and then failing and then coming with all the metabolic abnormalities, definitely need metformin. So if you look at the textbook indications, it is metabolic derangements. You have all the definitions of fasting glucose more than equal to 100. You have dyslipidemia, hypertension. All those textbook pictures are most of the times present in the kids who present to us, because before that stage the parents would have never approached the doctor.
Right.
So if the pediatrician has referred, or if there has been a concern even for the parents, that child would have definitely been in the textbook definition of indication of metformin. So if the kid has been having obesity issues, if the child has been having eating issues, menstrual irregularities, all these would have already been going on for quite some time. It's not something that has happened previous day. So if the parents have been concerned, if the pediatrician has been concerned, as a pediatric endocrinologist, I have very low threshold to start metformin because it's the safest drug. As
Right.
mentioned in the previous sessions, and as I said, it's the Ramban. We have the safest drug available, which has definitive value in reducing the risk in these kids. Because we don't want these kids to land up in an emergency with the adult physician. That's our moral as pediatricians. We don't want to send a sick kid into adulthood. So to prevent this, metformin right now is the only drug. Hopefully we have more drugs which are safer and coming up in the near future. But at present, metformin is definitely indicated, at least in this case, and I would say for any obese child who has secondary metabolic abnormalities or who has even menstrual irregularities, because menstrual irregularity is again not just because of menses. It's because of the overall derangements of metabolism and hormonal disorders.
Right.
So if you treat the insulin resistance, if you treat the primary cause of problems, it's going to definitely help with the menses as well. Menses is just one clinical outcome of the derangement. It's not the only symptom that we are treating. We are treating insulin resistance, we are treating the metabolic syndrome, and that in turn will definitely help the menses as well. So,
So indication is quite clear. Dosing, monitoring.
So dosing, we generally prefer the lowest dose of 500 mg per day,
Right.
because they have GI side effects to begin
Right.
with. Slowly we do escalate it, and most of these obese adolescents do go up to adult range also, because that is the dose that we have
Right.
to be giving for proper efficacy.
All right, well taken. Now, Dr. Nirmal, now we have to choose hormonal therapy for this patient. Now, what is your approach in choosing either the right estrogen progestin combination or progestin only combination for the adolescent having varied symptoms, acne, hirsutism, irregular menses?
So again, one more thing, no estrogen till 18 years of age. That's where we will start. I know
Okay.
there are a lot of people who say that drospirenone combination with estrogen, Yasmin or Dronis are safer.
Yes.
But when it's coming down around the 18 years of age, yes, I will say you can use it for 3 to 6 months, then it's fine. But before that, when it's comes between 10 to 18 years of age, only progestins we will use. Acne, hirsutism, irregular menses, out of that, irregular menses will get covered with the progesterone. But yes, for acne and hirsutism, we will have to use other medications. If they are on the higher sides, definitely the pediatric endocrinologist will take over from that part.
Right.
Anti-androgens, no, not per se.
Yes.
Spironolactone has been used in 50 to 100 milligrams per day. But compared to that, drospirenone has a better effect, better profile, lesser side effects. So I will prefer with that if you want to use a drospirenone alone, yes, definitely we can use.
It does have anti-androgenic properties.
Of course. That's why we are
Right.
using it, because it's
Right.
spironolactone derative.
Yes.
And it doesn't have that much of side effects what we consider
Right.
compared to that.
Right.
So these are the better options. And for other things, hyperandrogenism, again, Jayati or Rachna will take over from you. For what, ma'am? Progesterone, which progestin you are using, that is dependent. If you are using a medroxyprogesterone acetate, you are using a 10 milligram, you can give it for 5 days or maximum for 20 days. And if you want to control, yes, you can use norethistérone also. But norethistérone you will have to give in a loading dose to control if there is excessive bleeding, you have to control that by giving 2 to 3 days in the higher dose and then taper it off for next 15 to 20 days. So that will be helpful for that. But yes, medroxyprogesterone acetate, Devry or Meprate options are available, 10 milligram per day. It's a good option. Give it for 5 days every month. Patient will have regular menses every month. But that you can use it for 6 months or maximum up to 12 months. After that, yes, whatever the natural course is happening, you'll have to monitor that.
Right. Dr. Rachna, you want to add something? Yes.
Yes, like Dr. Nirmal said, we usually do that. Tablet Devry is medroxyprogesterone acetate, which we will start, say, for example, from day 15 to day 25 at 10 milligrams per day. During this phase, she won't have menses.
Right.
Once we stop it, she'll start having menses.
Like a withdrawal.
Yeah, like a withdrawal bleed. And we'll do this for 3 to 6 months till
Right.
the lifestyle interventions and the metformin have started to work. And then maybe give her a chance to see whether the cycles have regularized.
Right.
Along with that, when we add anti-androgens like spironolactone, so the important point there is that aldactone, that is 50 mg aldactone, may not cause menstrual irregularity,
Right.
but at higher doses like 100 mg, 200 mg, there may be breakthrough bleeding in between.
Okay.
So sometimes there, when we know that the child is post-menarcheal and growth is almost complete, we do combine them very rarely, not so commonly, but when the hirsutism is very severe, with combined oral contraceptive pills along with spironolactone, there the point is that we want to give a low dose of ethinyl estradiol, that is 20 microgram or 30 microgram, to avoid the deep vein thrombosis and the
Right.
clotting side effects that
Right.
estrogens may have.
Right. Okay, point well taken. Acne, how do we manage, Rachna?
Yes. So actually that is a very important question, I feel,
Yes.
because I have noticed this, that with all the pediatric endocrine knowledge might that I may start the child on metformin and even combine oral contraceptive pills, the parent may be satisfied, but the child is not satisfied, because she would be like, I'm coming here for the acne and the hirsutism, and she's given me some medicine
You're
for the
dealing
sugar.
with the teenagers, so they are more
Right.
worried about that. Yes.
Exactly. And if there actually the role of the multidisciplinary team comes into picture, and the that we should emphasize on them seeing a dermatologist and taking full prescription from the dermatologist as well. What they do is basically, I think we all know, like the parents have questions for us whether we can do waxing, threading, can the child get laser done? So dermatologists usually tell them that 13, 14 years of age is the age when laser can be done.
Okay.
However, if it's severe, only then, and the pain threshold is lesser for children. And also, if the lifestyle management doesn't work or they don't do it, the hair is going to come back despite the laser. And for the acne, of course, they have topical retinoids, topical antibiotics.
Yes.
And also, if it's severe, then antibiotics like azithromycin, etc., doxycycline are given.
Absolutely. So I think a multidisciplinary approach here is very important. So along with that, I would also like to mention that we do need a lot of psychological management for these patients. They, with the hirsutism, with the obesity, with the acne, they are going to have a lot of body image issues. So I think a proper counseling needs to be done for that. Positive approach needs to be told to these teenagers. They are going to deal with anxiety, depression, and we have seen these patients with eating disorders. Sometimes they have gone to too much of restrictive eating because of the obesity, or sometimes they even have binging followed by purging behaviors. So all this history needs to be taken. So I think psychological management also is very important as a part of the multidisciplinary approach.
And to have a empathetic look, because
Absolutely.
empathy, what the patient might
Yes.
be feeling and what is important to her is important.
So these are just the commonly used hormonal preparations. We are not sponsored by any of them. I'm just putting this up as a reference for us to know what we use. So what Dr. Nirmala was saying, Yasmin, I think has 30 micrograms of ethinyl estradiol. So it's a higher estrogen variant. I think Devry is medroxyprogesterone, which the pediatric endocrinologists commonly use to control the bleeding. And so these are...
Norepinephrine is also there. And see, there is a combination of ethinyl estradiol with drospirenone, that is Yas, which will have 20 micrograms of ethinyl
So it's
estradiol.
the one with the less, it's only called
but it
Yas.
has to be given for 24 days because the tablets, the pack comes as a 24 tablets.
It's a blister pack.
Okay. And with drospirenone, which is the
with the drospirenone.
anti-androgenic
Which is again an
progesterone.
So usually many of the times we start with the Yasmin. If you want to start for 3 months, you can start that and then shift to the Yas if you want to continue with the medication.
But definitely no long-term estrogen. That is, I think, the main take-home
So
message
that's what I
here,
said,
which
around
is
the 18
important.
years of 16 to 18 years of the age, if you know that thing, if you know the family history and all those things, definitely you can consider that part.
Yes.
All right. So these are the progesterones which we should know in order of their androgenic potentials when we are selecting the either the combination pills or the progestin only hormonal pills. So now follow-up we have treated, but follow-up is extremely important. Jayati, how should we follow up the at-risk ones and also those with adolescent PCOS? When should we follow up rather?
Yeah, so very important point that we have to emphasize that it's not a one-time visit. It's not a fever visit. It's not a vaccine visit. It is something that has to be followed up very, very, very strictly. So most of the cases that we have encountered, I am sure most of my colleagues would also agree, that obesity kids do not turn up for follow-up. Or maybe even the metabolic syndrome kids do not turn for follow-up. Because what do they feel? My child is healthy, why should I go back again to the doctor and pay the hefty fees? Rather, I would spend on a pizza or go to a movie and have more of those caramelized popcorn. So, extremely important to emphasize on the first visit itself that this is a disease. It's a chronic disease. It's not something that is just the outside acne or the outside hair that you just see. It's not a one-stop treatment. You got the laser, you got the antibiotics for the acne. It's not going to go away. It's a chronic condition. These are just the outside symptoms of a very complex disorder that's been there in the child for many, many years now. And it's just the clinical scenario that we are seeing now. So extremely important. Maybe we can spend 1 hour in the OPD just to counsel to come back. It's not for our sake, it's for the kids' sake, that the child has to be properly followed up. At least if the child does not look compliant, we call them more frequently for more sessions of counseling, maybe monthly or even 2 monthly till the cycles regularize, till the child and the parents both are convinced that this needs intervention. So once the family is convinced, it becomes more easier for us to manage this condition also, but it takes minimum of 2 to 3 visits to convince them.
Absolutely, well said. So it's like counseling here and anticipatory guidance to ensure compliance, very, very important. So when we follow up, Dr. Rachna, what do we investigate again? And if yes, which investigations do we send? And how long to continue this hormonal therapy?
Okay, so basically we would want to repeat the metabolic profile, especially the parameters that were deranged at the first place. And we've already diagnosed PCOS, so we do not routinely do the hormonal evaluation again.
Okay.
And we continue the hormonal therapy for a period of 3 to 6 months. Then ideally we should take a gap and see if the lifestyle interventions that we have also done over the last 6 months have worked. And then we may have to continue actually sometimes beyond after a break of 3 months also. But yes, that is what we ideally do.
All right. So now, Dr. Nirmal, many times the parents are going to have concerns about the future fertility in these teenagers. How do we address that?
That's too early to talk about.
No, but I know, agree. But parents will definitely see, we are giving hormonal pills to these girls, and they are always, see, when they hear the word hormone, they are like, ki nahi, kya ho jayega aage?
So again, I'm coming back to the same point that there we have to talk about the PCOD, and when it comes down to the syndrome, then we will say that it's a syndrome. If we just see a PCOD point of view, then you can tell them that there is nothing to worry. Even if it is a PCOS, the way you people are treating the patients, and if the reversal is happening, the way the second question was there, how you are going to continue the hormonal therapy or not. If you see the changes, if you see the reversal, definitely you can tell them there is no concern about the future fertility unless there is a full-blown PCOS is happening. Right? And in that case also, if the patient is showing good symptoms of reversal, we don't have to worry about it. So you can always reassure them that nothing's to worry unless the patient is crossing the 18 years of age.
Right. I think reassurance is more for the parents. The teenagers are never worried about that.
Yes.
But it's
and very good point made that the problem with fertility will be if the child continues to have the same metabolic profile.
Absolutely.
So we can use that as a scary
and not
point.
because of the treatment.
Right.
Yes, we can always use that to talk to the child or the parents also, that saying that if you don't want to lose on the fertility, definitely try the treatment whatever we are giving you right now.
Absolutely.
And definitely they can come for a follow-up later on if you say that way.
Okay, I think so that's the end of our panel discussion. I just want to give a few take-home messages which are very important. Firstly, PCOS diagnosis needs both ovulatory dysfunction and clinical and biochemical hyperandrogenism to diagnose it. Please avoid over-diagnosing menstrual irregularity in the first 2 to 3 years post-menarche. Most of the times will be physiological. Biochemical hyperandrogenism has to be confirmed using high quality testosterone assays. We heard the term at least 10 times in today's panel, lifestyle modification, first line therapy for all adolescents regardless of the BMI. Okay, so that is very important. They still might not have crossed the obesity or the overweight line, but if we know they are eating junk, we have to modify the lifestyle. Treatment does not need a confirmed diagnosis. Symptoms should be treated early, and mental health screening, very, very important, essential. I thank my esteemed panel. Please, ma'am.
110 kg overweight.
Okay.
They were from my family. One, they were subjected to I advised them to subject them to bariatric surgery. After bariatric surgery, the girls who were 110 kg, after about 2 months, they came down to 61 kg. The first one, she had polycystic kidney, cystic thing, and by Indira and Kusum Javeri, they did the laparoscopic management of the polycystic kidney. After that, the girl maintained the weight around 61 kg. She conceived, delivered, she is a mother and she is happy. The second one, who was also 110 kg, she underwent bariatric surgery. She came down to 61 kg, and now about 10 years, she is maintaining that weight. She is a beautiful girl. She is taking hormone therapy. She is married. So, bariatric surgery is very important in such cases because the amount of food they can eat is very little, and at a time the type of diet they maintain, that all changes. So because this part was not mentioned, only drug therapy, that's why I thought it is, and my both lifetime experience of seeing these girls becoming so beautiful. So
Yes,
thought
thank you,
that I
madam,
must
for
comment on this.
taking this up. Even Dr. Jayati can add. So yes, bariatric surgery, etc. There are many indications. It is indicated for very severe obesity with comorbidities after growth is complete, because otherwise we cannot allow the child to have that state of nutrition when the child is growing. But the point well taken is, when it's indicated, it's really useful and it can really change the clinical course of a child and an adolescent and adult consequently. Do you want to?
I would like to share a practical experience here. So maybe we are on the beginning end of this trend of bariatric surgery that we are seeing. So I had visited US for 3 months of my training, and there was a 6-month waiting in a bariatric clinic for an adolescent whose parents had already been subjected to bariatric surgery. So yeah, it's the future of obesity, but they were all on GLP-1 till the clinic was able to accommodate them. So maybe we are going towards that stage, but the first stage, that's why, is an early referral before we have to go to the extent of a waiting period of 6 months of bariatric clinic. So maybe we have to stop right now, halt the process right now.
Thank you, Dr. Amruta Shirodkar and the entire expert panelists for such a wonderful discussion. I request Dr. Sameer Dalwai, our past president IAP, to felicitate Dr. Nirmal Gujarati.
In the absence of anything else, I'll just wish you.
Yeah. Yeah, to Dr. Jayati Jala. Dr. Rachna Keshwani. No, it's okay, sir. Yeah, I'm coming. Yeah. Yeah. And request Dr. Sushma also to come to felicitate Dr. Amruta Shirodkar. She is our president-elect. Nehal, we want you here in this frame. Kal, Aaj aur Kal, presidents of IAP Mumbai. Please come in. All the presidents in... अभी आज ही चालू है. Thank you so much.
I just wanted to make a quick comment about what they said very correctly, Rachna, especially you, that, where's Rachna gone? Yeah, that the follow-up is very difficult. And as developmental behavioral pediatricians, you see that all the time, because the trouble is they largely see you talking. And in India, people feel they have enough gyan. So once they get the gyan, they feel they can do it. Why come and pay the doctor again? So it's very important not to overdo the first consultation, because very often we are so keen, sab kuch bata denge. That doesn't work, because then the patient feels, okay, now I know everything. So what's very important is to plan your treatment in parts. So the best way to ensure follow-up is to tell them what is going to be done next time. And if you don't have that call for a comeback follow-up again, they will not follow up, and they don't know that they need to follow up. So you need to tell them that next follow-up I will see this happen, and then I will decide what is to be done. A good contemporary example of this is the movie Dhurandhar. In the last part, they make sure to show you what is going to happen in the second part. So only then will you go for the follow-up. Otherwise, think picture ho gaya. So keep that back. Thank you so much.
Thank you so much, Dr. Sameer Dalwai, for that excellent tip. And now we've saved the best for the last. And we have our own Virat Kohli, who's going to play 2020 with all of us. So Dr. Nehal, she is our current president of IAP Mumbai, and she's got amazing achievements which are here all over here. And she is an expert at a lot of such. And I request Dr. Rachna Keswani to give her expert comments.
Okay, thank you so much, Jagruti. And after all this actual hormonal locha, all the hormonal chaos that we've all been sitting through since morning, of course it's given us a lot of takeaways. We will now go on to tickling our neurons a little bit, and with this endocrine express, Pecha Kucha. So Pecha Kucha is a concept which was first introduced by two architects, Mark and Klein, in Tokyo, way back in 2003. And this entire concept was that how to make the audience more interactive, engaged, interested, and focused in a particular session. So you're actually giving away your messages, and the concept revolves around only a 20-slide presentation, each slide only for 20 seconds. So you sum up the entire presentation in 6 minutes and 40 seconds. You keep the audience completely engaged and focused, and it worked wonders for educational conferences and business conferences, and even for small children. So you have a Pecha Kucha which is going on, you're just projecting images. There is very little text, and there is an entire history and an entire takeaway message coming out of it. So I would like to acknowledge a close colleague and friend, Dr. Amol Murkute, who first introduced this concept to me, and a lot of our pediatric conferences have now started taking. Let me admit that today it is going to be Pecha Kucha 2.0. The 1.0 is the original Pecha Kucha. 2.0 is an adaptation that we have done because it's not going to be strictly 20 seconds. The purpose of this is that every slide is going to give one important takeaway by that expert who's sitting here for us general pediatricians in office practice. So without wasting much time, let's go on with our Endocrine Express. And so there is a pre-sugar rush if anybody wants to stimulate. We have chocolates. And of course a post-Pecha Kucha, anybody who wants a self-acclaimed sugar savory as a reward if you answer correctly. So anybody is free to answer. This is a 19-year-old girl hailing from Rajasthan with a height age of 2 years and a developmental age of only 1 year. Diagnosis. Just hypothyroidism?
Yeah, say.
Okay, so the answer is undiagnosed congenital hypothyroidism. Initially it used to be called cretinism or congenital iodine deficiency syndrome or a congenital hypothyroidism. But strictly this is not true because this is undiagnosed congenital hypothyroidism. We don't know the cause which caused the hypothyroidism. And the quick question to my expert here is that what is the correct time of collecting a sample for TSH in a newborn, a cord blood versus a 72-hour versus a dry blood sample, and how do we interpret?
Okay, so now we advocate collecting cord blood because that is best for the logistics that we have here in India, of course. But we cannot collect a sample if we haven't collected the cord blood. Then there will be a TSH surge. So the TSH would come high for the first 24 to 48 hours. Our second window is 48 to 72 hours where we can again collect a sample, but we'll have to prick the child and then collect. The cord blood would be from the placental end of the cord that we are cutting during delivery. And a dried blood spot will give us information about other IEMs
metabolic
as well.
profile,
However,
screening.
it's it requires a bigger setup. It's costlier, and if we want universal newborn screening to happen for hypothyroidism in India, maybe the dried blood spot could be done, but for universal coverage, a cord TSH is advocated, is what we want to do, what we want to advise.
And Dr. Rachna, are the units of interpretation similar and standard in all the labs?
Right.
Irrespective of
that
the
is
sample.
a good question because we say a cutoff of more than 20 milli-IU per liter is the screen positive cutoff. However, when we do a dried blood spot, we actually measure TSH in whole blood and not the serum. So we have to be sure. However, now the DBS report also is converted to serum units and it's reported in serum units. So we have to note the unit. 20 IU per 20 milli-IU per liter is the serum unit.
Okay.
For screen positive.
Okay. And anything more than 80 is outright
so
pathological.
we have the new guidelines which tell us that between 20 to 40 may just be transient, above 40 is likely to be permanent, and above 80 is definitely you just need to send a confirmatory sample and start thyroxine anyway without waiting for the report.
So anybody in this window of 20 to 40, do we repeat a sample again, and when do we repeat?
Yes, so in the older guideline, we would repeat at 7 days. For practical purposes, we repeat before discharge. And the newer guidelines tell us to measure FT4 in the cord blood only. And if that FT4 is good, we need not repeat it, is what the newer guidelines say.
Okay.
The basic message is 90% of congenital hypothyroidism at birth is asymptomatic, making newborn screening mandatory. That is my message.
So the important take home is universal newborn hearing screening wherever we practice in whatever setup for a cord blood TSH, which is the most practical.
Yes.
And beyond that, if you diagnose, then ensuring a parental counseling, a very effective counseling, so that there is good adherence and compliance to treatment. And for the same thing, big celebrities like Oprah Winfrey, Hillary Clinton, and Arjun Kapoor, all are under treatment, and they have gone all out on social media to emphasize that not just diagnosing, but maintaining treatment is extremely important. Okay, the next one, 15-year-old boy with hypertension and abdominal pain. Ultrasound of the abdomen showed a retroperitoneal mass. Likely diagnosis? नहीं बोलो ना, कोई भी बोल सकता है.
Somebody is saying adrenal tumor.
Adrenal tumor, a little more specific. What is this? Okay. So this is a child with pheochromocytoma, and of course that rash was neurofibromatosis. So the classical symptoms are perspiration, the 5 P's. Perspiration, palpitation, pain, which is headache. The pain here is headache, pressure, and pallor. What are the classic 3 clinical symptom triad in these children with pheochromocytoma that we general pediatricians should look out for?
So of the 5 here, the headache, that is pain, the perspiration, and the palpitation, these are the clinical symptoms. And that
so any child coming with a headache, palpitation, and perspiration, this should be kept in mind.
And the 4th P I would like to say is in paroxysms, because it occurs in paroxysms. Suddenly when the child is playing or is stressed, it happens because the secretion by the tumor of the epinephrine and metanephrine is in paroxysms. It's
and how do we confirm the diagnosis?
Right, so one would imagine that we can check epinephrine and norepinephrine levels. However, that is not the case because that secretion is happening in paroxysm. So we have to check for metabolites of these adrenergic chemicals, and the metabolites have longer half-life. So that is why we check for metanephrine levels and normetanephrine levels in blood. Nowadays, it's easier to check them in the blood, and even urinary levels were done. Yeah.
Right, correct. Okay, so moving on to the next. Identify and describe the cause of short stature in this child. Yes. Sorry?
Yeah.
So what, a little better terminology? So this is constitutional delay of growth and puberty.
Yes, but she can.
And yeah, sorry?
No, but that was right, yeah.
Yeah, and Dr. Rachna, quickly explain us why this curve is very pathognomic of a constitutional delay of growth and puberty.
Yes, ma'am. So if you could go back to the previous slide. So the curve shows that the child was slightly below the 3rd centile. That was, the child was short. And then ultimately, maybe as puberty hit, the growth spurt happened and he ended up being in the target height range. So it's a physiological cause of short stature.
And how would I differentiate this from a familial short stature? Many times we'll have who are having parents who are short, and probably this child, before he hit that normal curve, he was somewhere lower down. So how would I differentiate in between a FSS versus a CDGP?
Yes.
And any one test that will help me do this?
Yeah, so the first question, FSS, CDGP, how would we differentiate? One is by looking at the parent, calculating the midparental height. In FSS, the midparental height would be lower down. What test we would do? So a bone age will be delayed in CDGP because the puberty is delayed and so the bones have not matured. So the bone age will be equal to the height age, both of which will be less than the chronological age. That is what is happening in CDGP.
Right, right. Okay. So moving on to the next. Which of the following is a scoring method of bone age estimation? The Grulich-Pyle Atlas, the Gilzan's Ratib Atlas, the Tanner-Whitehouse 3 method, or the Bone Expert? The scoring method of bone age administration. The answer is Tanner-Whitehouse 3 method. And Dr. Rachna can quickly tell us that
So,
why not the classical age-old that we've all known about Grulich file.
Yeah, so Grulich file is the traditional method of looking at the bone age. It's a matching method or an atlas method where we have a template of x-rays of different age group children, boys and girls, and we compare. However, to make things more objective, we have now a scoring method, which is the Tanner-Whitehouse method, and it takes into consideration Asian ethnicity people also. The Grulich Pile Atlas did not take x-rays of Asian ethnicity people. So now this is what we commonly use now. And yes, an important message here is that, like forensic medicine experts, we don't look at the carpal bones for bone age. That is not, we look at the other epiphyseal centers like shown in the boxes here. That is what we focus on, and we come to a bone age.
So for us as pediatricians, general pediatricians, when we are asking for a bone age, it always has to be universally the left wrist, and the exposure should be till the tip of the middle finger. And whenever this is analyzed and sent back to us, be sure that it's a scoring method and not the age-old conventional ATLAS method that Dr. Rachna rightly said. And now moving one step beyond, we have the MRI also, which is used as one of the modalities for bone age.
Yes, and there's a software method also, Bone Expert, but it's a paid
Bone
thing.
Expert,
We don't
right.
use
So
it.
Bone Expert is that software method. You
Yes.
already have these software. Okay.
So X-ray left wrist up to tip of middle finger is the prescription for bone age.
Right, right. So, of course, this was very quick. And we all know that this is Turner's syndrome with a typical Turner stigmata that we see. You have a girl who's short stature with a broad forehead, with a triangular face, white space nipples, with a cubitus valgus, multiple nevi. But our question here is that how will we pick up a Turner's at birth? So tell us the clinical pathognomic features of Turner's at birth. And is it really important to really screen and look out for a Turner's at birth? How is it going to improvise our management for a
Yes, so
Turner's?
at birth, few clues may be a girl child born SGA because they are usually small for gestational age with some edema of the dorsum of the feet and the hands. Also some redundant neck folds they may have. Also a right-sided heart lesion in a female newborn born SGA may give us some clue that in a slightly dysmorphic looking child may give us some clue. Of course, diagnosing it at birth means we have that opportunity of treating these girls with growth hormone earlier. Unlike now, what we see in the clinical scenarios, they coming to us at 12 to 13 years of age because they didn't have puberty and where we are already very late. So that is one advantage, that the height would be better because we would treat earlier.
So newborns always look out for the dorsum pedal edema, which usually maybe we overlook it as being normal, physiological. But when you have a girl child and a right-sided heart defect and some little dysmorphism, you are probably hit and you can go in and do a karyotyping right away.
Yes, there we all know that we do a karyotype for diagnosing monosomy X. But for mild grades of mosaicism, a karyotype which counts only counts only 5 cells. So that where we may miss a monosomy mosaicism there. So we usually write to the lab to do an extended karyotype to count at least 50 cells or 30 cells.
So you may miss a mosaic type of Turner syndrome if you're just doing a conventional 5-cell to ask for counting 50.
And also we say that a poor man's karyotype is an FSH level. So in a girl with delayed puberty, short stature, not affording, if I do an FSH and it comes high and she has some Turner stigmata, one of which is short stature, that is also something that can give us some clue and a quick clue.
Okay. So identify this growth chart.
So can I just, ma'am, describe it for the audience that there is something which is wrong at the 70th line. No, so the 70th line is red, that means something about 70th is wrong.
That is kind of a reference point. The 70th which is shown red is kind of a reference line or a range for this abnormality. Waist circumference, okay. So this is the Indian waist circumference chart. Internationally, the waist circumference greater than 90th centile on age and sex matched criteria is used as a cutoff for metabolic syndromes. But for Indian population, a cutoff value of 70th percentile for waist circumference is recommended to screen children with obesity and overweight for the metabolic syndrome. So, does this really have any advantage over the very traditional and conventional BMI that we all usually do for obesity?
Yes,
Is it really important to look at the waist circumference chart and maintain it?
Right. So we've already discussed this, that waist circumference gives us an idea of the visceral adiposity, which is the risk factor for metabolic syndrome, because we know of healthy, metabolically healthy obese and a metabolically unhealthy obese phenotype. So the unhealthy obese phenotype would have a greater waist circumference at a lower cutoff because we are from the Asian ethnicity. And also this is Indian data. This is available on the IAP website. So maybe we should start using this now, now that we already use the BMI charts. Now this is step 2.
So Dr. Abhishek earlier really very beautifully explained us that how the distribution of adiposity is also very important to predict the metabolic syndrome later on, not just looking at the obesity
BMI
part. So in this case, all of us should start even using waist circumference charts in children who come with us with overweight and obesity.
Yes.
So what is the correct sequence of puberty in a girl? A, thelarchy, pubarchy, peak height velocity, menarche. Second is pubarchy, followed by thelarchy, peak height velocity, menarche. Third, peak height velocity, followed by thelarchy, followed by pubarchy and menarche. Or thelarchy with peak height velocity, followed by a pubarchy and finally a menarche. Okay, great. So everybody correct. The option is A, thelarchy, followed by pubarchy, followed by a peak height velocity and then the onset of menarche. In boys, it is gonadarchy, followed by pubarchy, followed by a increase in the penile size or penile enlargement, with the peak height velocity being the last. And therefore, boys have a little more window to grow on in their height scores as compared to girls. A practical question here, as far as general pediatricians are concerned, that many times the parents come and tell us, the child has already started developing breasts, it's an early thelarchy. Can we predict when is she going to get her menses? So is it possible to predict menarche chronologically by the stage of puberty? Is it possible?
Right. So if it's not a disease, if it's a normal progression of puberty, so the sequence and the tempo, these are two things we have to look at. So we have the sequence here, which is thelarchy, breast development first. That is why IAP advises looking for breast development between 6 to 8 years of age. Of course, after consent and proper consent taken by the from the parent. Then every stage the child is in for around 6 months. So if I calculate that way, after thelarchy, menses would occur 2.5 to 3 years after onset of puberty.
Okay.
So, yes.
So in between two of these 6 months period, you can say.
Yes.
In
So
a normal
actually,
child.
it's between SMR stage 1, 2, 3, 4, 5, which is a combination of these. Pubarchy is just the beginning of pubic hair. And here also we could highlight that peak height velocity in a girl occurs in the earlier half of puberty. Like that is why we see girls being taller in 5th, 6th. And then the boys taking over in 8th, 9th, because they have their peak height velocity in the second half of their puberty.
Right.
And one more point to highlight here is in boys, the gonadarchy may go missed because we may not look at the gonad size, and that would be the onset of puberty.
Right. So I'm sure many of us sitting here are also experiencing a little increase in the incidence of precocious puberty. So children coming in with early sexual maturation symptoms and all. So this becomes an important thing to know and kind of guide or counsel the parents for further progress. Okay, so identify the abnormalities and the condition in this 7-year-old. So first of all, the abnormalities. It's a 7-year-old girl.
They've already said it.
Somebody said? McCune-Albright syndrome, okay. So the, So the features are the typical rash that you see, the cafe au lait rash, which has these typical borders. They call it the coast of Maine border because they're all ragged borders. It's not like the coast of California, which is very smooth and outlined, and they never cross the midline. It's always restricted to the midline. And then you have these orthopedic problems because of the fibrous dysplasia, polyostotic fibrous dysplasia. And typically in children affecting in terms of their spinal abnormalities and scoliosis, they come with a lot of bone pains. They have frequent fractures. And one common thing that is also seen radiologically, femur is affected because being the largest bone, you get that typical shepherd's crook curve. And finally, of course, the endocrine part of this syndrome, which Dr. Rachna can tell us what we need to know as general pediatricians.
So it is because of constitutive activation of the GNAS receptor, and many polyendocrinopathies may happen. The point to highlight here is the precocious puberty here is peripheral. So it will not be sequential. It will not necessarily be breast development followed by menarche. They may have just some breast development and then have menarche within a period of 6 months. So not sequential and a very fast tempo, because the estrogen being produced by the ovarian cyst, which is constitutively active, is not going to follow anything coming from the brain, FSH, LH. So the tempo may be very fast.
Right.
So that is characteristic of peripheral precocity.
Right, right. Okay, so moving on to the next, a newly diagnosed adolescent with type 1 diabetes mellitus was started on insulin therapy. The family was using syringe and vial for administering the regular insulin as against an insulin pen. What would you like to point out regarding the use of the syringe and vial in such patients? Sorry?
Dosage might not always be adequately given and infections more.
You don't say, Dr. Jaiti. Okay, so Dr. Rachna, please explain us. So the correct thing is you will always match the syringe with the strength of insulin in the vial that is being used for this child. Please elaborate.
Yeah, so actually only in India we have regular insulin coming in 2 strengths. One is a 40 unit per ml and a 100 unit per ml vial also is available. So what makes things difficult is the syringe that we have to use with it. So the insulin syringe here shown in the red, the one which is red, and the tuberculin syringe or the 100 unit syringe, both are 1 ml syringes. But the red syringe has 40 unit markings and the 100 unit syringe has 100 markings. So if I'm going to use the wrong syringe, I'm going to give the wrong number of units. So it's always important to match the strength of the insulin with the syringe that is being used. So for example, if I use 100, so one line of the 100 unit syringe is 0.01 ml, but one line of the 40 unit syringe is 0.025, 2.5 times greater. So we have to be mindful of that.
By mistake, if we interchange, we are really going to cause problems.
However, this problem is now decreasing because the other insulins are mostly
insulin
100
pens
units.
and all. But this is one thing that we need to keep in mind when you're treating patients who use this method. Okay, so we have a 16-year-old girl, previously healthy, brought with acute onset lethargy. In the casualty, her sugars were seen as 36 milligram per deciliter. Critical samples showed an insulin level of 1000 milliunit international units per liter, a C-peptide of 0.03. What is the likely diagnosis? Excellent. Who is this? Endocrinology. Okay, so the differentials were insulinoma, exogenous insulin administration. He's given the answer even before looking at the differentials. Congenital hyperinsulinism and type 2 diabetes. So this did turn out to be an exogenous insulin self-administration. The grandmother was on insulin for type 2 diabetes. The child had some problems, psychiatric problems, and she self-administered. She was severely depressed, and she came with this presentation in the casualty. My question and help from Dr. Rachna, how do we interpret these reports? And is it really mandatory to include a C-peptide as a routine in the critical sample when such cases come to you? So sugars are low.
Yes, so this is with an HGT of 36. Insulin has to be undetectable. However, it's extremely high. It has to be less than, not detectable by the lab range. The C-peptide here is very low. It is the normal ranges are above 0.5. It's 0.5 to around 2. So C-peptide is something that is removed from the precursor molecule of insulin. So it is produced with insulin in equimolar concentration. So if I have a high insulin and a low C-peptide, that means there's exogenous insulin coming into picture. So it does play a role in critical sample collection when we collect the critical sample, especially in this 16-year-old adolescent girl who was previously healthy. So that should ring a bell. And that is why, that is how we could diagnose this case, that because the C-peptide was low.
So they both should be proportionately high if we are looking at a true
endogenous insulin
pathology. If it is exogenous, then it's usually, this should be
However,
kept in
if
mind.
she's
That
ma'am abused sulfonylureas, then she would have high insulin and high C-peptide
High
because
C-peptide
that
as
would
well.
be endogenous insulin
Right.
secretagogue.
Sulfonylureas
still
would
be-
work by endogenously doing it.
Increasing the insulin, yes.
Sure. So identify this condition. Of course, this is very spot on.
Maybe from that.
Goiter. And the answer is goiter, but is this goiter always a hypofunctioning or a hyperfunctioning as we would take it clinically?
So we'll go quickly here. It could be any of the three. We have already discussed this in the first case. Important,
Yes.
but to look for when we are looking at a goiter is to examine, palpate for a nodule, the feel of the goiter, and also lymph nodes.
Okay, great. So, of course, everybody knows this is a case of trisomy 21 or Downs. The question is not that. What is the cause of short stature in children with trisomy 21? Is it hypothyroidism? Is it a chromosomal defect? Is it growth hormone deficiency? Or is it poor nutrition? Oh, great. So yes, the answer is the short stature in children with Downs is usually the chromosomal defect. And not like they conventionally believe that associated endocrine problems and all, although they are at a higher risk. In that case, Dr. Rachna, that if you have a child of Downs that we are following, and I want to really rely on my growth charts to pick up any kind of an endocrine problem setting in, or any kind of a chronic organ or systemic disease, they have a high incidence of celiacs. How are my growth chart, conventional growth chart, going to help me?
Okay, so the fact that the chromosomal defect inherently is responsible for the short stature seen in these children warrants that there be syndrome-specific charts. And on the syndrome-specific charts where they're supposed to follow their line according to their syndrome, if they falter, that would give us some indication of a secondary pathology setting in that child, if that makes sense.
So for children of Downs that we are following, use syndrome-specific growth charts that will help us to pick up any problems happening beyond their normal short stature. So because we are focusing, IAP Mumbai has always in all the conferences said, please use growth charts. And there has been a little apathy in most of us with our busy OPDs to adhering to even normal IAP growth charts. This is something different. So identify this growth chart. Okay, so this is a growth velocity chart, and Dr. Rachna can tell us how do we map, how do we chart, and how do we really interpret this.
Yes, so I would like to highlight the left side, the first picture, which tells us that the growth velocity is highest in the first year, then the second, then the third, and before puberty, it kind of plateaus to 5 centimeter per year. And then there is a spike again during puberty, so that is why the shape of the chart is like that. And if we were to use this chart regularly, we can detect subtle degrees of growth deceleration a little earlier. So here the cutoff for diagnosing someone as having low growth velocity is the 25th centile line. And also what we do is we measure height on 2 occasions. They can't be 2 occasions which are a week apart. They have to be 6 months or ideally a year apart, and then plot between the 2 ages. In fact, even if we don't use the chart for calculating growth velocity in the OPD also, it's a good practice to see what the height was last year, subtract it, and then get a number. That kind of tells us that, okay, in this year she grew 4 centimeter, the next 6, and then 8.
So any practical implications for use for us in our routine practice? When should we use growth velocity chart specifically?
So actually it's, even in endocrine practice, we've just started to use it, we don't use it.
So we are safe, no problem. We can start adhering to our routine charts. Okay, so this is a MRI brain with special emphasis on the hypothalamic region. It showed an iso-intense SOL arising from the tuber. Very good.
I think we are out of chocolates
very
now.
good. So both the questions are answered. So of course this is a hypothalamic hamartoma, which is a disorganized collection of the glia and neurons arising from the tuber cinereum at the base of the third ventricle at the hypothalamus. So what is the classic clinical triad of these children?
Yes, so like we all know, there will be precocious puberty, and that precocious puberty will be central. So that will be thelar followed by puberc, etc. And the other 2 features are gelastic seizures, which mean they may not always have, and sometimes also developmental delay. Yes, and that can happen very early. They usually.
So very simple ones. So this is a Prader's orchidometer. And Dr. Rachna will tell us how to use this. Okay, Dr. Sushma, tell us how to use this. Practical use in OPD of a Prader's orchidometer and interpretation.
So
Rachna will tell us.
Importance is because we saw that gonadarchy was the first sign in a boy of the start of puberty. So we as endocrinologists always check the puberty, the testicular size. The size 1, 2, 3 is pre-pubertal. We define onset of puberty in boy as a testicular volume of 4 ml or more. So from 4, so the colors are there for us to understand it better. The important point here I would like to point out is it's the volume that we are measuring. It's not the length. It's not 3 centimeter or 4 centimeter. The feel and the volume of the testes that we feel in between the two fingers, and then compare the size with the ellipsoid.
So how do we use this? Practically, how do we use this?
Yes, so after taking consent and after explaining to the child that it will be painless and why we are doing the examination to see if he's pubertal, we hold the testes and then we compare the size of
parallel
to it.
Right.
Yes.
Okay.
And we make sure that we don't take into consideration the vas and the epididymis which may be there, and the testes alone.
Okay. So this is a 17-year-old boy with short stature and delayed puberty. He had undergone a device closure for ASD in childhood. What is the likely diagnosis? Okay, so if I can give you one pictorial clue here, can you look at the ears? Something else that, so now you have a constellation of a heart, a growth. Sorry? No, madam.
You're definitely.
So this child, no, so this is the charge syndrome. Of course, the 4 were present out of 6. C is coloboma of the iris. The eyes are closed,
Coloboma,
but yes, you may be.
is-
Heart defect, atresia of the coena, retardation of growth and development, genitourinary defect, and ear malformation
This is
also.
first heart
And
syndrome. That is not a first heart syndrome. No?
charge is usually a constellation of more than 4 or 5 of these 6. And I would like to ask Rachna madam that what is the cause of retardation of growth and development in these children of charge syndrome?
So the delayed puberty in these syndromes, so some forms of IHH are syndromic. One of them is charge, and that can lead to delayed puberty, and that is why this child presented with delayed puberty. And the short stature is a part of the syndrome itself, actually. And
No, so that's a
exaggerated by
growth
the
hormone
delay.
problem? The short
So not usually the growth hormone problem, but we may test for it, but it's not like Chart syndrome is classically associated with growth hormone deficiency. That is not the case.
So usually with all of these features, the life expectancy is quite limited in these children. They barely pull on to 5-10 years with the best this thing, 70% survival rates beyond. But the oldest living individual of charge with all these 6 is a 40-year-old in Japan. So just like an interesting fact. Okay, this is a 6-year-old boy. Complains of hypoglycemic seizures, history of hypoglycemic seizures, and recent CAH, recent difficulty in walking. Recent difficulty in walking. A CAH would not have that probably.
So there is Addisonian pigmentation that you have diagnosed.
Yes, so this is an adrenoleukodystrophy, which we all know is an X-linked disorder. And there is a neuroregression primarily of the motor milestones because it's a white matter disease. It's a leukodystrophy. And you have associated Addison's disease. So hyperpigmentation, that was very evident in this child. They are more likely to go into emergencies, medical emergencies with an adrenal crisis. White matter, as we know, there is a neuroregression of the motor milestones. And Dr. Rachna, so for practicing pediatricians, what important thing that we need to remember about these ALDs, not as uncommon or as rare as thought of, from the endocrine point of view?
So one is, of course, that there are only 2 emergencies in pediatric endocrinology. One is DKA, which is commonly recognized now, I think even in smaller nursing homes as well. But the second is adrenal crisis, which may go undiagnosed. and giving if we can diagnose a hyperpigmented child coming to the casualty with hypoglycemia, collect the critical sample quickly and give a hydrocort stress injection even without calling the pediatric endocrinologist, that may be life-saving. That is one. And the second is, of course, hematopoietic stem cell transplant has a role to play if the CNS changes have not happened. So they may come to us first for adrenal insufficiency, and we do an MRI is done, and there's a multidisciplinary team involved where a decision is made about hematopoietic stem cell if there are no CNS changes, because they are not reversible.
So a child who comes to us hyperpigmented in the casualty with a hypoglycemic without even a neuroregression set in, may be in one of these medical emergencies of Addisonian crisis, and it is worth giving a shot of hydrocort and kindly, contributing to saving, really preventing a morbid.
Maybe the critical sample, because we will otherwise miss the diagnosis.
And then after diagnosis and proof and sending to our endocrine experts, this will be the time to offer a definitive cure for this person, even before a CNS has set in. So a 16-year-old child complained of milky breast discharge since 2 weeks. She had a tummy upset 2 weeks prior, and when she came, these are the levels done. Serum prolactin was 80 for a range of 15 to 64. So what could be the likely cause of galactoria, and what makes you say this is drug induced? Okay, so even before we go to the answer, would the level of prolactin per se give us a clue to whether this is like something pathological related to?
So this could, the prolactinoma would have higher levels, of course, but an 80 cannot be a prolactinoma is not the case. But yes, in this scenario, where only 2 weeks history and some tummy upset during the same time, maybe we would think of something else. Mild elevation of prolactin levels actually are usually not prolactinomas.
Okay, so this was indeed a drug-induced. The child was treated with rabeprazole and levosulpiride. The other drugs which can also do this. So high prolactin levels are OCP is used, risperidone, antipsychotics, antidepressants, and you just stop the treatment and repeat after 2 to 4 weeks, they are already normal. So as she rightly pointed out, that maybe prolactinomas and other pathologies would really have higher levels, and this window may be seen because of stress, decreased sleep. So would it also matter when this sample was drawn? Just that we are looking at mildly elevated prolactin levels are also seen in decreased sleep, increased exertion. I mean, which teenager doesn't have all or one of these three these days? Yes. So can you tell us what is the ideal time of collecting sample for prolactin, or for that matter, any hormone in routine practice? Which is the ideal way? What is the ideal time?
Right. So 2-3 points there. One is that the anterior pituitary hormones that we check, for example, for growth hormone testing, when we do clonidine stimulation test, or for cortisol, time is very important. We do an 8 AM cortisol. For the other hormones like TFT, prolactin, etc., of course, it's not very mandatory, but morning sample collections are preferred. That is one. Fasting is again not mandatory for, say, a TFT or prolactin, but again preferred. And home collection, especially nowadays, people get samples collected at home and then the 8 AM cortisol comes low. That happens because these molecules are very heat labile and they need to be processed, or the sample needs to be at least processed before it is being tested. So no home collection, preferably morning, fasting. Those are the general guidelines we follow, but we are more specific for some hormones.
So that's a very important takeaway for all of us, assuming that in office practice we are not going to come to an endocrine emergency to send the level then and there. We can probably make it elective by ordering a morning sample, preferably a fasting if it's an older child, preferably no home collection, go to the lab.
Yes.
And if the child is a known case of any disorder and on any kind of hormonal supplements or treatments, it always has to be taken without taking that supplement. Am I correct?
Yes, like for thyroxine, we usually advise that like we discussed in the morning. Otherwise, the FT4 may come slightly high.
Absolutely. A 10-year-old with chronic eczema and severe hair fall was ordered a TFT, and this is what the TFT showed. A T3 which is increased, a T4 which is okay, and a TSH which is less than 0.01. So anything that comes in mind?
The T4 is increased, yeah. So we T3, T4 both are increased and the
Graves'
TSH is
disease,
suppressed.
SA interference, sick euthyroid syndrome, central hypothyroidism. Dr. Rachna, will you interpret these reports for
So
us?
I think here it would be a good idea to discuss why it's one and not the other.
Exactly.
So we have high T3, T4 levels and suppressed TSH levels. Yeah, it could be Graves' disease or it could be assay interference, especially in this child who had severe hair fall. She may be on some supplements that may cause assay interference. However, it cannot be sick euthyroid or central hypothyroidism. I'd like to elaborate. Firstly, sick euthyroid is characterized by initially a low T3, then a low T4, and then TSH comes down. So the classical picture is of low T3, low T4, and low TSH. That is sick euthyroid. And during recovery, first the TSH rises, then the T4, then the T3. Central hypothyroidism is characterized by a low total T4, low free T4 value, irrespective of the TSH. So a very low TSH doesn't mean that the pituitary is not producing TSH, because in fact a low FT4 is what we use for diagnosis of central hypothyroidism. The TSH may be low, normal, or even slightly elevated. Because in the normal scenario, when my thyroid is not working, even very small changes in thyroid function lead to a exponential rise in TSH. And by the time the FT4 really drops, the TSH is in hundreds.
Usually,
so, and in central, the picture is different. For a very low FT4, the TSH may only be 5. So that's an inappropriately normal TSH. That is not how usually the TSH responds to a dropping T4 level. So it can't be central hypothyroidism.
So should we take this that free T3 and free T4 should also be a part of screening as general pediatricians in office practice in certain scenarios? So would you recommend this as a part of TFT? And if yes, both or either or? Which one?
So I like in metro cities where we have FT3, free T4 values available, doing a free T4 is preferable because 99% of the hormone is bound, and then what affects the proteins also affects total T4 levels, like a systemic illness, etc. So where possible, doing a free
Economically,
T4
is it viable, or are they
I
really
think it is viable now, and also in children there's no role of only doing a TSH. We should do a complete thyroid profile.
Right. So this turned out to be an assay interference by biotin supplements that mimicked a hypothyroidism on a thyroid function report. Of course, she was stopped on biotin and the test was repeated after 4 to 6 weeks. This is a 16-year-old with primary amenorrhea. She has a staging of B5A1P1, coincidentally detected palpable gonads. What is the diagnosis? Very good. So this is complete androgen insensitivity syndrome. And Dr. Rachna can tell us about this a little bit.
So just to compare this with the case presented by Dr. Akansha, where she was discussing Mullerian agenesis. So both CAIS and Mullerian agenesis would have breast development, and CAIS would not have pubic hair and axillary hair, because here this is a 46XY DSD where the androgen receptor is mutated. So the testosterone levels are high, but the receptor is insensitive. So all the testosterone gets converted to estradiol. And so there is B5 breast staging, no A, no P, no axillary or pubic hair. And because it was a receptor mutation, that gonad which is found as testes, it's working normally. It is an end organ receptor resistant, so it's producing AMH normally in utero also. So the anti-Mullerian hormone is going to regress the Mullerian structures inside. So there's not going to be any uterus inside. So of course that is why she has primary amenorrhea, and we look for, we have the gonads also.
So they all have a 46XY DSD, and as she said, and explained the other parts of it. Okay, no, sorry. So there is a, the last slide was left. I don't know how this happened. So how do I do that? No, it was the whole thing was coming when I. At least the Acha. So okay. Anyways, there is some technical problem. The last slide was about a child with typical rickets. So related to that, do we do a PTH levels in all these children that we encounter with rickets, barring of course the physiological vitamin D dependent? And how do we interpret? And two main categories, the calcipenics versus the phosphominics. How would you?
Okay, so when we see a child with rickets, we are talking here about the non-nutritional forms of rickets. Once vitamin D was sufficient, and now we are doing the tests again. With a normal vitamin D, if I have a low calcium, I have to think of other causes of calcipenic rickets. So then the next thing to do would be a 1,25 dihydroxy vitamin D. If that is low, then that would mean that there's a conversion defect. If that is high, that would mean that there is a receptor defect. So that is VDDR type 1 and VDDR type 2. So the criteria there is a low calcium. The phosphorus will be low even in calcipenic rickets. The ALP will be very high. So that is the calcipenic limb. The phosphopenic rickets limb is where the phosphorus wasting, the wasting of phosphorus, renal phosphorus wasting is the main reason. And there, because phosphorus is adequate in diet, so that is not usually the cause. And we have X-linked hypophosphatemic rickets, etc. Here I would just like to highlight that the role of PTH. Actually, vitamin D deficiency, the PTH is going to be high, trying to compensate and ensure that calcium levels are normal. The role of PTH is more important in the evaluation of hypocalcemia, where I have a low calcium and a low PTH, that is hypoparathyroidism. So that is something not related to rickets per se, but then low calcium with low PTH or a low calcium with a normal PTH. For a low calcium, the PTH should be higher. And inappropriately normal PTH with a low calcium is also diagnostic of hypoparathyroidism. And in the setting of a normal calcium, actually the PTH is not interpretable. Like if I have a calcium of 9, the PTH normal is not helping me diagnose anything.
Sure. Thank you so much, and thank you, Dr. Rachna, for those very important takeaways for all of us.
Thank you, Dr. Nehal. May I request Dr. Sameer Dalwai to felicitate Dr. Nehal.
Dr. Gewawat sir, special guest. Sir, please, felicitate. IAP. Most regular IAP Mumbai attendant. IAP. हम दोनों भाई ऑनर रियल मैडम को देंगे मैडम
So thank you everyone for your patient hearing. Apologies for running little late on this session. The lunch is ready on this entire session. And I would like to thank Dr. Abhishek Kulkarni for conceptualizing this CME. I would like to thank Alchem for being the scientific partners for this session and always proving towards academic excellence. Thank you all the delegates who came here in huge numbers, and also thank you to the delegates who are attending online and the faculty who gave us such insightful take-home messages today on important topics. And also thank the audiovisual and Novotel for their hospitality. Thank you.